much, and thank you to the NYSOMS Education Committee for allowing me, ROC New York, so I could be speaking today. This particular topic comes out of last year because there was a lot of presentations that were talking about cranial manipulation, and one of the comments was that, I learned it all these years ago. I wish I learned it well. I don't, it's hard to do. I don't remember how to do it. And we've been sensitive to that over the years. And it was actually at Kansas City University, and I had a whole bunch of fellows, and they didn't have that many faculty. And I said to my fellows, who were supposed to be table training for cranial, how many of you have done a 40-hour course? No one had done one. How many of you have actually felt the cranial mechanism, felt the primary respiratory motion to the fellows? And the fellows said, I think one of them said, I think I have. So, I realized that at that point that we really had to shift away a little bit, at least in that setting, where you're doing introductory cranial education, to something that the students could take home and actually use. So we went to more of a myofascial teaching approach in the cranium, and what we found out was that the fascia follows the spinobasilar symphysis mechanics exactly. Because all you're looking at is, as Warren said yesterday, really vectors of treatment applied to the head, applied to the bones, applied to the SBS, but it's also applied to the fascia. And so that's kind of where this came from, and I presented a few times. This is actually, last year, the Cranial Academy, Osteopathic Cranial Academy, went to Monterey, California, and that's where we had our conference, our yearly conference, and Dr. Sutherland lived out there. And this is, I took a picture by his grave. There's deers running around the cemetery, and I thought it was just like really cool. And then right across the street, because there's a street and it's right on the coast of the cemetery, is where Dr. Sutherland, had that picture taken. And I kind of did a similar picture because I was like, wow, I feel like I'm connected after all these years. And that's one of the great things about osteopathy. We're connected to these fantastic mentors. Not just your mentors, but even their mentors. And it's neat to be able to kind of trace that lineage. I don't know if you guys have ever done that. It's really cool. I have nothing to disclose. I have no conflicts of interest regarding the contents of this presentation. There's learning objectives. Basically, I want you guys to learn a little bit of cranial manipulation, indications, contraindications, and all that stuff. Here's the first thing, the first learning objective: identify the anatomical and clinical indications and contraindications for myofascial OCMM. And this is really osteopathic cranial manipulative medicine's indications and contraindications. Let's see if this works. I'm going to be excited if it works because it is so cool. Let's see here, this way. Go down here.
Treating diseases that manifest strongly in that division of the body. Then examine and treat the neck, chest, abdomen, and pelvis. Begin with the head and finishing with the sacrum.
I don't care what you guys think about AI. To me, I am so humbled and moved by that. I'm going to play it again because I could watch it again and again all day. And then I'm going to ask you guys who you think that the voice is that I use for Dr. Stills, because the recording of the voice of Dr. Still was lost by the AOA. All right, here we go. Can you put the sound back on again?
Of the body. Then examine and treat the neck, chest, abdomen, and pelvis.
Whoopsie. We're going to go back because I want you to hear the whole thing.
Begin with the brain or head in treating diseases that manifest strongly in that division of the body. Then examine and treat the neck, chest, abdomen, and pelvis. Begin with the head and finishing with the sacrum.
Okay, which celebrity voice did I use for Dr. Still? Anyone? Anyone hazard a guess? Close. I could see where you'd think that. Now that I'm like thinking about it. Anyone else? What? Burt Reynolds. You want to hear it again? One more time? All right, one more time.
Begin with the brain or head in treating diseases that manifest strongly in that division of the body. Then examine and treat the neck, chest, abdomen, and pelvis. Begin with the head and finishing with the sacrum.
Dr. Still reaching out over 100 years to tell you to begin with the head. And that's where he began all of his treatments, pretty much, unless it was like something in the foot. Which, we talk about orders of sequences of treatments, and we do pelvis, we do all this stuff. Dr. Still started with the head, at least for everything that had to do with like diaphragm up. He would start from the head. There's a special technique that, if you come to the session later, I'll show you that technique. But here is Dr. Sutherland, and with a disarticulated Duchenne skull, and ROC-NY is a system of diagnosis and treatment developed by an osteopathic physician, Dr. Sutherland, utilizing the primary respiratory mechanism and balanced membranous tensions. He was an early student of Dr. Still and a graduate of the ASO in 1899. Very cool. I probably should have had him, but there's a video I made for our students that has this kid on a swing, a rope swing, developing a headache. And I'm sure you guys all remember this from Dr. Still's autobiography, and I portray him, this is kind of like Dr. Still, and it's got a log cabin behind it. But indications for myofascial OCMM, or for cranial manipulation in general, include headache, cranial neuropathy, Bell's palsy, trigeminal neuralgia, colic, orofacial pain, otitis media, sinusitis, TMJ, vertigo, feeding difficulties in infants and in adult neurologic cases, like a post-stroke patient. Plagiocephaly, torticollis, tinnitus, post-concussive syndromes, traumatic brain injuries, basically any somatic dysfunction involving the head. And you just heard Dr. Still say that everything, like basically from the diaphragm above, start with the head. Smart guy, that Dr. Still. Contraindications, absolute, may include but not limited to occult intracranial bleed, skull fracture, acute cerebrovascular accident, and relative include coagulopathy and lesions, increased intracranial pressure. HPP is not a contraindication because it's a very gentle technique. So the rest of the learning objectives, now we're going to get into the different techniques, which I absolutely love, because you guys are like, I didn't know this was going to be a lab, but it's going to be both, and the people you're going to treat is sitting right in your seat, because it's going to be, you're going to treat yourself and you'll learn the principles, and then you can apply it to others. And the nice thing is you can observe how much force it is because you're doing it to yourself. Dr. Still beveled like the gills of a fish, indicating a primary respiratory mechanism for mobility. I was in this place called Oregon, and I started a school there, and just flipping through the channels, I saw this show called Walking with Dinosaurs. And they were talking about the pterion in a dinosaur, and the bevel in it indicated, and the forces from them walking around, the motion at the joint was 3 to 4 inches. Now, we all know that if you immobilize a joint, most often, not only does the joint ossify, you lose the bevels, you lose the architecture. And I used to have this fancy skull that actually had a fused sagittal suture, and it was like the whole architecture of the skull changed, but it was like really cool. But you have to keep that in mind. Again, we're not going to go hugely into that, but I'm kind of just briefly like breezing through some of the concepts of cranial, because I have a point to it. 5 components of the primary respiratory mechanism: inherent motility of the central nervous system, mobility of the intracranial and intraspinal membranes, the reciprocal tension membrane. We'll talk a little bit about that. Fluctuation of the CSF, mobility of the cranial bones, and involuntary mobility of the sacrum between the ilia, which is great. But I learned cranial, my basic cranial course was from Fred Mitchell Jr. Fred was a master of, muscle energy, right? The Mitchell's muscle energy model, all that kind of stuff. And so, he said, the sixth component of this is, because there's actually 6 components of the primary respiratory. He said it's the muscles. And, I thought that was fascinating. And then Dr. Robert Ward was one of my mentors. And Dr. Ward, he would say that, someday you have to create a myofascial course on OCMM. And his, so he never did. And I had Dr. Ward come and present at Kirksville in his 90s. I didn't ask him about it. I hadn't even thought about it then. But, years later, completing, in my mind, I'm completing some of my mentors' work by creating myofascial courses on treating the cranium. And, right now, at ATSU, Kansas City University, the way we kind of introduce cranial at Truro, Montana, is through the myofascial system. So because students can feel it real easy, and then when they feel it and they recognize it can do stuff, they will apply it. And the other thing is, we've had way less adverse events from students working with the myofascial system because we teach them that in the first year. We teach them that right away. And so then we use it throughout. So that ability is developed in them. Trying to move cranial bones is a little harder because it doesn't take much force, but it's hard to teach that. And in Western, we did a 40-hour course. And every year they look at removing the 40-hour course because it's a big chunk of the curriculum. But the student feedback is they love it. And because their skills, they sit there and they say, my skills, my ability to feel things increases hugely. So if you haven't taken a 40-hour course in a while, I'm going to encourage you to do so. The Cranial Academy offers them. There's a hybrid course, so it's not like all the time now, a full week. You do part of it online, and you go for the course in a weekend, and you get a 40-hour course. It's kind of cool. Fluids, diaphragms, lymphatics, and primary respiratory mechanism. All those little colored circles that are in the skeleton are places where there's diaphragms that affect fluid flow. Easy to understand, right? You have the diaphragm, we have the lumbosacral junction, we have the cervical thoracic junction, and then we also have the craniocervical junction, okay? Main places. So here's the SBS. I'm going to take out the temporal bone, and I'm going to take out, or actually I'm highlighting the sphenoid for you, okay? And now I'm going, the fancy bat wing bone, you guys see that's really cool. If you're sitting in the back and you want to come closer, you can. And then you'll also highlight the occiput, and when they come together, they call it the sphenobasilar symphysis, the sphenobasilar junction. And the reason why I'm doing that is because now we're going to look at all these muscles and how they connect to the head. And, it's simple stuff. It's anatomy. It's osteopathy. It's applied anatomy is what I tell my students I teach, in health and disease. So, I added in the oral pharynx and the trachea because that attaches in there. And actually, the technique that Still always did on all of his patients to address the head, it's cool because it actually involves the jaw and affects all that stuff. So, it's a neat one to learn. And then you can kind of get a feeling as we add in more things. And, here we have the suboccipital muscles, more spinal muscles. longissimus cervicis, semispinalis. Again, more muscle, just as it's adding it in. You know, think of all that. Those are forces that are going to affect the head. If you have a tight muscle on your neck, on one side, you know, it's like the bones move. You know, this is an anchor, they're anchored. What's going to be the stronger anchor, your head or the spine? What happens at the head? If it's tight over here, it's got to be tight over here to maintain balance. There has to be some kind of compensatory mechanism, right? We're going to add in more. Now we see the scalp. We've got frontalis, occipitalis, the temporalis, platysma, all the, the traps, all these muscles attached to the head and play a role in cranial dysfunction. And, but the thing is, we haven't taught it that way. We know that that's what happens for those of us who do a lot of manipulation, that we're affecting it, but we don't necessarily think of it in that respect. So, that was a word. Uh-oh. There was timings. All right. So I'm going to teach you guys real quick the screen for that I teach the students, which is a TART screen, right? We do TART for everything. So go ahead and put your hands, find your mastoid processes, right? Right behind your ear. And you're going to trace posteriorly from your mastoid processes to the occipitomastoid suture. Now I want you to just take a second on the mastoid, unfortunately my right hand is actually sore. And is anyone feeling the tenderness on one of the other sides of your occipitomastoid suture? It's tight. And sometimes you'll feel, right now I can tell there's more tension on that side too. And as I move superiorly to the asterion, I don't have it, so so it's bilateral, and then I'm going to sit there, I'm going to go and trace it along the, I want to say sigmoid, but I know it begins with an S, towards the, anyone? Or what is that? What is this joint here? Lambda, right. So lambda, if you do lambda, and then now you're going to go through your sagittal suture, and you're going to go, and there might be a tenderness, and then you're going to go to bregma, and then you're going to go laterally from that down the frontal suture to the pterion, and then you can feel your TMJ right here in front of your ear, in front of your tragus of your ear. You can put your finger in here if you want to, but right here you can feel if it's tender at all. If there's any swelling on the right side again. And then we're going to do muscles. So we can go masseter, temporal. We can go and do the frontalis muscle. We can do the mastoid over the mastoid muscles over the mastoid. And we do occipitalis. Okay, and occipitalis is sore too. All right, and I can feel the difference in tension. I don't know if any of you guys have felt that on you, but that's a quick exam, right? You can see that you can just go zoom, 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 and be done with it pretty quickly. So that's like something that I'm hoping you'll add to your armamentarium. This is, I wanted to talk a little bit about HRV stress, OMT, and suboccipital cell treatment. We talked a little bit about burnout yesterday, right? A lot of our students are burnt out. Probably this, close to 40% is what Dr. Stewart had said yesterday. It might be higher than that. Residencies kind of start to reach up into the 50s and 60%. As a physician, we'll probably stay around there, unfortunately. This is a technique you can teach, to your patients. It's a technique you can do on yourself, so you're going to do it on yourself. And it's a suboccipital myofascial release that addresses, the vagal nerve. We're talking about, a lot of us talking about vagal nerve resets. This is like a vagal reset that you can teach. It's, pure osteopathic medicine. And how powerful is osteopathic medicine? Well, see that fancy diagram that has the red in it and HRV? You know that HRV, you can monitor HRV and it can tell you a lot about your health. It tells you, like, how high your stress level is, what your energy level is, how healthy you are. So all these are questions. They've looked at this like hundreds of thousands of patients now. The data is really amazing. And actually, in the JOA, this past edition or coming edition, online, it's actually, they talk about HRV and how OMG can help with it. So there I was, minding my own business, that this is like an HRV monitor I got for myself. And the reason why is that I was having some ones of tachycardia that were abnormal, and I hit at different points in my life when I was probably burned out. One time, I was working at a school, 9:30 at night, working on a lecture, and I realized my heart was racing, and I said, well, what's my heart rate? Maybe I'm imagining this. And I checked, sitting at a desk, just typing a lecture, my heart rate was 140 beats a minute. That's not what it's supposed to be. I had to take some breaths, relax, and do a reset just from breathing, which helped. But, I was running around on stage teaching, and all of a sudden it's like, again, I felt like my heart was racing, did the cough birth thing, like not having, so I looked at like around 150 beats a minute. And I'm like, that's not good. And I got checked out, when I had the first run, cardio, they said, oh, you're fine cardiologically, it's stress. And maybe you're having anxiety attacks and all. That's weird. So, because I didn't feel like there was anxiety. But, there's different stages of burnout, and when you start to get into the later stages, you get physical manifestations, heart rate, anxiety type things, depression, illnesses. So I went ahead and, said, I've heard about this HRV thing, so I got a little HRV monitor for a watch, and sure enough, that's what I saw when I checked it. And on a really good day. Oh, sorry. On a really good day, it would look like this, yellow. And I'm like, wow, they advertise that there's supposed to be a green reading, but I've never seen it. And I had this for like 2 months. And I was like meditating, doing yoga, really trying to settle my system down. And that's as good as I got. And then I started using a little bit of osteopathy. I got this thing called a still point inducer. It's like, it's marketed by the Upledger people, and it's basically trying to emulate doing a still point. And I did the still points, and I said, oh, well, let's do it. But this technique that I'm going to teach you right now does the same thing. It's much faster than the still point inducer. But, long story short, after doing that for a couple of weeks, all of a sudden I got green and, wow, right? And so generally, the times when I would get into the red before, I usually only get to the yellow. And generally, it takes a lot to get me into the red, like a COCA inspection. But anyway, so, all right, we're going to do this together. You're going to put your hands on, you find your bowling ball of your head, the occiput. You're going to go inferior to the occiput, so you're in the suboccipital area. You're going to melt your fingers into tissue. So you say here, skin, subcutaneous tissue. You don't have to press hard to get to muscles, but just stay in the subcutaneous tissue, and take those subcutaneous tissues to the right, so translate them right, and then translate them left. And you're gonna find that one direction is probably gonna be easier to go to on both sides than the other side. Then you're gonna go ahead and take them superiorly versus inferiorly. And in my case, it's inferiorly, but it might be superiorly for you. Usually that's, if you go superiorly, that's more towards flexion, and inferiorly, it's actually towards extension. So what we're gonna do is take it the way it wants to go for right-left translation. So I'm gonna take it to the left, I'm gonna take it inferiorly, and then I want you to hold your breath out as long as you can. So when you feel like you need to breathe, take a big deep breath in, and then you'll recheck. And I'll recheck. And go right and left translation, superior, inferior. Easy peasy. Amazingly different. You'll take your hands away and you'll be like, does it feel cooler because there's less congestion? Or does it feel cooler because I had my hands there, but it feels a little better, right? It's like you can feel it like almost instantly. And it's something you can teach your patients. And what's that? It's suboccipital myofascial release. Yeah. Suboccipital. At the Danto Osteopathic website, I do have a video on it under self-treatments. All right, reciprocal tension membrane and the temporal bone. Boy, I wish we didn't have the lights there because it shows really cool. It's like the RTM, and there's the fascia, the temporal bone, and the temporal bone's there. And you can kind of, I added this fancy muscle called the temporalis muscle, and you can kind of see how that, it's like they all kind of resemble each other, these sickles that are kind of working, and it's, similar functions, and they're related. And we're gonna treat that. And here's another cool picture with part of the occiput cut out to see that reciprocal tension membrane. This is from one of those body exhibits that come around and you can go to, and I probably took like over 150 pictures when I went there because I was like, there's so many cool things to see, but that was one of them. This is the temporal bone, just to show you, here's the sigmoid sinus, and here's the carotid artery, carotid artery and the vega and the internal jugular, and then here is the cranial nerve 8, and then right through, and that's the cranial nerve 8, but there's also the facial nerve that goes through there too in that bone, which is like, we talk, it's really important to know that the facial nerve goes through the temporal bone. So it's amazing things you can affect when you work on this next technique that we're going to pick up. Here's the eustachian tube, within the temporal bone. And this kind of talks about the motion that we always talk about, the wobbly wheel, and it's kind of going through the margin of where the tent attaches. And so this is the technique you're going to do on yourself. So you're just going to put your hands like over your ears, okay, just gently, and put enough pressure on so that you're feeling, again, with your palms this time, ears, skin, subcutaneous tissue, you're just going to be right there. And then you're going to we'll do one set at a time. So take your right hand and go superior, inferior, anterior, posterior, clockwise, counterclockwise, which it doesn't matter which. And you'll notice that there's a preference, right? So I would tell you that load up the preference direction. And you don't have to be perfect because you're just loading tissues. But the other thing is if we do the other side at the same time and then check the other side, superior, inferior, anterior, posterior. Man, both likes to go posterior, that's interesting. Clockwise. So, and then you're gonna, again, exhale all the way out. Hold your breath out, if you can still hear me. And when you feel like you need to breathe, allow it to go back, and then you'll recheck. So easy temporal bone treatment, maybe with somebody who has tinnitus, maybe for somebody who's having some hearing problems, eustachian tube dysfunction, dizziness. Important techniques that you can do and you can potentially teach your patients. My model there is my daughter. She's a PM&R resident. Unilateral ear IMFR. So you can also do the, put a hand on your occiput and do one ear, and then you sit there's a superior, inferior, anterior, posterior, so there might be some residual, and then clockwise, counterclockwise, and then see with the occiput hand, superior, inferior, likes to go superior, and right and left, likes to go towards that ear. And then you could add, for me, clockwise and counterclockwise, which would be like side bending right and side bending left, are equal. So I'm just gonna hold it, exhale out, hold it out. And then relax and then recheck it, and it feels better. So there's, this is very similar to our, we would do a 5-finger hold on a cranial bone and the occiput, but this is real easy, right? You guys can, it's just vector-based. Looking at the relationships, the occiput drives the temporal bone cranially, so we often say, the two are related, so I wanted to show, how you would do a myofascial relation treatment for this area. Ooh, bilateral ear treatment. We'll come back to this. See how she's moving her arms around? Hard to do when you're the one doing the treatment, if it's doing a self-treatment. But what we can do is when we do the jaw, we'll move our jaw around for the masseter, and you can, change the relationship of things. We can turn our head and change that relationship. Certainly for the suboccipital, if we had taken it in all those different directions and sat there, so what if I flex my head a little bit? What if I side bend my head a little bit? That will, again, have a further effect on treatment. And it involves more tissues. So it's like you'll sit there and you'll feel that response, and you'll say, oh, that's even a greater response. So we can continue to involve other parts of the body. And actually, you can actually see her legs are shifted, her knees are bent, they're shifted over to that side because we're involving her whole body in treating her head. Dr. Still said, just begin with the head, but you can use it to treat the whole body. You can involve the whole body in treatment. So it's really whole person treatments. And Warren said we got to treat, fast. So this is like treating the whole person through the head. It's kind of cool, right? Now, you could do these sitting in a seated patients as well. That's why, if you practice that yourself, you can do it in a standing patient. That's why I'm doing it on myself on stage. All right, parietal bones. It relates to other 5 other bones. And, here they are. We kind of saw those before, and we palpated them. Lambda, bregma, lambdoidal suture, all that stuff. I skipped the parietal squamous suture. Sorry about that. I was excited. But you should always check the parietal squamous suture as well in your screen. And then here's a baby. And in the outer surface, you can see those two ridges on the parietal bone, where it says parietal bone, there's like a ridge above and a ridge below. Anyone know what those two ridges are? They're the outer and inner attachments of the fascia for the temporalis muscle. You know, that just, you know, blew my mind when I had learned that years ago, like these, you know, relationships, and you can feel them on the skull, and you're like, what? You know, you don't necessarily realize it. You might only feel, you know, the outer one because of the temporalis muscle might be in, you know, in the way, but, you know, if you are patient and soft with your fingers, all of a sudden you can go through that temporalis muscle and palpate it. But we're going to get to treating the temporal muscle in a few seconds. Here's the parietal inner surface, the sagittal sulcus, a groove along which the sagittal suture in which the sagittal sinus runs. So you can see right at the, you know, we saw it in the temporal bone, the sagittal sinus. You can see right here is where it crosses in the parietal bone. These bevel changes are the coolest because that's where the axis of rotation is, and you know, for the bone. And it's like, my first cranial course, I didn't get it, you know. It's like we looked at all these things, we didn't necessarily look at where the bevels change. But you know, some of those points that you found as you were palpating that were tender were right where the bevel changes, because it's under a lot of stress if there's a somatic dysfunction. It's really, you know, mechanics. We can feel in our knee on either side, and you know, we might feel a little bit of tenderness on the medial side, because that's always kind of the one that gets stressed because of the you know, cerebral triad. It's under, you know, it's a vulnerable area. Yeah, it's a vulnerable area where the bevel, where forces change. And we always talk about the apex of the vertebral curve and the top and bottoms of it, because the, you know, they're balancing points for the musculoskeletal system. Just a little bit of some arteries. Boy, did I do some fancy graphics. And those are the bevel changes. Okay, parietal axis of motion. Again, showing the bevel change and the relationship to other bones. This is kind of showing what internal and external rotation look like and how the head shape changes. And now we're going to do the temporalis myofascial release. And in this case, because we don't have a patient right in front of us, we're going to do it ourselves again with our palms. And we're going to fill in that temporal fossa. So the temporal fossa really starts just above our zygomatic process and going back towards here, back towards the, you know, posteriorly and superiorly towards the parietal bone and the occiput and everything. So now you're going to go ahead and take the fascia. I would always do one side and the other side. So superior on the right, inferior. It likes to go inferior. Well, that makes a lot of sense, and you know, because attached to the jaw, there's a pull down there. Anterior, posterior likes to go anterior, internal, external rotation. So again, we kind of see clockwise, counterclockwise. So now I'm going to load up the fascias. Let's go direct this time. Be gentle, because this is like, you know, the third myofascial you've done, and you know, now you've developed some skills. So I'm going to take it direct the way it doesn't want to go. So I'm going to superior, I'm going to go posterior, and then I'm going to go the way it doesn't want to go this way, and then I'm going to check the other side. Other side is a lot looser and balanced, but it still doesn't like to go posterior. So now, here's what we're going to do. You've loaded up the fascia, it's tight. You're going to move your jaw over to the right and over to the left. Open up real wide, close, and now relax. Did you guys feel it all move and release very quickly, right? Quick as can be. That's the integrated neuromusculoskeletal release portion, Dr. Ward's baby, but we just call it myofascial release now with release enhancing maneuvers. So here's the masseter. Now we're going to be underneath the zygomatic process, over the posterior aspect of the mandible, and we're going to go again superior, inferior. I might do both at the same time. Superior, inferior. Doesn't like to go inferior, anterior, posterior. Doesn't like to go anterior. Again, I'm going to do this one direct, and now we're really going to use the jaw. Just open and close. Right and left. Feel that release. And then you can recheck, and you're like, that quick. Now, your TMJ patients, obviously, you know, I teach this to so many, well, I usually teach them deep pressure. And I'll be honest with you, developing this treatment, we went through all these muscles together after we decided to start looking at this. And what happened here was, my daughter has headaches. She has, migraines. So I'd been treating her for years, cranial, and it helps so much. It's amazing. But she's like, where do you still have? Oh, I still have it right over my frontal sinuses. And maybe it was sign. I went ahead and I put my hands on her frontalis muscle. And we're going to treat the frontalis muscle, depending on time. We have to look at that. But and applied the same principle. And I'm like, her frontalis muscles were so tight, so hypertonic, and it blew my mind. And so that's when I said, let's examine all the muscles. And I am a guy who wrote a book called Normalization of Muscle Function, where I go through and I treat all the muscles with a whole bunch of osteopathic treatment. Did not apply myofascial release to all the facial muscles, all the head muscles. And now I feel like an adult. Why didn't I think of that 15 years ago when I wrote that book? Okay, 20 years ago when I wrote that book. So, but you're learning it now. You're learning it almost months after I've learned it. So easy to do, really important. All those muscles can be treated, applying the principles, applying the vectors, taking them, you can do it either direct or indirect. You just have to remember there's 3 direct vectors of force. You don't have to do deep pressure. It doesn't have to hurt the patient. And they will be like, wow, I feel so much better. Because I'll tell you what, I'm feeling better and better, which, when you're doing a lecture or a presentation, you don't necessarily feel better until you get done. So this is, fun for me. All right, this picture here, I wanted to show the styloid process coming off of here. And so if you find the angle of the jaw and you go up the posterior ramus of the mandible, right here, just superior to the angle, and you fall into this ditch, which we often say, oh, that's AC1. But if you go in, and here's the mastoid process here, anterior to the mastoid, posterior to the ramus of the jaw, you can actually palpate the styloid process of the temporal bone. It's like, it has the styloglossus, the stylohyoid muscles hanging on it, and ligaments. Those are like anchors for the bone. It literally, and then you have all these other posterior anchors and the mastoid that, but these are, big anchors and big important things to know. And so then also we can see the masseter in the other picture as well. So, just kind of how it attaches to the I said it earlier, the very fancy bone there. Is that okay? You guys don't have to help me. All right, but you saw it anyways. All right, Here's the global hyoid muscle diagnosis and myofascial release. So that's why I wanted to get to show you the hyoid. And so you guys all remember the hyoid treatments? Anyone? All right. So we're going to go, find your Adam's apple. The hyoid superior to that is actually where the angle changes from being, depending on which of my chins I identify, where it goes from horizontal to vertical. And right there should be the hyoid bone. And you can take it one way or the other way, find out which way, so it's lateral translation. Mine likes to translate to the right. So I could take it to the right and again, hold my breath out. Now, while you do that, I'm going to explain to you why real quick, because people say, why are you always holding your breath? And you don't have to do that, but it goes much faster because you can hold in direct, and because of the primary respiratory mechanism, it will do the release, but you have to hold it longer. When you hold your breath, what that does is it creates air hunger, but not only air hunger in your lungs, but it's all of your cells in your body feel it and they respond to it, and it's like a neurologic reset, and that's part of the reason why you can get a much more profound release of all the muscles, because it's this neurologic reset. We did all those. All right. Wow, I'm like almost right on time. All right, so I had occipitomastoid tenderness. Oh, there's a question? Yeah. Can't hear you. Just hold a second, he's bringing the microphone to you.
Normally, we hold for until the patient can't hold anymore. Then you take a deep breath. But for your technique, do you do the same thing or different?
That's what I do, air hunger.
Huh?
I do air hunger. So it's like I say, hold your breath until you feel like you need to breathe. And then after I'm inevitably, because if I have them hold inhale, and then typically they can hold their breath in a long time, they look at it as a personal challenge. And I'm pretty sure that all of my patients are pearl divers. And I've got other patients to see. I don't want to wait 15 minutes for a patient to finish holding their breath. So I have them hold out, which is a lot more compromising in general. Now, if technically, if inhalation, exhalation, there's usually a preference in the tissues. You can check for that, but if I'm in a rush, I just have them hold it out, which is fine. Okay, either way is good.
Do you do a foot cross-flexion of the foot also?
You can always, that gets into cranial patterns. And like I said, I showed how you can do because we're working mainly with myofascial release and not worrying so much about the patterns of the SBS. But I appreciate the thought. So the diagnosis of temporal dysfunction, and I think that'll be the last one I show you guys, and this is going to be the occipitomastoid suture. So you find your tender point on a suture, and what you're going to do with your fingertips, you're going to just go on either side of it and spread apart. That puts it under tension. And then you can try and introduce your vectors of force, superior, inferior, anterior, posterior. It doesn't like to go. I'm going to take it the way it doesn't want to go, although it's more tender that way. Maybe I'll take it the way it wants to go. And then you could go and do a coup contra coup and sit there and say, you have to learn the country. But you can just hold it in that area and just say, hold your breath out, and out, and out. And then when you feel like you need to breathe, you can recheck it, and sure enough, I'm probably about 50% better. There's still some tenderness. All right, occipitomastoid sutures. If you have recurrent, like OA to C3 somatic dysfunctions, you must treat the occipitomastoid suture, examine and treat them, because that will hold on to the pattern. So and then probably vice versa. If you're constantly finding OA suture problems, make sure you're treating that, the upper cervicals. And then I showed you how to treat the suboccipital area. You can apply that anywhere in the neck, obviously. It's vector-based. C5 and 6, very typically going to have a somatic dysfunction. You've probably noticed that in your patients. That has to do with the whiplash dynamics. And you say, well, not everybody's had a whiplash like a car accident. We've all gotten tackled, ball and chain, you have to think about that. And it might not be, so severe. So like if it's a bad car accident, over 5 miles an hour or 15 miles an hour, because the bumpers are really designed for about 15-mile-an-hour force to absorb. Above that, the whiplash usually can be severe in people who have smaller bones, who are older, who are younger, females, because their bones are smaller. That whiplash injury can cause something called microfractures, so that when people have those microfractures, they're going to have whiplash syndrome, symptoms. You're not going to see the microfractures are on the facet joints, so on both sides of the facet. They don't show up on x-rays. What you have somebody who has, neck pain, and, for, anywhere from 2 to 6 weeks. As the neck heals, the soft tissues get better, the microfractures heal. More severe, so you're going to see those patients again in a year, because the joint changes that were involved in it result in arthritis, or what I like to say pre-arthritis. They've done the joint damage. That's why I recommend at least some kind of indirect in those patients. I wouldn't recommend direct treatment like in the ER. It's like the perfect place to initiate treatment, and if they can get, if you're seeing them as a primary care after an accident, treat your patients. Are there any other questions? I'm gonna end it there. Let's see, there's a million other things I could show. I didn't even get to do the frontal one, but that's it. Thank you.
Oh, here it is. It's okay, I wouldn't have answered your phone calls. Okay. Okay. Good morning, everyone. Thank you for being here. I'm Dr. Gina Marie Papilla. After that introduction, we don't need much more than that. I'm board certified in internal medicine and integrative medicine, and today we're going to be speaking about perimenopause and menopause, and really how to integrate hormones, lifestyle, and whole person care in midlife women. So let's get started. Okay, so the reason why I find this topic to be very pertinent and important is because there tends to be somewhat of a care gap. 50 to 60% of women who are actually symptomatic go undiagnosed. And what I've seen in clinical practice is that there's this kind of ping pong effect where the primary care doctors don't feel equipped to prescribe hormones and they refer to GYN. And then the OBGYNs don't necessarily, not all of them, prescribe hormones. So a lot of patients tend to fall into the cracks. So today I want to give you information so that if you feel comfortable, you have all the information you need to prescribe hormones and other modalities that may help women in this group. In addition, I am an integrative physician, and a lot of women come seeking lifestyle first. So I want to give you some tools for your toolbox of some of the things you may be able to offer them to help balance them out during this time. And then kind of tying it back to our osteopathic principles, the body always wants to come back into homeostasis. It always wants to create healing. So when we can really regulate the foundations and create a healthy, thriving body, the body tends to balance itself out. So that's gonna be our objective today. Okay, so at the end of this presentation, our goal is that you can do these four things. You can't really see number one, it looks like, but number one is to have a really solid lifestyle foundation. What are some of the things you can talk to your patients about that actually may be helpful for balancing hormones and things? Number two is confidence in your diagnosis. How are we actually diagnosing this, and what are the criteria? Number three, a tiered framework for treatment. How do you approach this patient? What order do you offer things? How do you approach that? And then number four, understanding what your prescribing options are, hormones and beyond that. Okay, so to get started, I wanted to talk a little bit about the physiology of perimenopause and menopause. So I don't know about you, but when I learned this in training, I had this picture in my mind that you go through life, and at some point when menopause happens, we have this like going of estrogen, boom, it drops off. But in reality, that's not actually what happens. What's happening in perimenopause is that we're actually having this volatility of estrogen. So estrogen is actually doing this cyclical thing where we have highs and lows. And what I talk to my patients about is that it's not necessarily that your body is feeling the really high estrogen or the really low estrogen, it's feeling the change. And every time you feel those change, the body is trying to bring itself back into balance. And actually, that volatility is what can drive almost 70% of early symptoms before we even see like that profound drop in estrogen. What happens, like we were saying, the body always wants to come back into homeostasis. It always wants to come back into balance. So in order to balance out those hormones, we see this overdrive or this push into the HPA axis. So our hypothalamic pituitary axis it's trying to bring our body back into balance, which makes sense because we know as we progress into menopause, the primary driver of sex hormones, once the ovaries really stop producing estrogen, are your adrenal glands. So that makes sense. But what we also see is this sympathetic overdrive. And that's also going to drive a lot of the symptoms that we're going to see in this perimenopause phase. In addition, as estrogen starts doing this up and down thing, we have this slow drop off of progesterone that can happen as early as like late 30s. So this is something to be aware of. And progesterone, as compared to estrogen, tends to be more sedating and calming. So when we lose that and we have this sympathetic overdrive, it's creating this imbalance where we're seeing more mood symptoms and anxiety. As compared to perimenopause, once we hit menopause, the drop of estrogen, that's the sustained decline of estrogen, that's when we start seeing the metabolic changes, like increase in insulin resistance and LDL. But it's important to kind of differentiate the two and know how to diagnose them. So let's look a little bit deeper here. Okay, so I wanted to talk a little bit more about the physiology of once we have that decline in estrogen, what's actually happening in the body, and this helps us to know what to expect in our patients. So number one, we're seeing the drop in estrogen, but what actually are the patients experiencing? They can experience hot flashes, affecting 50 to 80% of women. Bone density lost 1 to 2% per year. It doesn't seem like a lot, but as that stacks over time, it is concerning and something we need to think about. Reduced collagen leading to skin thinning, 30% decrease in the first 5 years. We know the lipid changes with the metabolic changes. We're seeing increased LDL, decreased HDL, increase in triglycerides. Our glucose levels are changing too, the insulin sensitivity leading to increased insulin resistance. And this is why you'll have women coming in, you know, I'm gaining weight in my midsection. Everything that worked in my 20s isn't working anymore. These are some of the common things that I hear from my patients. As far as muscle, we see this decrease in lean muscle mass over time, somewhat like 5% range in 5 years. As far as brain health, we're seeing decreased verbal memory, a lot of women complaining about brain fog. And then as far as the further metabolic and risk factors, in vascular changes, we're seeing increased arterial stiffness, and this is leading to increase in blood pressure over time. And this is why we see, when we look at metabolic syndrome, we're seeing it in kind of the decade before in men, and then as the estrogen starts to drop, this is when we're seeing these changes in women. Okay, so to differentiate between perimenopause and menopause, this is more of a clinical diagnosis. Labs are not very helpful, especially in perimenopause, because the FSH can be unreliable. As we're seeing this up and down volatility of estrogen, your FSH is going to fluctuate. So it may be diagnostic one day and not diagnostic the next. So what we're looking for is a woman aged from 40 to 55, and these are some of the symptoms: irregular periods, hot flashes, night sweats, brain fog, fatigue, irritability, poor sleep, vaginal dryness, although that tends to be later with the drop of estrogen, joint pain, palpitations, weight gain. But you can see a lot of these symptoms are not very specific. So you have to have a good clinical acumen and think, okay, I mean, hot flashes, irritability, palpitations could also be hyperthyroidism. So you have to keep your differential wide. And then, so based on clinical symptoms, that's how we're going to diagnose perimenopause. So perimenopause can be irregular cycles, or it could even be just changes in the cycles. Maybe the periods were 5 to 7 days and now they're 3 days. Maybe they're heavier, maybe they're lighter. Those types of changes within the menstrual cycle, in addition to some of those like symptoms popping up. And that's really how we diagnose perimenopause. And then menopause, you have to have 12 months without a period, so 12 months of amenorrhea. And then that's considered menopause, and then everything after that is considered postmenopausal. So it's really just one point in time. And then that has to be 12 consecutive months. So if they have a period in the middle of those 12 months, the clock resets there. So that's how we diagnose this. So FSH is not very helpful for diagnosis. Okay, so this is a framework that I'm going to propose to how to approach this patient. One of the first things I talk to my patients about, and why they usually come to me as an integrative physician, is they want to know from a lifestyle perspective, what are some of the things that I can focus on to help balance out my body and help me to just feel better? So I want to talk about what are some of the resources that we have as far as lifestyle, and then I want to give you your options for non-hormonal. What are the FDA-approved medications that are actually indicated for vasomotor symptoms or hot flashes? What can be helpful for other indications? And then number 3, we're going to talk about HRT, hormone replacement therapy, which over the last 25 years or so has been a very controversial topic. So I want to give you the information that you need to make an educated decision as to whether or not you want to prescribe. Okay. All right, so let's dig into the lifestyle foundation. So number 1, we're going to start with sleep. This is nothing, we're not brain surgery here. This is really just nailing down what are the best sleep hygiene modalities that we can inform our patients about. This is one of the most common complaints that you'll hear is changes in their sleep. I'm waking up in the middle of the night because we're seeing that drop in progesterone. Sleep issues and anxiety issues are going to be 2 of the big things. It's just basic stuff, aiming for 7 to 9 hours in a dark, cool room, avoiding screens before bedtime. This can all be helpful. Sometimes something like magnesium glycinate can be helpful too. So that's sleep. When we talk about muscle, we saw that profound muscle decrease is going to happen within the first 5 to 10 years. So aiming for educating your patients on how to build quality meals, aiming for about 30 grams of protein per meal. And I really stress weight training. This is something that a lot of my patients, another common complaint I hear is that everything I did to maintain my weight in my 20s is just not working anymore. And what were they doing? They were starving themselves and they were over-exercising, and it's just not working anymore. And it actually creates more cortisol, more stress, and makes the whole system even worse. So I talk to these patients and they're usually really busy. They're busy moms, they're working, they have a lot going on, and I tell them, if you're gonna get the biggest bang for your buck as far as exercise, this is where you have to put your time. There's value to cardio, there's value to high intensity interval training, but this is where you really need to put your money. As far as glucose, we know insulin resistance is going to start to increase, so what do we focus on? Quality fiber, having regular meals to balance out your glucose, grounded in protein, fiber, and complex carbohydrate. Just teaching them how to build these meals and eat as much as possible whole foods. Try to avoid all the processed things, even the protein shakes and all these things, whenever possible, eating whole foods. As far as we know, we're going to see the sympathetic overdrive when we talk about increasing vagal tone, something like a 4-7-8 breath, meditation, mindfulness, yoga. You kind of have to adapt it to the patient because not every patient's going to want to do yoga. Not everyone is going to be open to meditation, so adapting it to them. I've also created a handout that you'll see at the end of the presentation where I use some of the resources because I don't know, I learned meditation and how to teach it in my training, but I know most of us did not in our medical school and residency, so I do have resources for that. Social connection. So if anybody's seen those blue zone studies where they looked at places like Sardinia and Okinawa, Japan, and they found that these people were living into their 90s and 100s and they were vital. They're climbing up mountains, they're out in the community, and they wanted to understand how is it that they're living so vitally. And they found that yes, it's what they're eating and natural foods and the exercise and all these pieces, but it's also the social connection. It's being part of a community where they felt safe and they felt supported. So encouraging your patients to, maybe it's a coffee date once a week, maybe it's connecting with old friends. So that's very important. And then something I didn't mention with the muscle is that, listen, muscle is great for aesthetics. However, it's more important so that in our later decades of life, 80s, 90s, we're able to carry groceries up a flight of stairs, take something off of a high shelf, pick up our grandchildren. That's the goal of all of this, is so that we live with longevity and we have this concept of like a health span instead of just a lifespan. Now we're talking about toxins. So the tide has changed on alcohol. We used to think drinking wine was healthy, but in reality, it puts more stress on the system, more strain on our liver and our body to process it. We're being exposed to toxins every day, the fumes, the pollution, all these different things, and the body does a really great job of being able to metabolize them and detoxify it, but we can tax the system by using air fresheners and all these different things that make it a little bit more difficult. This topic is very overwhelming because it's like, oh my God, what am I gonna do? I'm gonna go home and throw out all my Tupperware, I gotta just throw everything out in the house. But how I talk to my patients is I say, I'm just planting the seed so that next time you have to go heat up food or you have to buy new pots for your house, you're gonna think you'll be able to make a better informed decision next time. And then weight loss. So there's actually pretty good evidence for just a 5% weight loss can reduce vasomotor symptoms by 40%. So just talking to patients about that, that's a very small amount, and that's a really great reduction in hot flashes or vasomotor symptoms. And again, these things are low cost, pretty high adherence. Again, we're relying on behavior change, but good things to recommend for our patients. Okay. All right, so number 2, we're going to be talking about what are the actual non-hormonal options for vasomotor symptoms of perimenopause and menopause. Okay, so there's actually only 2 FDA-approved medications that are indicated for vasomotor symptoms. They both have a decent amount, 50 to 60% reduction in vasomotor symptoms. Number 1's going to be paroxetine. This is Paxil, but at a low dose, 7.5 milligram. It's given at night. It's branded as, it's called Brisdel. And this is an SSRI, helpful for vasomotor symptoms. You'll see there are other, and we're going to get to the next slide, SSRIs that can be used for vasomotor symptoms but are not actually FDA, we don't have the indication for them, but they can be helpful. The other one is this medication, fezolinetant. It goes by the brand name Veoza, and this is a newer medication, but again, we have this similar 50 to 60% decrease in vasomotor symptoms. It's a neurokinin receptor antagonist. Basically, there is a center of neurons in the brain that are responsible for the thermoregulatory center, and this is an inhibitor that helps to just calm that down and reduces hot flashes quite a bit. The only thing you have to know about that medication, LFTs need to be monitored. Okay, so what are some of our other options, non-hormonal? So these are medications that do not have like a guideline indication for their use, but they are used off-label for hot flashes and other symptoms. How I like to think about this is, what is the patient coming in complaining about? If they're coming in with sleep issues, primarily hot flashes at night, gabapentin may be a good option because we know that's sedating. In the studies they did on gabapentin, the dose is either 300 milligrams nightly or pretty much 300 milligrams 3 times a day, which is that's a good amount of gabapentin, can be pretty sedating. So you need to be able to talk to your patients about these things. If someone comes in and they're having issues with mood and a lot of anxiety, maybe an SSRI is a good option. As you can see here, these are 3 of them that have been shown to be helpful for those type of symptoms, but not all SSRIs have actually shown to be helpful. So these are them with the dosages. Again, that handout at the end, if you're interested, has all these medications and things. And then if someone comes in, they're having maybe mood symptoms and hot flashes, but they're also having pain, we could think about something like an SNRI. And then if we're trying no medications at all, there's actually level 1 evidence for both cognitive behavioral therapy and hypnotherapy to reduce vasomotor symptoms by 50%. So pretty good evidence for that. No side effects, pretty high adherence for those things. And then, like I spoke about before, what I tell my patients is that all those lifestyle things, whether you're implementing them all at the same time or slowly over time, help create a better resting place, your body being healthy and vital, so that all of these things that we're doing will work even better. So they kind of stack on top of each other. Okay, so now let's get to the fun part. Let's talk about hormones. Okay, so here's the story on hormones. So in the early 2000s, a study came out that basically created a lot of fear in the medical community, but not just the medical community, also the lay population. And basically they were connecting hormone therapy to breast cancer and stroke risk and all these different things. And in the 2015 to 2017, looked at all this data again and basically said they saw this divergence when they separated the population that they studied into 2 groups. And I want to give you the information that you need so you feel comfortable with this topic. All right, so let's dive in. So this was the study done in the early 2000s, the Women's Health Initiative. It was published in JAMA in 2002. There were over 160,000 postmenopausal women, ages 50 to 79, and they had a couple different study arms. So they were looking at estrogen plus progestin. They were looking at specifically conjugated equine estrogen, that's oral estrogen that comes from horses, and then medroxyprogesterone acetate as your progestogen, that's coming from, that's a synthetic progesterone. And then they also had another arm that was estrogen alone, but only for women with a hysterectomy. Because if we're prescribing hormone replacement therapy, if a woman has an intact uterus, you need to pair estrogen with progesterone for endometrial protection always, unless they don't have a uterus, and then you could do the estrogen alone. The findings were very concerning, and obviously we can understand why there was a very steep drop-off in the prescribing of hormones after this. So we're seeing increased risk of breast cancer, cardiovascular events, strokes, thromboembolism. Interesting, we're also seeing a reduction in fractures, colorectal cancer, and both of the study arms were stopped due to the early risks. But I want to look a little bit closer at the data. So in the arm that had both the conjugated equine estrogen and the medroxyprogesterone, these were per 10,000 women, these were some of the increases. So 8 more cases of breast cancer, 7 more cases of heart disease, 8 more cases of stroke, 18 more cases of blood clots, and then this reduction in hip fractures. And you could see the mean age was about 63, and this was stopped in 2002. And then you have this part of the trial, which was conjugated equine estrogens alone. And what's interesting is that there was no increase demonstrated in breast cancer, which kind of challenges a lot of the things we think about estrogen driving breast cancer. We know a lot of the breast cancer we see are estrogen-sensitive cancers. You would think it would be actually the estrogen, but it poses this question: could it not? Maybe it's not the estrogen. Maybe it's the synthetic progesterone that may be creating more of a risk too. But we did see increased risk of stroke and also blood clots here. Okay, so what changed? So basically, when they looked at the data, again, in this 2015 to 2017, they noticed a divergence when they split the population into two. In women less than 60 years old or within 10 years of post-menopause, when initiating hormones, they actually saw a 40% reduction in heart attacks. They saw a 30% reduction in all-cause mortality. And there were further studies that we're going to go over too that actually show no CVD harm, but going even beyond that, and how an early window may actually slow down atherosclerosis. But then in the women, when they looked at them that were over 60, greater than 10 years post-menopause, when they were actually starting the hormones, they saw it pretty much confirmed all the scary WHI findings. So we start to see this theory of this timing hypothesis, that if you initiate early enough, you do have a benefit, but if you initiate later in life, there may be some harm. Okay, so basically after all this data was looked at again in 2015 to 2017, now we have studies, randomized controlled trials that are really looking at, let's really look at what the information is, what's the safety profile, what's the impact on cardiovascular disease. So this is the KEEPS trial, and the question is early hormone therapy safe for cardiovascular disease? The study had over 700 women. The age range was 42 to 58, and the timing when initiating was within 3 years of postmenopause. So they had a few different arms. One with just oral conjugated estrogen, so that is in women who are post-hysterectomy, do not have a uterus. The other one is transdermal E2 or estradiol, that's bioidentical estradiol and cyclic progesterone, and placebo. It's important, another thing you'll hear when people talk about hormone replacement is the term bioidentical. Bioidentical just means that it is the same chemical structure as the hormones that we have in our body, as opposed to being synthetic. But that does not mean it comes from like a fancy compounding pharmacy or anything like that. There are FDA-approved pharmaceutical grade bioidentical hormones. Okay, and then they had the placebo. So this was a 4-year randomized control study. The primary endpoint was looking at carotid thickness over time. So what's interesting is carotid thickness was neutral after the 4 years in all groups, and the oral conjugated estrogen actually trended towards less coronary calcium. So there seemed to be some kind of protective, and interesting again, because now we're seeing just estrogen without the progesterone having this kind of benefit. And then we are seeing this reduction in vasomotor symptoms by anywhere from 75 to 90%. I will say in women who have moderate to severe vasomotor or hot flashes, hormones are still the gold standard of treatment. Okay. This is the next study. This is the ELITE trial. So this was trying to compare early hormone starting versus late. So this looked at women who were within 6 years of starting menopause when initiating hormones, or later, after 10 years. This was about 600 women. Age range in the early group was about 55, and in late was about 65. And they were looking at oral estradiol, again, bioidentical, plus vaginal progesterone, that is the bioidentical progesterone, versus placebo. It was a 6-year study, and what they were looking at was carotid thickness and coronary calcium scoring. And the key outcomes, they found that as far as the carotid thickness, they actually saw slowed progression, but only in the early group. Again, adding evidence to maybe there is a protective effect if we are in this window. And in the late group, which was interesting too, we saw no cardiovascular disease acceleration observed. So again, it's starting to make you question, okay, maybe it's not necessarily the hormones in general, of the estrogen in general, maybe it's the form of the hormones, maybe it's the combination of them. So starting to ask these questions. And then we also saw confirmed vasomotor reduction. Okay, so this is the final trial. This is the PEPI trial, and this was looking specifically what is the effect on hormone therapy on lipids and clotting factors in postmenopausal women. So this was a study with over 800 women looking in ages from 45 to 64, and they had a few different arms. One with oral conjugated equine estrogen. Again, this is post-hysterectomy group. They had another group with conjugated equine estrogens plus cyclical or continuous medroxyprogesterone. So that is your medroxyprogesterone acetate, that's the synthetic progesterone. And then you had a group that was the conjugated equine estrogens plus the micronized progesterone, that's your bioidentical, or a placebo. This was a 3-year study. Their primary endpoints were HDL, LDL, fibrinogen, and then plasminogen activator inhibitor. So 2 lipid markers, 2 clotting markers. And the key findings that in all hormone arms, we had a 16% improvement in HDL, and an 11% reduction in LDL, and then a reduction in fibrinogen. So if we go back to that other slide that we looked at over time, what's the impact of the decline of estrogen on those markers? They're pretty much at par. So that by replacing the estrogen, we actually are seeing this kind of metabolic benefit. Again, profound reduction in vasomotor symptoms, but again, stacking evidence here. Okay, so despite all this evidence that shows that there may actually be not necessarily a harm, but even a benefit from doing hormones earlier in life, the indications for HRT based on the North American Menopause Society and the American College of Obstetrics and Gynecology still only have 4 indications, and that's moderate to severe vasomotor symptoms, genitourinary syndrome of menopause, that's like vaginal dryness, pain during sex, recurrent UTIs, still hormone replacement, bone loss prevention. This is not for osteoporosis. This is to prevent osteoporosis in women who are higher risk for fracture. Actually, when they did studies looking at women who had osteoporosis already, replacing the hormones didn't really make, I would say, a statistical difference there. And then premature ovarian insufficiency. This is surgical menopause, removal of the ovaries, or if we have early ovarian failure. And again, we talked about this, that timing matters and initiating within the first 10 years of menopause or less than 60. There have been some changes. You might have heard about this in the news that most recently the black box warning on women's hormone replacement has been removed. The risks are not off it altogether. They're just not in a black box anymore. They've been moved to standard text. They also mention that there might be a lower risk for initiating earlier in life. And then, like we said, the indications still remain consistent. Vasomotor symptoms, genitourinary syndrome, osteoporosis prevention, and that hypogonadism. And then this really just supports individualized care, that every patient is different. We need to understand what are their personal risks and benefits, and are they a good candidate for hormones or other things. Okay, so if you're like, I'm on board, Monday morning, how do I start prescribing? This is the recommendation. So usually would start with both, like we said, this is bioidentical hormones. It's an estradiol patch. You start at the lowest dose, plus a micronized progesterone pill. So bioidentical seems to have the lower risk of VTE. We also see the lower risk with the micronized progesterone, possibly of stroke and heart attack and all those things. So these are the exact same chemical structure as the hormones we have in our body. The transdermal patch is a patch that can be replaced every few days. The lowest dose you can start with is 0.025 milligrams, and then you titrate up from there. And you titrate not based on labs, you titrate based on symptoms. So you go really how the woman is feeling. And then micronized progesterone, usually what I start with is 100 milligrams nightly. Take it every night. Again, because progesterone tends to be calming and a little bit sedating, it actually helps with sleep and stuff too. There are other options. If you had someone that wasn't tolerating the patch, sometimes it's like the adhesive in the patch, or it's not sticking, doesn't seem to be absorbing. There are options to do oral estradiol. You can also think about changing the brand. There's a lot of different brands that make these patches, so you can think about changing the pharmaceutical brand if that's an issue with the adhesive in there. There is an option for conjugated equine estrogen for post-hysterectomy because of the data that we saw. And then you can also do 200 milligrams of micronized progesterone, but only 12 days out of the month. That tends to be a pretty heavy dose of progesterone, and most women don't tolerate it really well. It can cause like a little bit of mood symptoms as they're getting used to it, and acne. And I mean, you're dealing with all these symptoms. You don't really want to deal with acne at this time either. So most women do better with just the micronized progesterone. I will say I have seen women who have, they have like an IUD, and it isn't guideline, but I have seen that done for uterine protection. Okay, so what to expect when starting HRT, what's normal and what's definitely not normal. So within the first 3 to 6 months, what's normal? You think about if you start somebody on birth control, what are the symptoms that they're gonna experience? Breast tenderness or fullness, bloating, mild weight changes or fluid changes, nausea, headache, light or irregular spotting, or mood shifts as the body starts to balance out and get used to the hormones. What are definitely not normal? So if you have a woman who's been on hormones for, let's say, 3 to 6 months with no issues, no real spotting, and now we're starting to see new postmenopausal bleeding, this needs to be investigated. And even if you're not prescribing hormones and you see someone in your office that's been on hormone replacement for many years, and now they're reporting new vaginal bleeding, postmenopausal, this absolutely needs to be investigated. And then any symptoms of the concerning things, clotting issues, heavy bleeding, clots, bleeding after sex, any issues with symptoms of a heart attack or neurological symptoms. Obviously, these things are not normal and need to be reported and investigated. And then there actually are not any guidelines for endometrial monitoring while on hormones, but you really need to be mindful of postmenopausal bleeding. And basically, if you did have a woman that was having postmenopausal bleeding, they get referred to OBGYN. They'll do a transvaginal ultrasound to measure the endometrial thickness, and then based on their clinical judgment, whether or not they want to do an endometrial biopsy. So it's very important to kind of work hand in hand with that. And then there are no different breast screening as far as mammograms or things based on being on HRT. The guidelines around self-breast exams are a little bit, here or there. Some people recommend against it. I tell my patients, you are going to know your body better than anyone else, and in reality, you'll notice a change before your primary doctor does, or even your GYN, and bringing it to their attention, I think, is still worthwhile. Okay, so I think it's also important to talk about what we were talking about before is systemic hormone replacement therapy. What about actual localized vaginal estrogen, which is still the best option for moderate severe genitourinary symptoms? So how many women we see with older ladies, recurrent urinary tract infections, burning, pain with sex, vaginal dryness. This is still the best option, and there's a lot of different options. And what's great about this is we get very little systemic absorption, so you actually don't need to balance it with a progestogen if they have an intact uterus. And it can be safe also in breast cancer, but we'll talk about that. So there are different formulations. There's a low-dose estradiol tablet that can be inserted locally. There are creams. There's a vaginal ring that can be inserted and left in for a few months. And then, like we said, you don't need a progestogen, little systemic uptake, and then it improves vaginal dryness, pain with intercourse, pH, epithelial health, all of these things which can significantly improve quality of life. So it's good to have these things, be aware of them. There is very little systemic absorption of the vaginal estrogen, so it's usually pretty safe for women who have a past history of breast cancer. I still err on the side of caution. I always like to have the oncologist kind of looped in and aware of it. We're going to talk a little bit next about the what are the contraindications for hormone therapy. And I will say, although it's a history of breast cancer is not an absolute, it should be an absolute contraindication, I would say, for me prescribing, but a specialist with the oncologist on board, I have seen it done before for very severe symptoms. All right, so let's talk about this. So what are the absolute contraindications for systemic hormone replacement? So current or past estrogen-dependent cancer, unless explicitly stated by a specialist. So that means you have the oncologist on board and you have somebody that's prescribing hormones day in and day out, maybe from a menopause center, and they're working very closely together because the quality of life for that patient is so impacted by vasomotor symptoms. Unexplained vaginal bleeding needs to be investigated. Active or prior VTE, history of stroke or a TIA, established coronary artery disease or a recent MI, severe active liver disease because it can affect the clotting factors and all those pieces, and then obviously known pregnancy, contraindication to HRT. What are the relative contraindications? So one of the things listed is hypertension, diabetes, obesity, hypertriglyceridemia. Why? Because all of these things are factors that are building up this metabolic syndrome that eventually will lead to heart attacks, strokes, all the different things that come with that. So being aware of those risks and kind of weighing the risk-benefit for the patient. A strong family history of breast cancer or VTE, and maybe that just means a referral to a genetic counselor to understand what are the actual risks for this specific patient so that we can make an educated decision together. Migraine with aura, gallbladder disease, significant smoking can all impact it and need to be decided on a case-by-case basis. And then older age, like we said, this timing hypothesis, greater than 10 years from menopause onset. Okay. So this is my field, so I want to leave you with some tools from the toolbox. So these are some of the integrative modalities that you can use in your patients that are experiencing different symptoms. The North American Menopause Society put out two bulletins. One was for hormone replacement. It's about, if you're very bored, you want to read more about this, about 30 pages. This was, the last one published was 2022. So they have one for hormones, and then they have one for non-hormonal basis. Both of them are about 30 pages each. And based on them, they rate the evidence for all these different things. So the ones that are in green that we already spoke about, cognitive behavioral therapy, clinical hypnosis, weight loss, are all level 1 recommended modalities. All the other things don't have enough evidence for them to actually recommend it. But one of the principles that we think about in integrative medicine is measuring this harm versus when we look at evidence. If there is like a little bit of evidence for something, but the harm is very low, this is still something that I might recommend to a patient, because although maybe in studies it hasn't been statistically proven, I have seen patients in clinical practice that have benefited from some of these things. So let's go through. Mindfulness-based stress reduction, that's up in the top left-hand corner, can be helpful if you're not trained in that. Harvard has an online program that you can send your patients to. That I think it's free, actually. Other lifestyle adjustments, exercise. There's actually pretty good evidence for yoga, although the studies are not robust. It's very difficult to double-blind yoga, so that can be challenging too, but there is some evidence. There's also yoga. There's so many different varieties of yoga that it's hard to standardize. Dietary modification. There's pretty good evidence for a plant-based diet. It's pretty good evidence for just increasing fruits and vegetables. That seems like pretty low harm to me to tell my patients to increase fruits and vegetables, so that's another thing you can recommend. And then cooling techniques and trigger avoidance. I laughed when I saw this one it's like, this is not recommended. I can't tell you how many patients that I tell them, you know, have you noticed you had a hot flash with like spicy foods or alcohol? And they're like, oh my gosh, I never put that together. Significantly reduce those things, and hot flashes are significantly reduced. So I think that's an easy thing to recommend. And then dietary supplements. Does anybody know what the most common dietary supplement used for menopause is, or talked about marketing-wise? Yes, exactly, black cohosh. So when you look at the data, it's actually not a lot of good evidence for black cohosh, which I think is so funny, because clearly they do a very good job of marketing because everybody knows black cohosh. But some of the other ones that actually have a decent amount of evidence, Siberian rhubarb extract can be helpful. Equol, so they did this study in women in Asia where they basically gave them like a cup of soybeans, and they found a cup of soybeans a day. They found this significant reduction in vasomotor symptoms or hot flashes. But the problem is that not every woman has the enzyme required to metabolize the soy into the byproduct that actually is the phytoestrogen that reduces the hot flashes. So they got around that, and they engineered Equol, which is that soy metabolite. Some promising stuff there. Pollen extract, ammonium succinate is another one. And then we already talked about soy isoflavones and some evidence for omega-3. And then other things, acupuncture, electroacupuncture. This is another thing that they don't really recommend, but I have seen, especially in my patients who come to me who are post-breast cancer, this is a great option, acupuncture. And a lot of them do really get relief. And why I think it's difficult to study, again, it's hard to, they do sham acupuncture to blind it, but it's very difficult to study acupuncture. And also, anytime you see a Chinese medicine practitioner, acupuncture is not used in isolation. It's used in a combination with all the different modalities, and it's that holistic plan that really demonstrates the most amount of meaningful impact in my patients. I thought this was interesting, this neural oscillation calibration. It is basically like a device that mirrors your own brain signaling, and then it mirrors it back, and it can reduce the hot flashes. I thought that was pretty cool, technology advancing. I have not seen a patient that's had that. And then there's very limited evidence for cannabinoids, milk thistle. So these are some of the things in your integrative toolbox. Okay, so what did we learn today? We learned what are the solid lifestyle foundations, some of the things you can recommend to your patients. We got confidence in our diagnosis, that it's really symptoms over the labs, and it's about getting a really good history. We learned that tiered framework of treatment, lifestyle, non-hormonal, and hormonal. And then we talked about understanding what are your prescribing options, HRT, and then some. Here are some of my references if you want to read more about those. This looks a little blurry. So this is the handout I put together. So basically includes all the different things that you can use. This is the QR code that should bring you to the page so you can see that. And then we're open for questions.
It's a great topic. Thanks for the discussion. In primary care, I see a fair amount of my patients seeking some relief of their symptoms, but perimenopausal symptoms, at some of these fountain youth clinics is what I call them.
Yeah.
Whether it be male or female, in this case for the females. What is your take on the use of the hormonal implantable pellets in perimenopausal women when they're not postmenopausal at this point, certainly earlier than we're speaking to here.
Yeah, that's a great question. So I don't use pellets. A lot of times with these things, I don't find that there's like good resources. Like, where do you actually get the data for looking at pellets? What are the dosing? How do they know? What's the absorption like? As far as using hormones, I have had women who are in that perimenopause phase. They're not quite estrogen deficient, but they are having mood symptoms or sleep symptoms where I'll use progesterone earlier. And that's the micronized progesterone. It's very safe, has a pretty good safety profile, and they tend to respond really well to that. And it's that plus all the lifestyle stuff too.
Are you following up on hormonal levels in those people because they are not postmenopausal?
Sometimes you can, but it's not like I have and I do, but it's not like good data. I feel like it's not very like reliable data. Even when you're doing hormone replacement with the actual estradiol and those things, the hormone levels don't really tell you too much, and the guidelines say that you really need to do it based on their symptoms. Yeah.
You had mentioned that part of what drives the anxiety is sympathetic overgrowth. Has there been any studies, or do you use beta blockers for women that are really suffering from that?
That's a really good question. No, I haven't. I'm a little bit, it's funny, as you say that, what I'm thinking about is that I did some CME training with the obesity medicine, and beta blockers are actually an obesogenic medication, and I'm thinking in my mind, I'm like, wow, if you have a postmenopausal woman that comes to you and she's gaining weight already and you put her on a beta blocker, I think there are probably better options for anxiety and stuff, but I haven't seen studies specifically for beta blockers.
I have used even in primrose oil, which has some benefit, which probably most patients have some benefit. Sometimes very good benefit, sometimes not. The other thing is the Chinese usually use yam. Yam is have you ever used the progesterone cream before?
I have. So there's the use of yam, so it has the wild yam, like creams have progesterone in there. The issue with that is not a lot of them are very standardized, so sometimes there's not enough in there to actually have an effect on there. If you wanted to do creams, there are options for like compounding pharmacies, different ones that will make progesterone, and at least it's a little bit more standardized so you actually know what's in there. But I have had patients on with the yam creams. They do sell them over the counter. I just haven't had too much success with that.
I usually use progesterone.
Yeah.
Which is some probably 60% patients should have some kind. And in Chinese, yam itself is the natural hormone, which is the pregnenolone. That's the earlier hormone
Yes.
that goes to every part of the hormone when the body needs them. So Chinese thinks that yam is longevity early, which is safe for them for a long time. So it's good to eat every day, which is beneficial for the whole body besides hormonal regulation.
Yeah.
The other question is, do you use like estriol, like a cream or tri-estriol, like an estrone, estrogen, so give you less side effects of the estriol?
Yes. So I would say I don't really use them routinely. They're harder to track, and if I have patients that come to me and they're already on those like creams that have estrone, estradiol, estriol, they have all the different forms of estrogen, this is not guideline based, but there are tests that look at all the different hormone pathways and what direction they're going, because the concern is that depending on how your body metabolizes the hormone, you could be producing more of the dangerous, like the more breast cancer forming metabolites of estrogen. So there's to track those things. To your point saying about the pregnenolone, so if we all remember back when we had to remember the cascade of cholesterol hormones in the adrenal glands, pregnenolone is the mother hormone. It brings all the other hormones. So you actually can use, they don't necessarily recommend pregnenolone, although I have used that in my integrative practice, but DHEA topically has a similar effect and creates that downstream effect, can be symptomatically very helpful.
DHEA causes some side effects, hair growth or different stuff. I don't think pregnenolone will cause that.
Yeah, locally, not too much of an issue there, but it is worth being observant for that.
For the estrogen topically in the vaginal, it definitely has no cancerous at all, just still a slight risk.
Much lower systemic absorption, so there's not really a concern for endometrial. You don't need endometrial protection. So really, and it's safe enough where most, I would say, menopause centers will feel very comfortable prescribing it to a woman who has a history of breast cancer, even without talking to their oncologist. Although I err on the side of caution, I'd rather, have the oncologist on board. It's a pretty good safety profile.
I sometimes use vitamin E suppository with progesterone. They are somewhat helpful.
Yeah, that's interesting. Thank you.
How long do you keep them on, these hormones? And then when you decide to taper them down, don't they have symptoms again?
Great, that's a great question. So that's something we didn't cover here. It's funny, every time I would practice this presentation, I'm like, oh, that's a good thing, that's very important. So there are no guidelines for when you should stop it. It basically is decided from a case-by-case basis. Based on this evidence, everything we're looking at shows that when you initiate hormones is when we're seeing if you initiate after that 10-year mark, that's when the majority of the risk we're seeing. However, it really needs to be decided case by case. Yes, when you taper it off of them, there is a good percentage of women that still have symptoms, so just making them aware of it, and it's really balancing what are the risks versus the benefits, the quality of life and those things.
Excellent talk, by the way. Thank you. I had a question about the topical HRT bioidentical versus the patch. Have you seen the difference in the data for efficacy and side effects?
Topical versus like vaginal estrogen or the creams. There's not a lot of good data for the topical creams and stuff. And when you look at the North American menopause, nobody's talking about that. So I feel like you need to go to different resources, like the more integrative resources for those things. What I would like to see is what's the safety data on that? Maybe the safety profile is even better, and maybe we can leave women on it longer. So I feel like there's a lot of good questions. The more you dig in, oh, sorry, Christine. The more you dig into this stuff, you start to realize that this is a very understudied population, because women are difficult to study because of all the hormones and all the variations, and there's a lot of study that needs to be done.
What I've heard about the patches is versus the topical is they are fairly equal, and topical might be slightly superior because with the patch, if the dosing isn't appropriate,
Yeah.
it's hard to kind of maneuver it, whereas with the topical it's easier.
Yeah, it's a good point. Yeah, that's a really good point.
Thank you.
Hi, I was wondering if you use menopause as a cardiovascular risk modification.
That's a good.
How does that affect your preventive health strategy?
That's a good question. I wouldn't. There's no formal score calculator that you can use menopause for that. But I would say that when I use the kind of age range and what's going on with the hormones to dictate, am I looking for insulin resistance? Am I looking for those changes in LDL? And educating my patients that this is what happens as the estrogen starts to drop. What we have to look forward to as women is as the estrogen starts to drop, the risk factors do increase for cardiometabolic disease. Yeah.
Usually acupuncture is very effective, and also Chinese herbal medicine. Alone, either one alone should be very effective. So most times you really need any estrogen kind of stuff.
Yeah.
If you do those things. Of course, you have to like to do it.
I totally agree. What some of the issues come in with is that we're trying to study herbs as one formulation, but the reality is that anytime you go to a Chinese medicine practitioner, they don't just prescribe one herb. It's a combination of herbs that work synergistically. That's a little bit more difficult to standardize because they change it based on the patient and the symptomology and all those things.
Chinese herbs always use combination because the body is very complicated.
Yeah.
We start using combination thousands.
Mm-hmm.
Western medicine, they start combination.
Yeah.
Only research. So it's usually better. You can use single herbs, but the effect may be a little bit less, especially topical. But there are patterns very, very for most, probably 80%.
Yes, yes.
So, thank you for your presentation. Speaking of herbal medications, integrative medicine, have you ever considered using Ayurvedic medications? So, ashwagandha is very popularly known right now. There's a medicine called Shatavari, which is also used for this purpose as well for treating symptoms of menopause. Have you ever considered using that?
Yes, definitely. That's a great question. So do I use different formulations from Ayurvedic medicine? Ashwagandha I use pretty often. I've used some other formulations. I tend to refer to, same thing with Chinese medicine, I tend to refer to an Ayurvedic practitioner because I feel like my lens of what I can see and what I can prescribe is like this, and they have the wider range. And I think all those different modalities in their toolbox are complementary to each other. So absolutely, I think a woman, especially in that perimenopause where we're seeing the anxiety and the sleep issues, to kind of calm down that autonomic overdrive, ashwagandha is wonderful.
I'm curious, as we're going forward, and clearly your topic is one of people who are not worried about their primary diabetes. They're much more advanced. And we have lots of patients like that, particularly in the New York metropolitan area, Miami, Chicago, wherever you are. How do you see AI playing a role in this, as these particular women are often coming in with so much information they're getting from ChatGPT that is beyond the scope of an internist who's not integrative?
Yes, that's a wonderful question. So I think when we talk about AI, if the thing that everybody's talking about is if we don't learn to use it as a tool, we're going to be left behind. So I think it's a wonderful tool, but we need to educate our patients on the safety of it. So what I like to talk about is, thank you for bringing in all this data from ChatGPT, but ChatGPT also makes up a lot of stuff, and it will tell you what you want to hear. So we can't always rely on it. We don't know where it's pulling from. Sometimes it pulls from somebody's random blog. However, there are better AI tools that are evidence-based that pull from research journals, like something like, if you've ever heard of Perplexity, is one that's helpful, and it's pulling from research. So you need to be educated on the different types of AI, not pigeonholing into one, using all the different ones, and then educating our patients that it may not always be correct, and then just being comfortable saying, like, I don't really know too much about that, but I could do some research, or, you know, in all your spare time, do some research about that, and or refer you to someone. Yeah.
Excellent talk, Dr. Papia. I wanted to ask, how do you find that your osteopathic training informed your integrative medicine approach?
That's a great question, Dr. Foti. So when I went into integrative medicine, or learned about integrative medicine, it felt like this very natural fit, because our principles, the body is a unit, it's mind, body, and spirit. If we make the body really healthy, it heals itself. It's like all these things, like, oh, that makes sense. I feel like this is, Dr. Andy Weil, who's one of the founders of integrative medicine, he said, this isn't integrative medicine. He goes, this is common sense medicine. And that's how I feel about osteopathic medicine. It's common sense. And if the more that we can integrate these foundations into our practice, the better it's going to be for us and for our patients too.
I wanted to add, if you haven't heard of open evidence, it's a really good app that is actually open only to medical professionals, so that's a more reliable one than ChatGPT.
That's a good one.
Yeah, and I also I wanted to mention for any of your patients that have contraindications to getting hormone replacement therapy, phytoestrogen supplements are really good, and they can help with the vasomotor symptoms too. So
yeah,
just another thought.
It's really, and what I've learned too is, like, the more you talk to people who are in this clinical practice, the more you learn, because there's not going to be, who's dumping millions of dollars into studying phytoestrogens. It's not very lucrative, but the more you see in clinical practice that there's very low harm, good benefit, you learn all these things. Thank you. Okay, I think that's it. Thank you.
Good morning. Nice to see everybody. As Dr. Hoffman said, my name is Rachel Kushner. I'm a dermatologist on Long Island. Today we're going to be talking about emergencies in dermatology. The focus of this lecture is so that when a patient comes in, it's sometimes hard with derm and with rashes to differentiate between what's something that's urgent or emergent and what's something that's routine. And so that's what this lecture is hoping to clarify. The lecture was compiled by the residents that I teach with, and their names are listed over here. I don't have any relevant conflicts of interest. Okay, so what we're going to do today is we're going to talk for a minute about the basic surface of the skin and what it looks like. Then we're going to talk about the different rashes that you can see. And we're going to find out how the basic skin functions to identify serious derm conditions that we spoke about and how to manage and care for those conditions to the best of your ability. Some of them will have to be admitted to the hospital, and some of them you can treat in your office. Okay, so this is what the skin looks like. The epidermis has a few layers, the stratum corneum on top, followed by the stratum granulosum, stratum spinosum, and stratum basale. Underneath that, you have the dermis divided into papillary and reticular dermis. Inside the dermis, you'll see hair follicles, you'll see sweat glands, and the different conditions that we talk about, they affect this skin structure, and that's where you get the pathology. Ooh. All right. See, I'm really okay, here we go. So the stratum corneum, which is on the top, okay? When you lose the stratum corneum, which you do in some of the conditions we're going to be talking about, you can have a loss of fluid of up to 40 times, okay? If more than 50% of the bodice surface area is involved, then you can lose up to 4 to 5 liters of water a day, which leads to the loss of sodium, potassium, and chloride. So what that causes is metabolic instability, which can lead to cardiac arrhythmia, hypovolemia, and cardiac failure. You can get temperature instability because you're not holding on to what you need to, and that can give you a hypermetabolic response, which then also predisposes you to infection, okay? When the top layer of the skin is disrupted, obviously that leads to the bacteria being more able to get inside, which increases your predisposition to infection. So this is some of the different rashes that you can encounter. So urticaria, which is, in layman's terms, hives, okay? That's a skin reaction. You'll see wheals or hives. Usually we see them within 24 hours. It can be mediated by 2 different responses. One is a type 1 or IgE-mediated immune response, and one is a non-immune response mediated by mast cells, which release histamine. And that can give you edema and swelling in different areas of the skin, and that's visualized right over there. It is most generally caused by the beta-lactams, usually, by NSAIDs. It can really be caused by many things. A lot of times in the office, when we see a patient like this is not like an emergency, and you can eventually recommend to the patient that we do patch testing to see if there's something that they're coming into contact with or something that they're taking internally that can be causing this, but this can also be severe, and that's why it's included in this lecture. It can be associated with angioedema, anaphylaxis, and serum sickness, and the most important thing about this is to avoid the trigger. You can use antihistamines, steroids, and for anaphylaxis, you would use epinephrine. A morbilliform drug eruption, very often you can have somebody, this happens pretty commonly. Someone will come into the office and with this rash that consists of macules, it consists of papules, they didn't do anything, they don't know anything, they didn't take anything, and then when you do a further history, you'll see that a couple of weeks ago they took an antibiotic. And very often this can happen in somebody that has a reaction like this. It can happen 1 to 2 weeks after starting the drug, and a lot of times what will happen is it'll just present us, let's say, 1 or 2 spots, and they don't even realize it because it happens as soon as they start taking the medication, and then it starts to spread, and then it can look like this. It's a type 4 hypersensitivity reaction. Again, the beta-lactams is a common culprit. Bactrim, anticonvulsants, but it can be linked to really many other medications or even any of the herbal supplements or anything like that that the patient is taking internally. You can have a mild fever, you don't often see that, and itch. Again, you want to identify and stop the causative drug. topical steroid cream. Sometimes I do an oral steroid taper, but when you do an oral prednisone taper, it's very important that as soon as the prednisone is finished, even on the last day of the prednisone, you immediately transition to oral antihistamines, because if you stop the oral prednisone cold turkey, very often the rash just comes right back. So I'll say on the last day of the prednisone, if I'm doing it systemically, start an antihistamine right away, even one in the morning and one at night if they're feeling itchy, and then I taper that off slowly as well. Topical steroid creams you can use as well, but sometimes it's just hard to get the cream everywhere if it's so, like if the rash is so diffuse, and so that's why sometimes we have to do like an oral steroid taper. Red man syndrome, I personally have never seen this, okay, just so I would be surprised if you do, but it's good to know. You'll see flushing of the face, neck, upper trunk. It's about within 10 minutes of the infusion of vancomycin. It is histamine mediated, and it can result in hypotension, angioedema. You obviously want to stop the infusion right away. Benadryl, famotidine, and you can actually restart if you're brave enough. The slow infusion of the culprit drug, or find something else to try. That's my recommendation. This is acute generalized exanthamatous pustulosis, okay, also not super common, okay. You'll see little pinhead pustules 2 to 4 days after the drug is administered. It can last for 1 to 2 weeks, and then you'll have the skin peeling off, okay. The pathophysiology is an increasing IL-8 with neutrophil migration and survival. Again, the beta-lactams are common culprits with macrolide antibiotics and antimalarials. You can have high fevers, you can have swelling, organ dysfunction. You want to stop the medication right away, which is pretty much the theme. You can do a topical steroid, and again, the oral antihistamines are very key, and you want to make sure that you don't stop those cold turkey. Again, taper off slowly. This is DRESS syndrome. I've not seen this either. Okay, drug reaction with eosinophilia and systemic symptoms. You also get this diffuse rash. You have lymphadenopathy. It is delayed T-cell mediated, so you'll get tissue damage because of cytotoxic T-cells and cytokine release. The common culprits, you have phenytoin, carbamazepine, Bactrim, sulfas, minocycline, Dapsone. It's associated with facial edema, involvement of the mucosa, liver damage, and heart damage. You manage this in the burn unit or in the ICU. You want to avoid the antibiotics that could potentially be causing this. Withdrawal of the drug and systemic corticosteroids, IVIG, plasmapheresis. Again, this is not something I'm thinking you're going to see very often. Stevens-Johnson syndrome, which is very serious, and things that we have seen, especially when we're in the hospital, when you're doing consults in the hospital. The residents for sure have seen this, and I've seen this as a resident as well. You'll have dusky erythema. The epidermis starts to detach, like the skin is actually just peeling off, okay? Mucosal involvement 1 to 3 weeks after the drug, so you have to make sure if the patient is alert enough to be able to get a history as to what they could possibly have taken a few weeks back. Okay, the theory is that it's an altered drug metabolism, T-cell mediated cytotoxic reaction, Bactrim, anticonvulsants, allopurinol, NSAIDs. You can have fever, joint pain, stinging eyes, difficulty swallowing, because again, there is mucosal involvement here. So SJS and toxic epidermal necrolysis, it's a scale, okay? The SJS is mild, the TAN is more severe. So less than 10%, you would call it the Stevens-Johnson syndrome. There's an overlap where there's 10 to 30%, and that's the overlap of Stevens-Johnson syndrome and toxic epidermal necrolysis. And then more than 30% of surface involvement, you would call it toxic epidermal necrolysis. That also then you end up in the burn unit. You need consults from optho, uro, and ENT. You want to maintain fluid and electrolyte balance. That's super, super important because they're desquamating, so just they're not able to hold on to any of their fluids. High dose IVIG, antibiotics, dressing changes, just a real burn unit patient. You want to make sure you do the blood cultures to see if they develop any kind of infection, superimposed infection. Okay, then there are these infectious mediated rashes, okay? Staph scalded skin syndrome, okay? That's a bullous disease where you get like bulla, blisters, and again, the epidermis starts to detach. It's the Nikolsky sign where if you press on the blister, the skin starts to peel off, okay? Typically heals within 2 weeks. It's caused by the toxins A and B from Staph aureus, okay? It's associated with 60% mortality rate in adults. So this is a pretty serious thing. I, thank God, have never seen this either. The management is fluid resuscitation and dressings. You want to treat with Vanco or penicillinase-resistant penicillin and fresh frozen plasma. Toxic shock syndrome, as everybody knows, women at least, when you turn the back of the tampon box, there's a big, warning. Toxic shock syndrome may be associated with this. So that's the most common thing that people usually associate this with. It can look like a sunburn, also classified by desquamation, where the skin looks like it's peeling off 1 to 2 weeks after. Surgery is also a cause of toxic shock syndrome. Okay, it's caused by the gram-positive bacterial infection, staph, strep. It's associated with fever, hypotension, hyperemia of the conjunctiva, and the mucous membranes. You diagnose it via a blood culture and a CBC, and you want to treat with supportive therapy, penicillinase resistance antibiotics, and vasopressors, dressings and wound care. Again, anything that desquamates, you want to make sure that the dressings and the wound care are very important so that the skin has an opportunity to heal and then it does not develop into more of an infection or even a superimposed infection on top of what they already have. Other rashes. Okay, paraneoplastic pemphigus. This presents as mucosal erosions, also dusky, which is like the, the reddish, dark reddish patches that desquamate. Palms and soles are usually involved in this. Okay, you have severe stomatitis, which extends to the vermilion border. The mucosal involvement can be more severe or less severe depending on the patient, and I have seen a couple of cases of this. Autoimmune mediated is the pathophysiology. The common culprits are anything that's, a neoplasm, benign neoplasm, malignant neoplasm, non-Hodgkin's lymphoma, thymoma, sarcoma, any kind of neoplastic process can trigger this. So even if somebody doesn't have pemphigus, just idiopathically, this can be caused in someone with a neoplastic syndrome. Direct immunofluorescence, which is a specific biopsy that we do, and we put it in Michelle's solution, and you can test with that, linear IgG and C3. You want to treat the malignancy, then this goes away. Corticosteroids, wound care, it has a poor prognosis. Okay, this is erythroderma. Okay, we see this, we do see this. It clinically presents with diffuse erythema and scaling of more than 90% of the body surface area. The pathophysiology is an increase in epidermal cell turnover rate. Okay, so the cells just keep turning over and turning over and turning over, which means that they're less mature when they're already at the top, and then the epidermis sheds, and you end up with a defective skin barrier. Okay, the main differential diagnosis for this is psoriasis, like a very erythrodermic psoriasis. Psoriasis usually doesn't present this angry, but sometimes it can. Same for atopic dermatitis, seborrheic dermatitis, PRP, drug-induced, and cutaneous T-cell lymphoma. You manage with steroids, topical or systemic, depending on how diffuse the reaction is, or oral antihistamines. There's generalized pustular psoriasis. Okay, this presents, it's a chronic inflammatory disorder. You end up with sterile pustules, a burning sensation. It can, again, all of these severe life-threatening complications if the skin barrier is disrupted enough so that the patient can't hold on to their volume, and also because of their skin barrier dysfunction, they end up with infection. So that's, those are the two most important problems with a lot of the things that we're talking about. It's an altered expression of IL-36, and you end up with excess inflammatory cytokines. So the predisposing conditions for generalized pustular psoriasis: infections, prolonged steroid use, stress, hypocalcemia, pregnancy. It associates with metabolic syndrome and polyarthritis. You want to make sure you're replenishing the fluids and proteins. If there is an infection, you want to make sure you treat with an antibiotic. And the first line is acitretin, 1 milligram, which is, similar to Accutane, 1 milligram per kilogram per day. And that's why, like, it's not the only reason, but I'm saying, like, I don't use a lot of oral steroids in psoriasis, okay, because it's just a vicious cycle. Psoriasis is chronic, it's long-term, so oral steroids will give you a quick fix, and I have so many psoriatic patients that come in and ask for steroids, and you have to just really gently explain to them it's not the way to go, because you need something that, especially with the biologics that are now available, you need something that is safer for long-term that cannot end up with either the steroids stop working, or even worse, you can end up with something like this. Angioedema, okay? This is, you know, this, if you see this swelling of the lips or around the eyes, it's painful, it's edematous, it involves the face, the lips, the extremities, and the genitalia. It's often idiopathic, meaning, you know, and then, but sometimes it can be caused by different medications, ACE inhibitors, penicillins, NSAIDs, allergies. It associates with abdominal pain and respiratory distress. It is an emergency. You see somebody like this, you need to send them to the ER, okay, immediately, because you want to make sure they have a secure airway, okay? So a lot of times you'll have a patient that comes in and says, my lips are starting to tingle, they're starting to swell, they feel itchy. You know, you automatically want to go to, like, how quickly has this happened, over how period of time? Are you having difficulty breathing? You want to make sure you're documenting that, because what we're trying to rule out in those cases, and sometimes swelling lips have nothing to do with this, but you want to make sure you're not going to miss a case of angioedema, which progresses pretty quickly and is something that has to be treated in the hospital. Then there are these environmental rashes, okay, burns. So, you know, you have to distinguish between a burn that you can treat as an outpatient and a burn that has to go to the hospital. First degree, second degree, third degree burns. First degree burns are pretty painful, okay? Sunburn-like rash, it involves only the epidermis. Usually that can be treated as an outpatient. You want to do cool compresses. Anti-inflammatories are very important. You know, I don't do a lot of, oh my God, I'm totally blanking. The cream. Silvadene. Like, I was like, I have a burn, I need Silvadene. But, like, you don't. You know what I'm saying? Like, you need Silvadene if you have an infected burn. You know what I'm saying? You don't automatically get a burn. Like, I have friends text me all the time, I have a burn, can you prescribe me Silvadene? You don't need that. You know what I mean? Like, NSAIDs, not ice, but cool compresses immediately. You know what I'm saying? And often, and that's usually enough. That's usually what you need. Second degree burn is a partial thickness. That's also painful, but there you get swollen, blistering rash with the epidermis and dermis. And third or fourth degree, that obviously needs to be treated in the hospital, okay? That's where the skin is charred, okay? So the skin is black. So that's your, you know, your clue to that. And it's not painful, right? Because you've burned right through the nerves, you know? So that's also your clue to that. And that already has involved the adipose and deeper layers of the skin. Thermal burns, electrical injuries, chemical burns, you know, it's associated with leading to infection, right? Because you disrupted the skin barrier, so you can get a superimposed infection on any of these, and you can end up with hypovolemia. You want to cool the burn area, treat the infection if it's there, okay? Fluid resuscitation, and the severe burns which are treated in the hospital may need skin grafts. There are burns, unfortunately, related from abuse, pressure ulcers, psychological distress, people who burn themselves, people who are burned by other people. You really just want to make sure you're not missing any signs of abuse when someone comes into your office and you see these like little discrete burns. Heat stroke can lead to these things as well, and you can end up with severe CNS damage and lightning strike, which, you know, hopefully none of us will ever see. And that looks like a fern-like or swirl pattern rash, and that can be associated with heat arrhythmia, shock, and CNS damage. These are the references, and I just want to thank again Dr. Hoffman for asking me to come, and Dr. Taufik, for my resident, for giving me this lecture and working with us on this today. Now I'll get all unhooked up.
Promoting healthy dietary patterns through education and practical application. Implement ways to teach your patients the essential of culinary medicine. And then finally, we'll answer Dr. Cannon's question regarding defining lifestyle medicine and its uses. So culinary medicine combines nutrition science and culinary arts. And I got interested in this, getting my master's in clinical nutrition, learning that many of the lab values that I ordered as a doctor sometimes do not accurately reflect the amount of vitamins that you take or that your body's showing in itself. For example, oftentimes we'd always think of when you look at a lab value for vitamin B12, a lot of times it says if you have 200 to 400, if you're in those ranges, they can still cause some neuropsychiatric symptoms. So it's interesting to think about how to test labs, if labs of vitamins are important, and how to get the essential nutrients important. So cooking and knowledge of how to cook is associated with a healthier diet. And what I like to tell my patients is it doesn't even have to be cooking. Can it be things like meal prep, food prep, learning the essentials of reading food labels, the importance of looking at things? I know the topic this morning with Dr. Papia mentioned about microplastics, and that's a whole new field coming up. So the importance, many of my patients look for BPA, make sure to buy organic in certain foods, and again, this is also some financial barriers with that. But culinary medicine also takes into account all financial barriers and the importance of home cooking, preparing at home, and if you're going to eat out, make choices that are sensible and reasonable. So the thing about culinary medicine, and even if you're in the beginning of your career, at the end of your career, you may say to me, I know for myself, how do I get involved with it? Also, how do I get involved with the lack of funding? Do I have to take another board? Is this something else I have to do? Believe it or not, many DOs become famous, whether they be on TikTok, like tonight, or on social media, because they run their own cooking channel, or they do a little food prep show, or something like that. So there are funding opportunities through grant sources, and if you're interested in that, I can let you know a little bit more. But one way to get involved in culinary medicine is to identify partners who are important and who have the same goals as you are. So for example, if you yourself want to run a culinary medicine workshop, if you decide, you know what, I'd like to give back to my community, I think my community has a need, I have this specific niche, and I could show people how to cook, the importance of preparing food, then maybe partner with people. I've had people partner with community churches, with community sources, places like Whole Foods, funding places, like for example, identifying community kitchens, perhaps faith-based organizations or national organizations. For myself, it would be the ACOFP. Other people combine with the ADA, dietitians, schools, maybe push it towards the osteopathic medical school, saying look for CMEs that are available to it. But remember that in the back of your mind, maybe you'd want some of these things to be financed. So for myself, we decided at NYITCOM to get a food as medicine grant, and we wanted to explore with this grant, we wanted to do a hands-on interdisciplinary culinary medicine workshop and specifically aimed towards students, but also we made it into CMEs. I reached out to the ACOFP, they were interested in partnering with us for this grant. We then got the grant, and then even before I started realizing how much money goes into CME planning, buying food, then we decided to have it at a workshop so that it could be a big area, so the amount of money for the space, renting space, and if you're going to be using foods such as that need to be refrigerated or heated, that's an additional cost. So I slowly realized, oh, this grant is not going to be enough to cover everything. That's why finding partners and local resources is important. And with this, we held a pretty big culinary medicine. You'll see in our first row, those are our students. It was at the ACOFP April 2025. We decided to make every recipe gluten-free. We wanted to show the students that to incorporate this, not only utilizing what they know with regards to nutrition base, but to also recognize that food is medicine and that food can help not heal necessarily chronic conditions, but can help through the treatment process. So giving that individualized treatment approach to each patient that they will encounter. And it went very well, and while I was there, I met this man he's a DO, Dr. Zhu, and he's board certified, and again, Dr. Cannon, board certified, or fellowship trained in lifestyle medicine. And he basically is a cook, a DO, and a chef. And I said, lifestyle medicine, what is that? And it was really interesting. He's the lifestyle medicine chef, and he explained all there is about lifestyle medicine. So I just want to go into the six things about lifestyle medicine. So the American College of Lifestyle Medicine, which I'm going to give you some homework, Dr. Cannon, can you find out who's the certifying board of that? Because I do know many people who are going through this and getting fellowship trained in lifestyle medicine. And they have a dedication to the root cause of treatment of chronic diseases. And right now, this is huge. Going around America, as you know, there's a push for nutrition as a treatment, the bare minimum, right, of our lifestyle. And when I heard about lifestyle medicine, I did think that a process that to me seems kind of easy is challenging to live on a daily basis. For example, sleep, right? So the first one with regards to sleep. So like we said, 8 hours at least. That is challenging, especially we heard all these talks about perimenopause. Think about how much stress you have on a daily life. Think about even today where we had a lecture at 7 a.m. I had to get out of bed at 5 a.m. to make sure to get here by 7. So our own lifestyle is challenging to get 8 hours of sleep, but the importance of sleep is huge. Another thing, social support. As one of the I think it was Dr. Papia, she mentioned getting a coffee date once a week. The support of someone, and lifestyle medicine also says, okay, it doesn't have to be human. Sometimes a dog, a cat, or some of those, but having access to someone, something that you feel is a higher purpose or gives you a reason for living besides your patients, okay? We could all be consumed by our patients and our patients' problems, but having that social connection is so important. Another thing, stress management. And stress management doesn't only say about meditation, yoga, although some people find that really amazing, but stress management in the lifestyle medicine world is individualized. So it's really a journey, finding the way you can manage stress. Some people manage stress through CBT, going to therapy weekly, however they feel. Some people manage stress towards exercise, running. You could think of a million ways to do it. Some people manage stress by their art therapy, going on YouTube, just zoning out for a bit. I'm sure some people manage stress watching TV, right? But you have to find your way to do it and make sure it's a healthy stress management way. Exercise. As of now, the U.S. Task Force, everyone says we want 150 minutes of moderate exercise at least for every week, so we want to definitely get out there, 30, and then they added 2 times weightlifting sessions, hopefully around 20 minutes each. So that's the bare minimum. Other times there's 90 minutes intensive exercise recommended. You have to find your way and the importance, but just simply getting out there and exercising is important. There are the NEATs, those are the non-exercise activity. Thermogenesis, those are the things like, for example, I don't know who, shampoo, but some people like to vacuum. That has a high NEAT level. That, if you ever look at your Apple Watch or your watch, you are burning calories, you are doing that. So some people are, I don't know if you've known people, but sometimes they're fidgety, they're getting their NEATs on just from that. But conscious streaming exercise is important. Another one, which is a big one, is nutrition. And that's when we go into the culinary medicine and saying the importance of eating a nutritious diet. And some people can't get their 30 grams of protein per meal, whether they be a vegetarian or it's challenging, but just making sure that their plate is mostly filled with whole foods and just getting the right nutrition that's for them. Avoiding risky behaviors, and in lifestyle medicine, they think those have to do with alcohol use, to really either avoid alcohol, or if you're going to drink a limited amount, but also things that you yourself find risky. So, like for me, I decided in January to stop going on I'd go on Facebook just to watch those videos, right? And then before you know it, I was in this zone for an hour, wasting my time watching these 5-minute TikTok videos. I got like addicted to it. And then I said, you know what, I'm not gonna do it. I didn't do it for a month. And not that I miss it, but now I go back on it and do it because I'm bored or it's like at night and I'm like, let me go. So I know, oh, that's a little bit addictive for me. So avoiding behaviors that I'm saying, oh, it's wasting my time. Am I really getting joy out of this, or is this a problem? Other things, obviously smoking. But if, let's say, you have a problem gambling, if there's something, or let's say you are someone who, if you buy a bag of Doritos, you can't stop eating it. So lifestyle medicine would say, you know what, don't even bring that bag, don't even buy that bag. Not that we're labeling food as good or bad, we're just cognizant and saying, you know what, this is a risky behavior for me, so I'm going to try to limit it. And what's amazing about lifestyle medicine, which has a different way to culinary medicine, and a different way for nutritionists and dietitians, because lifestyle medicine makes all of these equally important. It's not saying nutrition is more important than exercise. Exercise is more important than sleep. It really shows that this is the whole person, and these are the things we can make in our lifestyle changes to really help us out in the long term. Why do we need this? Well, we need to prevent disease. We need to treat chronic illness. There is major inflammation going on, not only in the United States, but throughout the globe. Have you, in your practice, seen an increase in chronic diseases? Have you seen an increase in chronic or inflammatory diseases, or things like rheumatoid arthritis, rheumatologic issues, lupus, positive ANAs, elevated CRPs, increase in calcium scores? Inflammation is around, and they believe that with not only nutrition, obviously with pharmacologics too, lifestyle medicines can treat pharmacologically, they're doctors as well, but also the importance of food in the treatment plan. Stress management, I think, is important, especially for physicians. Life is hard, right? We're on a time crunch. RVUs, everything, our patients, our time doing it. So the importance to get that in. One thing we do at NYIT-COM, where we start at a young age, is focusing on physical movement. Movement is medicine, that's our theory. So the importance, they have a run club on Tuesdays. We have access, we're lucky, to a beautiful campus where we have long roving trails. I didn't do the club all of January and February because of the snow. I was scared of falling. Like, you know, you don't want to fall and hurt yourself. And as I'm getting older, I'm like, oh, these are things I have to think about. But movement is medicine. So incorporating that, our students, they feel like they're being hit with a fire hydrant. They have so much, especially the first years. Think about yourself as first year. When I think about it, I say, oh, it wasn't that hard. I think now, you know, many years after, because I was just sitting there and that's all I had to do to study. But at the time, if I were to put myself in that position, it was really hard. I wouldn't want to go back to being a first year, knowing all that I have ahead of me to do again. That's going to be a challenge. Just think about biochemistry, anatomy, your anatomy lab, everything you went through. So they feel like they're getting everything pushed on it. So we try to tell them, okay, even though you have to study, there's an importance of studying, learning your didactics, but there's also an importance of taking an hour out of your week. We do this once a week, hopefully more, but to either do a walk or a run through the campus, enjoy nature, which is one of our things that we put as the stress relief in the lifestyle medicine, but also to move and the importance of any type of movement. So, and one of the things that connectiveness, so this is a connection, right? Seeing all my friends every year at NYSOMS ROC, year after year, since 2014, right? So this connection, we have the social connectedness. When I look in the eye of someone who I remember every year, I'll see them at ROC, there's something special about that. When I learn that, okay, we know that we're going through the same thing, we both see patients, we know how challenging it is, that connectedness, and you can get that through CMEs or through organizations that you join or through your specialty society, so many ways. Find your happy place, like if you have a dog, if your happy place is traveling, if you have a place in Florida that you like to get to, if you just like being around in nature, if you're like hiking, these are all parts of the idea of lifestyle medicine. The avoiding risky substances, I don't really go into that much because I don't want to judge people, but I leave it to your discretion. You know what you need to avoid or some people need a glass of wine every night or two. That's their decision. Just recognize that there could be consequences to that. Sleep is a challenge, but I learned so much today just in these lectures. I'm thinking of like new sleeping meds, pharmacologic therapy, even things to do, mindfulness. So that's always something. I have references. And I do want to tell you one thing that I have learned recently, which I thought was really interesting. A fit prescription. So one day, because when I see patients, my patients are so interesting. That could be a CME for another day. But oftentimes, they don't want medication. They don't want a quick fix like writing. They want individualized attention and individualized treatment plan, but they also want to talk and someone to listen to them, and also someone who can understand that writing them a prescription, a lot of times they have side effects from it. And the side effects could be a lot worse than the main thing that they were trying to treat. So for example, if they had insomnia and they couldn't sleep and I wrote them an Ambien, oftentimes they'd come to me the next day and be like, oh my gosh, I had delusions, they have really bad side effects. So instead what we tried to do is we tried to give the patients an actual prescription, but not something that they could take to the pharmacy. So that's why I thought fit prescription was so interesting. And that's huge in the obesity medicine field, which is another board of ABOM, a board of obesity medicine. Many people are going to be board certified in it. It takes a lot, sounds like a good way to do it. But in the physical activity thing, they recommend a fit prescription, which is where you're going to tell the patient, okay, you're going to write it actually down in the EMR, you write it down, you print it out, you give it to them, and that stands for frequency, intensity, timing, what they decide to do. I'm trying to think of what that T is. And their E is enjoyment. So you're actually going to say it. So let me give you an example. So that would be frequency. Okay, so you're going to sit down with the patient and say, well, what can you do? And a lot of my patients are in chronic pain, so they're like, I can't do much. I said, well, give me something. Give me something. And they said, okay, I could walk. Right? Which we're blessed. Everyone, I don't see anyone in a wheelchair in this room, so everyone, we are blessed, we can walk. So I said, okay, we're going to take that. So we're going to say walking. How much do you think you can walk? They said, I think I can do it 3 times a week for 20 minutes. And with breaks, maybe they need, I said, okay, so we write that down, frequency. Okay, what's the intensity? A lot of my patients can't afford to have an Apple Watch or to check their heart rate. So I try to say the intensity for the eye is based on if it's, can they talk while they're doing it? So to do their own test, did they reach their maximal heart rate? So I like to be at the point where it's a challenge to talk, but you can still do it, where you think about it when your heart rate's up a little bit, you're breathing heavy, okay, or if you could say heavy breathing, that's the intensity. And then you're going to say the type of exercise we're going to do, walking. And then what is the E? The E is for enjoyment. So I would say to them, well, what do you like to do? Who do you like to spend time with? What is your pleasure? And many times they'll say, oh, I like to walk with my service dog, or oh, I enjoy listening to music. And that's what you're going to put on the prescription, the fit prescription too. Enjoyment, so while listening to music. Because I think we all agree, sometimes even if I'm on the treadmill or something and I'm watching TV, the time will go a little faster before you know it, especially if you're in chronic pain. When you have something that you're focusing on that isn't the pain, sometimes the time can go faster, and therefore they can get their movement in. So I hope this opened the eye for you on lifestyle. What do you think, Dr. Cannon? Isn't it an interesting field? Do you think it deserves a board certification or a fellowship? We could always ask Dr. Chowdhury afterwards, but I like the idea of it. Don't you? Tell me.
No, absolutely. Unfortunately, as medical students, they want to know what's on my board. And if you have to, I'm going back to our days, you know, okay, study EKGs because you want to get that right, or study life. And unfortunately, our board, meaning the people who write our board questions, I think have failed us as an osteopathic profession. I'm only speaking about internal medicine.
We're talking to a board member. Dr. Costa just walked in, a board member of the NBOME.
So that is are we concentrating on these things? Obesity, I don't know, an hour, I remember. Forget this, let's do EKGs, let's do pharmacology, study Mancini's notes, things that we knew were going to be on our boards, but we know how important this is, but no one's asking us until we're in practice. And I'm hoping that's changing. I'm a former dean of a medical school that put this in our curriculum, but are the students going to take it serious if we're not following through on it?
So Dr. Cannon, we have such experts in the field, so I want them to also say, but I could say, I know your passion for nutrition. I know how much you've done for the community. He's started community culinary medicine. He's helped, especially the homeless. I know your passion, and I truly believe that COMS, the NBOMA, the ACGMA, and correct me if I'm wrong, that they now recognize and put on boards nutrition questions, physical activity questions, and the importance of work-life balance.
That's very important. They're excellent. Thank you. I just remember at NYSOMS in my day, looking forward to nutrition class, and it wound up being like mathematics. And it wasn't fun. It wasn't really educational in the way that we wanted it to be lifestyle medicine.
Well, guess what?
20 years ago.
When I got my master's in clinical nutrition, guess what the first year was all? It was all organic chemistry, molecules. I'm like, where's the clinical? Where's the clinical? But then it comes, and then it comes, and there's so much. Nutrition is such a wide field, and such a, that's where interdisciplinary education comes in, everything. But we have two great speakers in the audience. Dr. Costa, do you want to say something? Do you think that the NBOME is taking this into consideration? Great questions are also when you have things like how many minutes is needed. 150 this many times a week.
Unfortunately, I can't speak for NBOME. I'm not at liberty to speak for NBOME, but on a personal note, I think it's very, very important. I think our patients, again, and it's very difficult to, if I'm 350 pounds, 400 pounds, telling my patient, you need to cut back on your carbs, you need to do more exercise. I mean, we have to be role models for these patients, so the patients see me and they're like, oh my God, you're buff. And I'm like, well, I do CrossFit a little bit here, a little bit. And they're like, oh wow, that's one, they want to hear more of your activity, and we always have that whole, 50 round peg in a square hole. Do 10,000 steps may not be, like I mentioned yesterday. Start with 1,000. Just do it around the block, in Yakima, Washington, when I was there as the assistant dean, we used to have meetings. It was a mile-long walk. The dean, everybody, we just had the meeting just by walking. That encouraged the secretaries, other people to walk with us and listen to the meeting, some of the students as well. So you don't have to start, heavy, but I do agree that this needs to be incorporated. But again, remember, the bioscience, biochemistry, all the first year teachers, they want everything's important. Well, no, you need to cut back something on the curriculum to be able to add. When everything is important, then nothing becomes important.
Thank you, Bernadette. Great talk. So I can certainly speak for FSMB and the USMLE program, but I know Complex is doing similar things. This isn't just because of what we've been seeing in the news lately, that there's been a governmental push to encourage nutrition, but really for several years now, way before Sean, you and I went to school, there has been a greater emphasis. I don't think it's been filtered down fully to the faculty and the students of our MD and DO schools, but recently we did an analysis of our USMLE. How many nutrition questions do we have? And a lot of it is, we don't categorize them as nutrition, so it depends on where they are. So we're looking at that, and we're also working with the entire House of Medicine, really across the entire continuum, not just undergraduate, but even in residency, and then continuing education as well. So there is definitely, over the last 3 years, a greater trend to encourage not just nutrition, but as much of what Bernadette talked about so wonderfully into the curriculum. And you're right, if it's not on the test, sometimes students and faculty don't pay attention, so we're trying to do our part. Thank you.
So I was just going to double click on what you said that ACOM, or ACOM, I always want to say ACOM, but the ACOM and AAMC work together with HHS to create these competencies, which are fantastic. They're already in the osteopathic curriculum, and the president of ACOM, Robert Kennedy, basically said as much. We've always had them as part of our curriculum. I do like that the competencies are way an improvement over what has been done. I think there was somebody who was ACL on the staff on the board helped create them, and I think that we're moving in the right direction, regardless of politics, doing what's right for our patients, doing what's right for our students. Students don't believe that they're getting nutrition education because we haven't made it clear how it's incorporated. And I think that this is a huge step forward because we have to, put it in a way that the students understand it and correlate it to patient care.
Perfect. Okay. Thank you.
attending these events. I'm a very proud osteopathic physician. I hope that comes through a little bit in my presentation. And what I have an opportunity to do is influence a lot of students coming up. And you know there's a lot of growth in our profession. New York State has several osteopathic schools. Florida, which is really where I practiced for years, 25 years as an internist in Tallahassee, Florida, the state capital, of course, so I was involved with advocacy, but Florida currently has 7 DO schools, not to mention all the MD schools, and there's more coming. And so that's an opportunity to really influence healthcare in America and influence these young folks coming up. I'm very encouraged that more and more we see that students are only applying to osteopathic medical schools. They have a lot of choices, and it's the type of landscape that we're really at a point where we can make an absolute difference. I wanted to also apologize on behalf of Kathleen Creason, our CEO. She's ill and couldn't travel. I checked on her this morning. She's doing a little better, and she sends her apologies, but she's been doing a fantastic job on behalf of all of our members and our profession. So I wanted to go over a few things. I'm the president-elect of the AOA. Bob Piccinini is our current president, and he's formulated these presidential goals, which I certainly support, all of us support and work towards. And so one of the first things is about communication and member engagement, and this is in part what we do by coming to associations, going to schools and campuses. You cannot underestimate that personal connection, meeting people, but more importantly, listening to people. The students want to be heard, just like you want to be heard, I want to be heard, but even more so, if you have, if you're raising kids or teaching kids and through their teenage years and their 20s, they very much want to be heard, and they want their opinion heard, and they want to try to contribute and be recognized for that. And so that's part of communication. Communication is the AOA and other groups reaching out and talking, but also you've got to be able to receive. And so I look forward to having a few minutes at the end for questions and some dialogue there. So in anticipating managing disruptions, and so what does that mean? So that's being an association that's nimble, that's responsive, but also more than just reactive, trying to be proactive. And if so, it can be anything in terms of advocacy and on a legislative issues, restriction of practice, expansion of scope, which is disruptive to our practice, and appropriate comprehensive physician-led care. So we want to be there to respond to that. Honoring the legacy and supporting the future. So you folks are part of the legacy of osteopathic medicine. There was folks before you that helped bring you along, that trained you, whether it was on campus or in offices or as a partner. A lot of folks that have influenced you. And so we want to make sure that we hear those voices, but also the voices of the folks coming behind us, all of these new students that I spoke about a few minutes ago. And if you've been on campuses, you'll see that those students represent all the people in America and the world. And so we're trying to expand our influence and our recognition throughout the whole world and not just the country. And that's the future of osteopathic medicine, healthcare in general, really, and then prioritizing mental health. Those of you that don't know, Dr. Piccinini is a psychiatrist practicing in Michigan, we needed him to be president to kind of psychoanalyze all of us of what the hell we're doing with all of this, but he's really prioritized that, and that's something that I must say with a younger generation, if you haven't seen it, I'll tell you, there's a lot of young folks on anxiolytics. There's a lot. Or they're on Adderall, you know, for ADD and so forth. Antidepressants and things like that. The key is that if you or they or your patients have some type of issue with mental health, it shouldn't be stigmatizing to practice medicine. There shouldn't be a question that says that's going to penalize you if you answer yes to, in terms of have you had depressive history of depression, or are you on treatment or medications or been in therapy? That should never be something that's going to penalize you and keep you from practicing medicine and helping others. Matter of fact, I'll just stick my neck out and say that I think it makes you a better doctor and a more effective physician for a lot of your patients. Osteopathic medicine is a lot about empathy, isn't it? Healthcare in general should have a big dose of compassion and empathy. And so that's part of mental health and wellness. Now, this is something that if you want to scan that QR code, this is something that Dr. Piccinini does online. There's, I've participated a tiny bit with him on that, but it's something to try to reach out to everyone, but especially the younger generation folks. And I'm sure a lot of you are very savvy with social media and everything. I'm catching up, but I love this idea, cooking with Bob. He considers himself a real aficionado, an expert in barbecue and meat preparation, but also he's Italian to the core. And the best I can do, if I get a chance next year, it's going to be eating with Rich. It's about all I can do, you know. But basically, he's got me there testing the sauces and everything. The white sauce is the best, by the way, if you get a chance for that. So what is your AOA membership doing for you? I hope everyone in here is an AOA member. If you're not, I hope that I can convince you to be one. But I'll say this, everyone, every osteopathic physician benefits from the AOA and what we do in terms of advocacy. What's the number one thing that a professional membership does, at least in healthcare? The AOA, our members and non-members consistently say it's advocacy. Who is advocating for you? And if I or anyone say go to the state legislature or go to Washington to advocate for our practice rights on behalf of our patients, everyone benefits from that, whether you're a member or not. But we sure could use your membership. And it's not, you know, it's not so we just are trying to get your money for an association, although it takes money to do things and to run things. But really, we want the numbers too. We want to prove that not only do we represent all the osteopathic physicians, they're members, they're here, they're behind us, they're supportive of this and our mission. But part of your dues will go to publications and news. You know, every medical student, osteopathic medical student, all they have to do is sign up with the AOA. We give them a QR code. All they have to do is put in their name and an email address. We assign them a number, and there's no cost. And that keeps them in the loop, because we need to make sure that they're informed. When they go out on a rotation or they become an intern, resident, and then new physician in practice, they're representing themselves and us, right? And so we want to make sure that they have up-to-date, accurate information. Advocacy, I mentioned, professional development, whether it's CME or working with medical schools and residencies, but networking, you all are networking now, whether you realize it or not, okay? And all opportunities to advance our career, but especially with board certification. I'm AOA board certified, very proud of it. I have absolutely never missed an opportunity to use all of my skills, whether it's been actual clinical bedside management. I had a traditional practice. I was in the office, went next door to the hospital, followed my patients. If they went to rehab, subacute, or long-term care, I followed them there, and I even followed them into hospice if they needed that, and subsequently got a CAQ in hospice and palliative care. But everyone follows a different path that's best for them. But my board certifications open doors, and I never missed an opportunity. I was with 10 other physicians. I was the only DO, and after a few years, I was leading the group. Not because I was smarter, not because I was the best clinician. I was better than most of those guys, but it was because I wanted to do it, and I had that fire in my belly, and I wanted to make a difference. And that's why I'm in the AOA and leadership for the same thing. But we've got lots of events, lots of online learning opportunities. The AOIA is kind of our business arm of the AOA, and developing more value for the members as well, and research. And you'll hear more about research in the coming year, and opportunities to support osteopathic manipulative medicine. Dr. Chin and I were out in the hallway. Y'all know Warren. There he is. And you can't walk past Warren without him stopping you and talking about that. And I'm very much on board supporting and have a few ideas as we go forward. Maybe we can talk about that at the end. So here's something, if you haven't heard, this is part of that disruption we talked about. The ABIM has, and that's the biggest group in the American Board of Medical Specialties. The biggest subgroup is the internist. All right? Now for us, it's family medicine. Okay? For them, it's internal medicine. And honestly, they've been a little bit of a bully to us, to osteopathic physicians. And we've tried behind the scenes, talking, negotiating, to make sure that DOs that have been program directors, assistant program directors for years, continue to be that when we went to a single accreditation system, ACGME. ABIM said, well, we don't want to play by those rules. We're not going to play by those rules. Hey, nothing against DOs, but we want them to be ABIM certified. If they're AOA certified, not quite good enough for us. And that's ridiculous. That's not what we discussed and agreed upon. And despite other negotiations, it's resulted in legal action. And the AOA is going to spend a few $1 million on this, we project, over the next 2 to 3 years. And I'll just tell you right now, I don't know that we're going to win, but we've got a good case, very good case. But all I can say is we're going to fight. We're not going to roll over.
Do you have any New York lawyers? Or?
Yeah, well, I trained in Philadelphia. I've got a Philadelphia lawyer. I know a guy. Okay? So, And by the way, I love David Broder. We've really formed a bond and a friendship over the years, and if you've never been to the House of Delegates, this guy knows what he's doing and really runs a great show and a great program as the vice speaker. So thank you, David, for that. Yes. Thank you. That's great that y'all recognize that too. So this is a big deal, and it's going forward. We're only in the early stages of this. Okay, so interrogatories, no depositions yet. All right, so a big thing about the AOA certifying boards. AOA certification, you heard me talk about it. I walk the walk and talk the talk with that. And so, but we've got to make this a value proposition for students. And so we've got to maintain the integrity of it. It has all the psychometric validity that you need in a certifying board and boards. And so we've got to make it, though, that it's attractive and financially competitive, which it is. But we're trying to get away from, and have for the most part, high-stakes exams. You got to take an exam the first time you get certified. Okay, I think that's very reasonable. But your recertification, we're not sending you across the country to Chicago, you know, to take another high-stakes exam. But you do need some ongoing work, the CME, and that sort of thing. We've even set up for several boards that you can take from home. You don't have to travel anywhere and do this. And so there are definitely some improvements in this. What's holding us back from everybody getting certified? Some of it is just communication and folks in these, the program directors in residencies. Most of them are MDs still, right? So we need more DOs out there. We need more MDs to kind of drink the Kool-Aid a little bit, right? So osteopathic distinctiveness. How are we distinctive? We like to say that a lot. And this is another conversation that Warren and I always have, you know, is that DOs need to do some OMT, but you need to get credit for it too, right? And so for the feds or your state legislators, when they look at billings and payouts, they're like, well, we've got so many DOs in the state, but nobody's really billing for, you know, Blue Cross of New York. We don't see many charges. And we know the DOs are doing OMT. We know you are. But you got to bill for it too so that we get credit, and so the world and the third-party payers know that we're doing it so they can appreciate it, right? And so I tried to teach on campus. I've been a course director for OPP. I'm an internist. But first and foremost, I'm a DO. That was well trained. I went to NSU down in Miami. Before they merged with Nova, it was just Southeastern then. And so I am capable, you are capable of teaching OMT if you wanted to. You got to relearn some things, maybe brush up on some things. But we all have that basic skill set, and we need to be using it. Don't deny your patients your ability and the potential to really make a difference in a short amount of time. It doesn't take as much time as you think, right? And so one of the things that AOA was absolutely involved in was with Blue Cross and Blue Shield of California. They wanted to affect the billing, so if you put that 25 modifier on there, because you also did some OMT with the EM visit, they wanted to cut your EM visit in half. They want to pay you as much for the regular because you had this add-on. So it was keeping folks from doing OMT. But we reversed that. And so it's those types of things where we're all in. We're going to put the resources behind there to make sure that something like that doesn't happen. We're also very much in support of osteopathic residents. You know it's a single accreditation system. Why did ACGME want the DOs? Because we're very adept at community-based training and primary care emphasis. And what do the feds want? More primary care, more preventative medicine, more wellness, emphasis on nutrition now. That's a big thing, and rightfully so. Nothing wrong with that, rightfully so. Less emphasis maybe on procedures, but procedures are needed, right? There's interventions that people require. Yeah, we're going to keep training on that too. But the osteopathic programs, traditional osteopathic hospitals, that sort of thing, we're in community-based delivery of health care. ACGME wanted a bigger part of that. And we wanted to have that relationship to where our students had every opportunity possible out there. If you want to be a pediatric oncological neurosurgeon practicing in Brooklyn, Queens, great. That's what I tell my students and potential students coming into Alabama. We have 200 students a year in each class. We're not a new school anymore. We're certainly not a small school. We're above average on all the metrics, above the national average. 100% placement rate the last 5 years. Researchers of the Year, 3 years in a row. Simulation competitions, 6 national championships, 3 international championships. We kind of know what we're doing, but it's in little old Alabama, in Dothan, where nobody's heard of. And people still say, we have an osteopathic school in Alabama? Yeah, you got 2 of them, actually. Okay, so, but does that hurt our students in placement of residency? Hasn't for us, okay? But we need you, as an osteopathic physician, to support this career trajectory for these young people going forward. This is part of our advocacy. This is outside the building that AOIA owns in Washington, D.C., very close to the Senate Hart building. But we're there, and people are there, and I invite you to come to DO Day in Washington if you've never done it. You should do it at least once. This is a big deal to come to that. I don't know if, David, if you're going this year, but certainly David and I have been multiple times. The students are energized, and they're energizing. And one thing about students in white coats running around Washington, everybody wants to talk to them. And I don't feel bad about that. I go in the room and there's 4 students. I'm the last one to talk. Okay? And the last one they want to hear from. They want to hear from the students. Right? So we got to make sure the students have the message and they have the message correctly, right? So let's amplify our voices. This is the Osteopathic Advocacy Network that you can join. It doesn't cost anything. Sign up for that if you've got a first Wednesday of the month at 3 or 4 o'clock, I think, Eastern time. But we'll have congressmen on and influential political figures on there and different political pundits and also give you feedback on what other states are doing, not just what we're doing on a federal level. And this is just another example of DO Day. You can scan that code if you're interested. We have a virtual presentation the weekend before and then in person in Washington. There we are. That's Cooking with Bob there. You can see how happy I look, stirring the sauce, stirring the sauce. All right, but this is a little treat at the holiday there at the AOA building. We had about 100 people in attendance. You can't see them there, but at any rate, that was a good time. And much appreciated we put that online. That's something I'm getting better at, using social media. I kind of resisted that when I was in private practice. I took care of a lot of sick folks, you know, chronically ill folks, the kind of folks that are in and out of the emergency room in the hospital, you know, every other week. And of course, the hospice part, nursing homes and all that. And I was just always worried about some kook getting on there and saying, oh, he killed my grandma. She was 103 years old. You know, he didn't know what he was doing. I got to tell you, once you get about 90 or more, the less I do, the better for you. But that's just my approach. So this emerging DO platform is something developed by the AOIA, and it's really taking off. And this is, once again, reaching out and meeting some of the demands and desires of all DOs, but particularly those that are newer in practice. They need a little bit more direction, whether they need some form of mentorship. They want information, and they want information that's easy to obtain. And so this is another QR code. You see, we're using a lot of QR codes, right? And it just makes it easier, and it's a little bit more with it. All right, so that's the end of my presentation. That's Ms. Creason on the left there, Dr. Piccinini, and myself. So I hope that was a little bit informative. Y'all have been very attentive. I appreciate that, but I would love to have any sort of question or interaction that you would like. So, yes, sir. Yeah, thank you. Yeah, microphone coming around, and I just caught out of my corner of my eye you were shaking your head agreeing with me a couple times, so I'm encouraged. So don't ruin that warm fuzzy feeling I got about you.
I'm here about advocacy, and that's why I'm here.
Great.
The kind of part of the question I want to ask you is, how are we doing statistically? I feel like New York, our delegation should be much larger.
It should.
The AOA House of Delegates were totally overwhelmed by Florida. I'm just using that as an example. So what are we doing? We're a state that trains a lot of physicians.
Yep. Number 2 state for medical schools.
4 spots as a DIO or DME.
Yep.
I have some of my former students right in this room.
Yep.
And they all went to ACGME, obviously. Well, no, not obviously. We had good programs. I'll thank David Broder. We were NYSOMS originally. And so our programs all made it through, including surgery, to the ACGME. I followed my friends. No one's taking our board. How? And I talked to the program directors. We have FM, we have IM, we have general surgery, and they're all taking the ABMS because they just, I don't know what it is. So could you share how we change that? I don't know. I do know that we have an issue at AOA with volume of people. Our profession has grown so rapidly. I talk to my people all the time. They're overwhelmed. I don't know if QR codes are going to solve all of that.
Yeah.
Kind of part of the bigger
Right.
problem.
Thanks for that. Thanks for that parachute.
How do we kind of get the program directors?
Yeah. Yeah, well, you bring up all great points, a lot of points. Let's start with where you started, right? New York State, why don't you have more members? I'm not quite sure, right? But certainly New York has the second most DO schools, right? Florida is number 1 and still growing. It is what it is, right? Why don't you have, more folks in the House of Delegates, right? That sort of thing. Because even though you've got a lot of DOs in New York, you do, I don't know, 9,000 or more, okay? But they have to be AOA members, right? So that's on me and others, right? It's mostly David's fault. But why, we've got to get more folks into the AOA membership. New York has a vote, a voice, okay? It's not like anybody's forgot or anything. But that's part of it. Part of it is I touched on communication, right? In terms of we got to get the message to the right people, which we've got to refocus and find different ways to influence the program directors. You as a DIO, man, thank you, right? You're in a great spot. But a big part of this whole thing, if you really want to drill down a little deeper, is, yeah, we can try to catch these horses. They're out of the barn. We can try to catch them. Bring them back into the barn. That's one way. Don't let them get out of the barn at residency. But when they're born, our little horses, when they're born in the medical school, indoctrinate them a little better there. And for whatever reason, we don't always have that on a campus, you know, across the board. Dean of a comm has to be a DO. You want comms to be as osteopathic as possible, but the truth of the matter is that less than 20% of our DO students are being trained by DOs. So that's my initiative, and we're going to talk a lot more about it, is we've got to get more DOs recruited to train our students. Once they get off campus, right, the OMT, using OMT decreases. They're influenced by MDs, and I love MDs. I mean, it's not us versus them. I mean, it's not that. But their influence circle is different. It's just like you raise a kid and they go off to college. They're influenced by their peers and their instructors, and they forget, maybe not forget, but they change and adapt some of their outlooks, whether it's political or not, right? Well, it's the same with our students. They get off campus, and for the most part, they're trained by MDs. COCO only requires 1 month in their third year, 1 month to be with a DO. At least do that, okay? 1 month, right? So that's a big part of it, and then we need more DOs like yourself being a DIO or a program director or assistant program director, or training third and fourth year students or residents. That to me, I think, is the crux of the matter. And unfortunately, we've got this great problem, all this growth, right? But do we have enough people to kind of manage that growth? And where are they? So in Alabama, there wasn't many DOs. There wasn't many at all. But we're making a difference now, but it's taken a few years. We're helping develop GME there. And that's true in a lot of other states. I mean, look at Montana, 2 schools, right? Although most of their students leave the state to train. But more DOs to precept and to be in leadership positions. To me, that's the crux of it. Warren.
Let me ask you that. In terms of you saying that a lot of people are not taking the DO boards, one of the reasons is that DOs, when they're in training, they don't see physical examples of people getting fixed with osteopathic manipulation.
Yeah.
I advocate that all the comms get clinics, that they can actually see people being treated and recovering well and getting better. If they see that physically, then it sets in their mind, it's distinctive to be a DO. And, you know, I have a license plate that says DO's ROC. My slogan is, you know, be proud to be a DO. You have to really advocate that special quality that we have in the training. And they don't see physical examples. They just train on each other. They don't know if it's going to work. And some of the things are difficult that they're learning. They're not going to use it if they don't see the physical, advantages of being a DO.
And so OMT is not the only thing that defines us, but is so important, right? And to have that distinctiveness, it is part of the philosophy, the thinking, the approach, you know, are we good listeners, or do we care about social determinants of health, and all of these different aspects of taking care of someone, right? The physical manual medicine, the hands-on component is important too. And so I try to teach students to have, I compare it to music appreciation. I don't need every DO student or every person in this room. You don't have to be God's gift to OMT. You don't have to be a prodigy, but I would like you to appreciate the music, right? And I try to teach students to like at least understand the difference between recognize jazz and classical and pop and rock, okay? And that's music appreciation, right? And whether you don't have to be a virtuoso in the field in order to utilize it and be effective. Yes, sir.
Yeah, so to speak, to add example to that, right? So I graduated residency about 4 years ago, went to NYT-Com, and after I graduated NYT-Com, I wanted to continue using OMT. Some of my professors are in this room, right? They inspired me. I went into internal medicine, but I still wanted to continue doing that. But then when I went to residency, I was told, well, no, you're not allowed to use OMT here, right? When I was finishing residency, they said, we'll pay for your ABIM board exam, not your AOBIM board exam, right? I went out of my way after to get dual reciprocation, get AOI board certified, because I'm an AOI member, I want to do that.
Thank
so
you.
I went out of my course. Yeah, so I went out of my way to do that, but I'm just wondering, so like you said, to give an example to what you're saying, I was trained by mostly MDs, and even some of my I had DO attendings, but they weren't performing OMT.
Yep.
Right? They
Yep.
weren't allowed to.
Yep.
So what can be done, I guess?
Every movement, every revolution needs a champion. Somebody's got to pick up that flag and say, this is not right, and we're going to get this changed, right? And so whether it's bylaws in the credentials committee for the hospital, every DO can do OMT. There may be some restrictions. Are you going to do cranial on a newborn in the NICU? Well, maybe not, unless you have that certification, and the additional skills. But we should be able to practice that by virtue of being a DO. And there should be a mechanism in the hospital in terms of credentials of how to do that. And it is their right, that this place is more strict and this place is wide open, do what you want type of thing. Yeah, there's some variation, but the best I can say is we need boots on the ground, need a champion, and we'll try to mentor those folks as best we can and try to put people together. Yes, sir.
I want to thank you for the opportunity to talk about this topic.
Thank you.
I am in a similar situation than him. I graduated from NYCOM, that is NYT now called, in 2002, and I went to New York Hospital that is now Presbyterian, and I did internal medicine. And I wanted to continue my AOA and to be board certified by AOA, but I had the same problem that him, so I was certified as the ABIM. And later on, I did my specialty in infectious diseases, and they told me, you don't have certification in the AOA in infectious diseases. You have to do ABIM. I did my certification in infectious diseases and ABIM. So I did all the recertification that I've been doing for both, but didn't have any support from the AOA to do my specialty and to be board certified.
Because you didn't have the AOA initial, right, AOBIM.
Correct. If that would be something that we can help the DO students, because there are many DO students that want to do what he just mentioned.
That's right. And so that absolutely has to change. I know there are people that are of the like mind. I know you're not alone in that. I support that folks that whether or not we certified in internal medicine, if you want to do your fellowship and get certification, I'm very supportive of that. I got to get everybody on board, and I'll certainly champion that. Just like I said, you need a champion. I'll be a champion for that.
Thank you very much, Doctor.
Yes, sir, Juan.
So as the champion at NYU for when I was there for OMT, I started an OMT for surgery program.
Thank you.
I published on it, and in peer-reviewed journals. I've presented on it around the world, and nationally and internationally at scientific conferences beyond the osteopathic conferences. I had a lot of students that
told by NYU they are not allowed to even apply to surgery as DOs, or that they are not allowed to apply unless they're from a certain DO school that is supporting them. If they're MD, they can come from anywhere.
Right.
They can be international MD, they can be MBBS, but DOs were excluded. The students then went online and posted on the AOA website that this is happening. They never heard back. What is the AOA doing to allow parity for our students? And are they supportive of something like the FAIR Act to allow us to get our students and our residents at that early point to realize that they are equivalent and therefore continue to their attendingship?
I'm trying to find, I hear you, brother. I'm trying to find the QR there, but I'll tell you, you can use this one. And that's the best way. So posting online is one way, right? Yeah, no, and I understand. I'm not going to make excuses for that. The AOA or any organization has to be responsive. There's no doubt about it. And once again, that's my pledge. That's Dr. Piccinini's pledge. We've hired a new communications director who's fantastic. I'm doing things, and Dr. Piccinini and I and the board, we're doing things to make that communication better, and that big part was listening and hearing what's going on. But yeah, we have to be responsive to that. Now why, I'm not sure. I'm not sure. I can certainly look into that more. You mentioned the FAIR Act. We're supportive of the FAIR Act. However, we resisted initially to go the legislative route. And that was even the AMA supportive, okay? ACGME supportive. But legislating things, you all know how that works. You do that, and then you're opened up to all these other amendments, right? And it becomes something more and probably not what you want, right? In terms of a legislative package. You might get some recognition on the parity, but now people want to talk about medical boards, right? They want to talk about licensing boards. And why do we need COMLEX? And why do we need separate medical boards? Or why do we need separate institutions, right? You can open up a whole can of worms. So we were trying to avoid that. But we see where it's going, and so we're trying to help and put the right people together. So we're certainly not trying to, be obstructionist or whatever, but honestly, I think we know what we're doing when it comes to federal lobbying. Where we've not carried the water as well is exactly what you point out, is being responsive to individual and or localized issues that pop up. And we have to be responsive to that in a firm, decisive, quick manner. Now, sometimes folks aren't going to like what we say, or they're not going to take our advice. That's okay, right? But we at least got to respond. That's the worst thing you can do is ghost somebody, right? And we don't want that reputation. Yes, sir.
Yeah, thank you so much for your trajectory, mentoring students, residents, and attendants.
Thank you.
Just a question in regards to health policy and the health policy fellowship now under ACOM that many of us have done in the past. How do you think that we could encourage younger, either students, graduates, recent graduates to at least do it, to understand that health policy and its wide net that could be done? You don't have to go to Albany every single day or to Washington, but just to understand, that goes a long way, and be able to understand what the AOA is doing and will continue to do for DOs, and I think that's one of those ways that people will be able to understand what the AOA advocacy-wise, and it's worth the membership.
First of all, we have to be present on campuses, right? Try to get communication lines with residencies too. Folks are mobile, so they leave the school, their email changes, that sort of thing. And so sometimes it's hard to reach people directly by email, but so we try to do blast emails and different, more general things. But we've got to reach out for folks. But what the AOA does is we have a Bureau of Emerging Leaders. That's just one thing, where we've got young people. We've got on our board a student, a resident, and a new physician in practice. And we encourage them to speak up and to have parts. And they're assigned to committees and so forth to be active. So we want more of these folks. What every president-elect gets to do is to greatly influence the appointment book on who's doing what. So on April 1st, this is going to open up, and anybody that's interested, young people and everyone, there's a spot for folks. There's different work groups and task forces, as well as standing bureaus and councils and committees. But apply. I won't know if somebody is really a great fit or really wants to do it, has got that energy that they want to impart. I won't know it if they don't apply to these for an appointment. So that's another way to get involved. How most people move up into federal or national types of organizations, whether it's AOA or ACOI or AOBF, ACOP and all that, ACOFP, is that they come up through their state. So this is the incubator room right here. I mean, we're in the incubator. So we got to get more young people and students in these type rooms or from campus to have a SOMA chapter, right, at every campus. To have get a pre-SOMA in undergrad, right? But there's a lot of different things that we can do, but we've got to incubate that mindset and those young people on a state level, and then that's how they're going to go to higher levels in terms of policy. Nobody can really show up and say, hey, I'm just energetic and I really want to do this. Well, to the AOA, I'm like, well, what have you done to get here? You kind of work your way up. Don't confuse that with saying, oh, you got to pay your dues. No, I'm not trying to see people run a gauntlet, but honestly, you got to get a little experience, in order to do that. But we want young, energetic people, and we want folks to self-nominate and volunteer, and if I don't have the right people, I'll tap you on the shoulder and ask you, right? And that's what we have to do, is we have to ask people. We have to ask to join the AOA. And that's what I'm saying today. For those that aren't, please join so that we can put all of our energies and forces and talent and treasure, together to make a difference. So, all right, I know we ran over a little bit, but thank you so much for indulging me. I really appreciate everyone staying, and excellent questions. Thank you. Have a good day.
cut it down. So I decided this year we were going to just do a couple cases and the differential in them. On overall, we'll do all that goes bump on the legs to excise or not excise and our references. I am a speaker, but it has no relevance to this talk for Galderma, Gain, and some laser companies. So we'll start with this case. This is a 45-year-old with a past medical history of hypertension and type 2 diabetes, presented with itchy bumps on her legs and ankles for a few months. So already your brain is starting to think. She reported trying A&D ointment and Vaseline, nothing helped. Patient admitted to having pets, especially cats, for several years and denied any sick contacts. She stated that she recently traveled to the Dominican Republic and she migrated from Haiti a few years ago. And this is what she walked into. This is what she walked in with. So a couple different things we see, right? We see hyperpigmented papules and nodules. We see center clearing, multiple different sites we see. And pretty much everybody goes, oh, where do you even begin? Is this prurigo? What is this? So scattered on PE, we see scattered hyperpigmented erythematous oval macules and patches on the lower legs and ankles. We see 2 hyperpigmented plaques without surface changes noted on the left dorsal foot. And so we start to think, okay, we look at her history a little bit, and we always say that in derm, most of it is by looking at the patient, and you can look, but now we got to figure out. So is it arthropod bites? Is it lichen planus, granuloma annulari, sarcoid, xanthomas, or erythema elevatum diutinum? And that's pretty much what you start to think about. So we decided to do a shave biopsy of the right ankle to rule out arthropod assault from her travels. We started Ultravate cream, a high-potency steroid, for 2 weeks. We checked her cats for fleas, and we had her return in 2 weeks. So on her results, it showed an interstitial, and this is actually the biopsy site. You see that central clearing, so you know that's where it was scarred. Interstitial dermatitis, very nonspecific. The findings are consistent with arthropod assault, and the path loves to throw in this line. Clinical correlation is recommended, which means CYA, there's not much more we can offer. So what we saw in the epidermis, it had some reactive changes. There's a wedge-shaped interstitial lymphocytic infiltrate with numerous neutrophils. The PAS stain is negative for fungi or significant basement membrane thickening. So the Alcam blue stain demonstrated no increased dermal mucin. So that took away some of our differential. So going back to clinical course, between April and September, the patient followed up monthly. 2 more biopsies were collected. They weren't doing great. The patient was improving, but was still getting new lesions and was itchy. Her cats were fine, no other animals. We tried all different strengths. We tried injecting cortisone, and we even tried UVB therapy, but everything seemed to improve. So then we ordered our labs, CBC with DIF, CMP, SED rate, CRP, ANA, RF, HIV, and hepatitis screens, serologies, quantiferon gold, and a UA. Again, we were ruling, is this keloidal, is it scar, is it sarcoid, is it LP? And again, dermal granulation tissue findings were deemed nonspecific. Without sarcoidosis or lichen planus was noted. We didn't see the typical path that you would see that. PAS stain again is negative. There were some numerous non-atypical vessels within the lesion noted with staining for CD34. Everything demonstrated appropriate reactivity. So now we went to EED versus GA. So on the 3rd biopsy, it showed dermatitis consistent with erythema elevatum diutinum. And this showed the reticular dermis contains an interstitial granulomatous infiltrate with mixed neutrophils and lymphocytes. There is a leukocytoclastic small vessel vasculitis and perivascular fibrosis. So that's why we saw that vascular component. And this is classic onion skinning known. The PS, again, was negative, everything else showing mucin. So then her bloods came back, and this is why this case is important. So everything came back within normal limits except for the quantiferon gold. So now we got a positive quantiferon gold. So we continued topical treatments. We referred them for infectious disease treatment and TB workup, which the patient probably needed, and further workup for hematologic malignancies. The next step would have been adding dapsone if no improvement occurred with the treatment with TB. So a little bit about EED. It's a rare chronic dermatosis characterized by these red-violet, red-brown lesions, papules, plaques, nodules, and they favor the extensor surfaces. It's considered a subtype of cutaneous small vessel vasculitis. It has, on a histopath, leukocytoclastic vasculitis lesions followed by fibrosis and replacement of the dermis with older lesions. You could see a fibrotic replacement. It can develop at any age, but it's most common in middle age and older adults. Its earlier onset occurs in HIV infections, and there's no gender or racial predilection. It is associated with numerous things. This is one of those like kitchen sink type of diagnosis that you have to now go and find out what it is. And this is just a list. You can do group A beta hemolytic, which you might think of erythema nodosum in a differential. Tends to be a little bit more posterior and tender. HBV, HIV, tuberculosis, hepatitis B infection. Well, I'm going to show you the differential in that. You're thinking about lichen planus, which is on this differential. TB, syphilis, granulomatous changes with polyangiitis known as Wegener's disease, IBS, anything inflammatory, celiac. So you could tell this becomes a very difficult diagnosis to make because you have so much to go to. We don't know what exactly causes it. The circulating immune complexes with repeated deposition, associated inflammation, and partial healing are thought to represent the underlying pathogenesis. Immune complex deposition results in complement activation. You get a neutrophilic infiltrate, and you see the destructive enzymes released, and they cause that fibrin deposition in and around small dermal blood vessels during these later stages of the disease. Here's another clinical presentation of it. This is both early and late. So you see early, the red-brown violaceous papular nodules and plaques on the extensor surfaces and near the joints. The later lesions are firm nodules at previously inflamed sites. You have systemic associations with this. It could be ocular, such as scleritis or uveitis, and you can see arthralgias. And so there again, you have the different stages that we shared. And when somebody like this walks into your office, you know, it's not uncommon in derm for us to sometimes have to biopsy 2, 3, even 4 times. And here on path, you can see an inflammatory nodule. And here you could see the neutrophilic debris. It's small. The lamellar fibrosis that gives you like the onion skin layers. You see how it's like onion skin layers if you were to cut it. And you could see that. Again, here you could see the fibrosis. This one really can show it. Layers, it looks like if you transected an onion. And here you can see a lot of the debris. So how do you manage this? So let's go back to, again, our workup. Skin biopsy, rule out underlying conditions. We did all of that. And then it's really treating the cause of it. So in this patient, we treated the patient for TB. And again, what is appropriate? If it's HIV, it's antiretrovirals. If it's celiac, it's gluten-free diet. If it's ulcerative colitis, I don't have to go through all that. You guys know that. But the point being is, it's not a disease you treat on its own. You have to treat the cause of it. The prognosis, unfortunately, is not great. It's chronic. It can be relapsing in a remitting course. And most cases resolve maybe 5 to 10 years, and it can last up to 40 years. So we're asking patients to walk around looking like this, which can be very, debilitating to them. Here's a lit review. I'm sorry it's hard to see. This list is all the different causes associated with EED. In this case, we showed tuberculosis, but it's low on the list. We found only 2 cases reported from 1991 to 2003 with TB and EED. Although this association between them remains possible, it seems unlikely that any strong correlation exists. But that's what we found on this. So it just puts it on your radar if you see this patient. You know that do a hepatitis screen, do TB, do things on that level. So in summary, it's a rare chronic condition, middle-aged to older patients. It's associated with some infectious causes. Early lesions are symmetric and red-violet to red-brown in plaques over the continuum of the disease. It can develop into firm nodules, and it shows very distinct fibrosing onion skin pattern, and dapsone is the treatment of choice when it stands alone. So the thing is, it didn't show up on the first 2 biopsies, and that's why we're not afraid to biopsy. So case 2, and the reason why I brought this up is indifferential to that. Doesn't look that far off, looks pretty similar, but if you look at the location, right, and you see there's atrophy in the center, we really didn't see atrophic plaques in the other one. And you have very specific, more on the face, and so in discoid lupus, it's localized red plaques, usually on the face, head, upper chest, and arms in sun-bearing areas. You have scaling, you have follicular plugging, you have atrophy, you have depigmentation, and you have telangiectasias of the involved areas. The scales are dry and thumbtack-like. You have photosensitivity in this, and your ANA is positive, where in our other patient it was negative. So an ANA positive, as you know, reflexes and goes into your double-stranded DNA. You can look at hypocomplementemia, suggesting lupus. In discoid lupus, the treatment, protect from sunlight, avoid photosensitizing drugs. Local treatment is the mainstay that we do with high-potency steroids. We also inject very commonly with ILK, intralesional Kenalog, or triamcinolone. And systemic treatment usually is antimalarials like Plaquenil. And I have to tell you, during COVID, and I don't know how many of you saw this, our lupus patients, or especially our discoid patients, had a lot of trouble getting Plaquenil during COVID, if you remember back. Which is hard to believe, but March 11th, 6 years ago, 2 days ago, was the declaration of the pandemic. I don't know, I had COVID March 19th. And I look back, I can't believe it's 6 years that we went through that. So Plaquenil is the mainstay of treatment. Isotretinoin can be used, thalidomide, belimumab. And again, the prognosis with lupus is persistent but not life-threatening unless SLE is present. So our next case, again, very similar looking, right? But this is on flexor surfaces. It has a little bit, if you look at it, and this is why in derm, looking at things is so important in descriptions. It almost has a little shine. It has a little bit like a more violaceous color, and it has like white lines on it. Right? It has a little bit of white lines. And this is lichen planus, so Wickman's striae. It's the disease of the peas, pruritic papules, pruritic purple papules, itchy, very, itchy, symptomatic. So these are lacy lesions also on the buccal mucosa. The white lines are the Wickman's striae. It's on the wrists, the genitalia, the trunk, the extremities. You can see it inverse in the groin, under the breast. It also has the Kepner phenomenon, which is very unique to it, which is it can be along any trauma you could develop a lesion, a injury, anything is what Kebner phenomenon, the disease state forms. So you see that in psoriasis, right? So a lot of people ask about psoriasis sitting on, why does it extend on the elbows? And you're all sitting here, we're leaning on our elbows, and that's why the plaque tends to extend. That's known as the Kebner phenomenon. And it may be drug-induced, such as gold, sulfonamides, NSAIDs. NSAIDs. If your patients walk in with a drug reaction, the first either fixed drug or anything, if there's anything I can tell you to take home from here, ask them about NSAIDs. It's the #1 cause. NSAIDs. And with lichen planus, you want to make sure to rule out hepatitis C. Treatment is remove the offending agent, check your medications, super potent topical steroids, immunomodulators you can use, and then there's systemic treatments such as steroids, phototherapy, and the new biologics can fit into this. And then our last case, I'll be right on time, is a 26-year-old African-American male with a past medical history of hypertension and obesity. He presented with a 4-year history of keloids on the posterior scalp. Past treatments failed. He had isotretinoin, he had intralesional Kenalog injections, he had cryosurgery, nothing really worked. He had multiple large keloidal nodules coalescing to form this large collection of tumors on his posterior scalp with purulent drainage between the tumors at the base of the scalp. And that's what it looked like. I mean, you just gotta have such, the Yiddish word is rachmanis, but heart for these patients. They walk in, they're so uncomfortable. So at initial consult, we started him on doxycycline, topical antibiotic solution, washes. At 1-month follow-up, there was no improvement. This is not going anywhere. No matter what I do, we could put in, and there's some derms in the room, I think they'll all agree, you could put in as much Kenalog 40 into this, it's not going anywhere. So we performed cryosurgery and injected intralesional Kenalog. So there's some studies out that show freezing the scar till it forms an ice ball, the keloid, and then injecting it with Kenalog helps. We've had some minor success with that, more on smaller ones, let's say on the ear. At 2-month follow-up, still no improvement. So due to treatment resistance and size, we sent him to ENT and facial plastics for surgical removal. This is draining, it smells, the patient's uncomfortable. So AKN, acnoid keloidalis nuchae, is a chronic inflammatory disease which can often be painful and very disfiguring. It begins as small, tiny papules or pustules in the occipital scalp. Sometimes in the face, it's known as pseudofollicular barbae. It's in the same family. Thankfully, we don't see it quite as bad like that. It later progresses to large keloidal plaques on the posterior occipital scalp to the nape of the neck, and it may lead to scarring, restriction of motion, alopecia. Advanced stages can be very debilitating. Primarily affects males greater than 20 years old, African Americans, Afro-Caribbean, Hispanics, ages 20 to 40, and the incidence is 0.5 to 9%.
Is it doxycycline for anti-inflammatory effect?
Yes. So it's both, it's a dual functioning drug, and doxycycline at the higher dose is antibiotic. So he was draining also because sometimes you get purulent nodules in there around the hair follicles. Doxy, the minimum inhibitory concentration for doxycycline for antibiotics and antibiotic, that MIC is 50. So there is a preparation of doxycycline 40 milligrams out that is below the MIC and is used as anti-inflammatory. It's not used as antimicrobial. It is a great drug. It's used in rosacea. It's used in many things. How did we find out about the effects of doxycycline low dose?
Your husband told you.
Was periodontal disease. So what happened was the gums, when you have bad periodontal disease, they put you on something called Periostat. Periostat is doxy 20 twice a day. They found in those patients their rosacea got better. And that's how the drug was found out to be effective for rosacea. And then the companies went and they determined, they figured out a 40 milligram tablet because of the MIC. Here's the problem. The insurance companies don't want to cover it. So I'm trying to think who made Oracea. I don't recall off the top of my head. I think it's Galderma. Galderma. So Galderma made Oracea, and they went and made their generic. But what do the insurance companies do? 50 milligrams of doxycycline is much cheaper. So they tell us as doctors, we want you to give 50 milligrams. But we have to be the best stewards we can of antibiotic. And we're setting up antibiotic resistance. And so I fight very often, and I'm sure Cindy does, that we don't want our patients on 50 milligrams. It's not the same drug. It takes you into the antimicrobial venue, and we don't want that. And that's a big fight we have. And patients, though, will say, just give me the 50. They don't understand, and they don't want to pay the higher copay, but it does take you to a different level. So that's why, rather than go to 50, I go to Periostat 20 twice a day. And that's pretty much what we do, because I don't want, dermatologists were the worst antibiotic stewards. We were the cause of a lot of resistance. People had, for acne, patients on amoxicillin, on doxycycline for years, 10 years, 5 years, 3 years. We don't do that anymore. It's 6 months and out. So those are the things that we want to keep in mind. So that's why Doxy works as an anti-inflammatory. It's like taking a Advil. So the pathogenesis is skin injury is the inciting trigger. It's occlusion, trauma, friction, and hair cutting practices. So you tell people to shave the area and the way the hair is growing. You have to teach men not to shave, same in the chin area, not up. Look at the hair. If it grows to the side, shave to the side down, not up against the grain. It's an exaggerated immune response. Intrafollicular antigens draw inflammatory cells to the follicle, damages the sebaceous gland and the follicular wall. The follicle wall ruptures. You get intrafollicular antigens released into the hair follicle, and a furthering inflammatory process cascade begins. And you can see how he started very small. I'm going to skip this. It is the histo of it. You can see this, all the inflammation here, the neutrophils and lymphocytes around the hair follicles, they become destroyed. So the hair follicle shafts are gone. You'll see in the beginning, dermal fibrosis here at the end, and you just see all this deposition. So management, there really is initiated at the first time of diagnosis. Get them early. It's shared decision making. And then the goal is to manage patient expectations, patient education, multifaceted approach. And unfortunately, there's no cure. So this is what here's a algorithm of it. For mild disease, mild keratolytic agents to soften the coarse hairs, topical steroids, oral antibacterial agents when they're inflamed. Moderate disease are steroid injections. Bleomycin and 5-FU now are being injected in conjunction with steroids. Cryotherapy, again, often limited by pain and hypopigmentation in dark skin patients. And then in severe disease, it's surgical excision, CO2 laser, and superficial radiation therapy. And that's what he had. So he was, based on tumor size, they decided to do a 2-stage excision, and they cut the whole thing out. It's got to heal by secondary intention. And then you have to be careful because this guy tends to scar and keloid, so you have to watch it closely, sometimes putting in IL Kenalog into the base if you see overgrowth of keloidal tissue. Based postoperatively, look at that. Not bad, pretty good. So the other thing is, what we've done now is superficial radiation therapy is being added. So you cut it out, and then you send them right away. So like in my clinic, we're doing that right now. We have a patient scheduled for an excision, And he's going right away that day, right to radiation therapy, oncology, and they'll treat it. So in summary, we discussed 4 common or uncommon presentations, retreatment modalities, and some disease nuances and histological findings. Thank you.
Just to see what my audience is, who are family medicine people here? Raise your hand. Okay, great. Who are internal medicine people? And derms? Okay, great. Okay, thanks. I know who to target. Who are students? How come they're not here? Okay, all right, so we're going to get started. Okay, so hopefully we'll pick up some tips. Okay. So it's to try to target the common disease processes and see what you can add to your treatment plan. Okay, so for acne, a lot of people come in for acne if you have a teenager or even adult population, and there is a lot of combination treatments, and usually we start with topical treatment first. Topical treatment and combination topical antibiotics. Usually we like topical clindamycin combined with benzoyl peroxide gel, or topical erythromycin combined with benzoyl peroxide gel, so that you don't run into antibiotic resistance. And these are usually spot treatment, whereas the topical retinoids is only used at night. They get deactivated by sunlight, so we only want a small green pea size at night only, and that takes 6 weeks to work. So a lot of teenagers, they get upset after using 2 weeks. They're like, oh, it didn't work, okay, so I'm not gonna follow up. So I always tell them, well, if you put in the homework, you will get the results. If you don't, you're not gonna look good. Also, hormonal acne is in an older age group, middle-aged females, so they can be started on spironolactone or birth control pills, and they have very good results with it. And then, of course, patient counseling is very important. So we take before and after photos before they show up to teenagers. And I tell them, well, if you go to school, if you do the homework, you get the benefits, just like acne. If you don't do the homework, you don't put on the creams, don't take antibiotics as required, you're not going to see results. And we take before photos, come back 6 weeks later, we can show you improvement if you're using your medicine. And that's done in front of the parents, because the parents are the ones that will judge you as well. If they come, pay the copay, go to a visit, they don't see any results, then you can say, did the kid use the medicine or not? That way, you don't get the blame, okay? All right, so why did I start out with acne first? This is a very nice young man, 16 years old. He was in pain. He cannot even walk. He is afraid of doctors. So his mom made him come in. It's pustular cystic acne. Of course, #1 drug of choice is Accutane. But due to insurance reasons, you have to try on a little bit of oral antibiotics, fail 3 topicals, then you put on it. So the thing to do is get all the blood work ready, tell them about Accutane, and then do 2 weeks of oral antibiotics, 2 topical antibiotics. You can push it through with the authorization with the insurance. And he was afraid of blood draws. You're supposed to monitor them once a month for blood draws. So I had to deal with him. You get a baseline blood test, everything's A-okay, and you get a blood test 1 month later. I will keep you on the same dose for the entire duration of action. You don't have to take any more blood tests. And then he was okay with it. And this is no scars, and now he's able to walk. He really could not walk, okay? So that's why I talk about acne first. So obviously, there are primary cares who are very comfortable doing isotretinoin, but if you're not comfortable, you can refer to a dermatologist. Okay, so what else can we do? If somebody refuses to do topical treatment or just doesn't want to do anything, but the parents can choose other options, you can talk about light chemical peels with salicylic 20%, Jesner's, Mandelic. These are very inexpensive. Delasco sells it for $45 to $60. You just wipe the skin off with alcohol, acetone, put a small layer on. That's it. They don't have to neutralize it. They get better even with that. And from your cost, you can bill some of the insurance, or you can just give it complimentary. And then just have them follow up in a month and say, hey, if you want more improvement, maybe you ought to add some topical treatment or oral treatment. Also, acne surgery, extraction, either by the physician or the esthetician is also an option. Get out that sebum, cladospore. If you have access to blue light, they can just sit in front of the blue light for 16 minutes. It's anti-inflammatory. You don't have to add the expensive ALA acid. And it's very safe for pregnancies. Pregnant mommies, You're very limited for what you can do. You just put them in the blue light. I have them come back once a week. I don't charge them extra. I just charge them a medical copay, and that's it. Of course, they can self-pay for photodynamic therapy, which is more expensive. Put the AOA acid on there, and then activate it with the blue U. And that takes a series of 3 treatment. And that's a little bit outdated because we have now the acne laser. The acne laser has been shown to shrink oil glands permanently, whereas the photodynamic therapy is just a Band-Aid until they get through the puberty years. But of course, this is a price tag. It needs 3 treatments, $3,000 to $4,500. Needs 3 treatments, and the results are better than Accutane, but not 100%. So if someone's willing to pay that, they have to know that it is better than Accutane, but not 100%. Of course, isotretinoin paid for by insurance is good, and then spironolactone. I usually start off with 50 milligram pills in females, and I can go up to 200 milligrams, and it works very well. It works to clear up the acne. It works as a water pill. They have a little weight loss. These patients love it. They will come back every 90 days and see you. You just check a creatinine level once a year. Just make sure the kidney is good. And of course, they should not get pregnant while on it. Okay, so Accutane, there's a registration, government mandatory registration program called iPledge program. Usually dermatologists do it. They know how to do it. Some family medicine are on. Some PAs like to do it. So the isotretinoin, when I start someone on it, I get buy-in from the patient and the parent. They require monthly visit. They require supposedly monthly blood tests, and they should stick with the same provider for the duration of time. It's based on weight. If not, you can run into trouble. And I tell them nothing is 100% in medicine. It's only 40% cure rate after the end of the treatment. 30% their oil glands responded partially. It shrink the oil glands. They can have a lot of improvement, but not 100%. And 30% poor response. So majority is 70% improvement. Monthly fasting blood tests, it's not needed. A lot of dermatology literature shows you can do baseline blood tests and 1 month later, and depending on whether or not you trust a teenager, you can do it sporadically, or if you do adjustment in dosage. Female patients, however, have to get monthly pregnancy tests. That doesn't have to be through blood. It can through urine pregnancy. They can answer the questions in the office to make sure they're not pregnant. They are on 2 forms of birth control if they're sexually active. It saves unnecessary phone calls later and chase them down. And the female patients, their prescription has to be picked up 7 days from the time you send in the prescription. So there's a lot of chasing back and forth if you don't do this part. Okay, so, okay, hold on 1 second. Okay, so these, so why do I treat acne? Why do I like acne? Because I don't want to have people come in with acne scars and then they have to pay for treatment with me. This is after 1 treatment with laser, combination treatment, laser, subcision, use a little needle, break up the scar underneath, and also sometimes I inject it with exosomes, I inject it with PRP, the blood in there. This is another patient, and this is all 1 treatment. They know they need multiple treatment. A female, older female, and this is after 1 treatment. This is with a pico laser. Nothing else is done. Okay. Okay, so second condition, eczema, very common, okay? So the most common take-home point is moisturizer, moisturizer, moisturizer is a key. Without that skin barrier, the skin goes into inflammation mode, they start having itchy rashes, okay? The preferred treatment of choice, number 1 is steroid injection, topical steroid. If you use a very strong one for 2 weeks, nothing's gonna happen. They're not gonna run into issues. It's just if you give a lot of refills, 5 refills, yes, and they will give it to the parent, they will give it to the siblings, they will give it to everybody else, and that's when you can run into issues. If a uncontrolled eczema takes place, you can consider patch testing to see if there's anything in the environment making it worse, okay? And gentle skincare, don't do too much showers, it dries out the skin, fragrance-free cleanser, and avoidance of any harsh fabric, okay? These are just some moisturizers I recommend. Oh, sorry. So this is a very easy, it's a spray-on moisturizer. Even a 90-year-old can spray their skin twice a day. It takes less than 1 second. It's very quick. And then these are other ones. There's so many on the market. Okay. Okay. Okay, so number one thing for eczema is pruritus control. You have to control the itch. If not, they are very, very itchy. I like to give oral antihistamines. And I do a higher off-label dosage. Zyrtec Claritin Allegra on label is 10 milligrams. But off-label usage is up to 40 milligrams a day. The study submitted to FDA was every 6 hours. So you can tell them, as long as you have good kidney function, you can take one in the morning when you feel itchy, wait 7, 8 hours. If you're not itchy, you don't have to take the second one. If you're itchy, take the second one, and then reserve the last one and the one next to that right before bedtime. So you can take up to 40 a day. And the allergists are telling patients all to do that, and some dermatologists. The other antihistamine pill I like is doxepin, the strongest antihistamine there is. I start with 10 milligrams QHS at bedtime. It makes them sleepy, and it makes them not itch in the middle of the night, which can aggravate the eczema. Maximum dose is 25 milligrams, okay? Also, very important, decrease hot shower, 5-minute showers, no steamy bathroom, short shower time, maintain the skin barrier with moisturizer a couple times a day, humidifier. Now, there was a Hong Kong female young nursing student, in 2018. She was studying to be a registered nurse. She killed her parents and killed herself because she could not stand the itch from the eczema. So that's why I think pruritus control is very, very important, in addition to the other things, okay? Okay, skin cancer prevention, okay? So prevention is, of course, very good. So tell them avoid sun, you know, get regular skin checkups, come in, and anything that looks suspicious, biopsy or send to a dermatology provider, you know. Okay, so anesthesia tips. So this can apply to any minor surgery procedures you do in-house. I usually like to do 1% lidocaine with epinephrine combined with 8.4% sodium bicarb at 10-to-1 ratio. So 10 ml with 1 ml of bicarb, or you can decrease it based on ratio. This cuts down on the stinging sensation, so it doesn't sting the patient when you stick them. If the patients are very phobic, you can order a topical anti-pain, topical anesthesia at the pharmacy. They can place it 1 hour prior to procedure, have them wrap it with saran wrap. That's called the occlusive dressing method. It makes the numbing much, much more pleasant. And you unwrap them when they get here. I use vibration tools. My nurse, let's say if I biopsy something on the right cheek, my nurse would tap on the other side. It distracts them. It's the gate theory. And then I just do my biopsy, and then my nurse keeps tapping them. It's a very inexpensive way. And also the squeezy ball is very important, and sometimes ice packs, you know. Do what you can. Okay, so in order, when you remove anything, lipomas, neuromas, skin cancer, you want to create the best scar. If not, the patients would not like you. So I usually, number one, I plot out my excision site by drawing it out. I would avoid obvious veins and especially nerves, and of course not over an artery. Try to do it in Blaschko's lines and relaxed skin line, you know. You don't want to do at 90 degrees, so it's going to make a very contracted scar. Avoid shaving hair. They have a few papers that shows that shaving the hair is really not necessary. If you remove anything on the scalp or body, it causes microtrauma. It can increase risk of infection. So, and also the patients hate it. Are you going to shave my head? No, I'm not going to. And then they're much more happier. Consider suture material based on the skin type for non-reactivity due to hyperpigmentation. For skin type, darker skin type, I tend to use Prolene sutures so they don't react. But for lighter skin type 1, 2, 3, you can use any type of suture you want. Also decrease tension in the surgical site. You can do undermining, do several layer closure. Just don't, you know, to save time, some people just close the cutaneous layer. That's going to have a very ugly scar. Do the subcutaneous first and then the cutaneous. You can also do little baby Botox, if you have Botox, parallel, like track marks, parallel to surgical sites. 3 to 10 units to let the site become very immobile. So they did several papers on thyroid scars. Thyroid scars are right in the middle, people can see it. So they would inject on parallel little baby Botox, and the scar turns out much better. Also, the other tricks are you can do compression, have them wear do a compression dressing on the site. You can do steri strips to decrease tension, avoid sun, avoid heavy exercises for 24 hours. Okay, so this is an example of my surgical patient. So this is a subcutaneous soft bump on the forehead in a young lady. So, and I know it was lipoma. I cut into it, I saw the yellow fat, so I make a very small cut, and I do my very rough pressing down on it. Squeeze out the lipoma. You don't need to make a very big line. Squeeze it out, and then do closure. And my nurse did this is on the day of their suture removal, already removed the steri strips, and I tell the patient, extra credit if you can do compression on it every night for 30 nights. That's gonna flatten the scar. And of course, if they're not happy with the scar, I would do the Candela V-beam post-dye laser to stop the redness, and the scar looks really good. Okay, all right, so these are other scars that I've done too. This is a young girl that went into the ER, got repaired by my friend, the plastic surgeon, but still have a little redness in the scar. And this is a month later. I just did one treatment of the V-beam, which is the post-dye laser. And then I also smeared Kenalog on top, steroids. So you don't have to inject Kenalog. You can do the laser and smear it on, and it looks pretty nice. So this is an indented scar from a previous acne pimple. So this is a very simple method. This is, and you guys can all do it. This is intralesional 1 ml saline. You would do 1 ml saline in a 1 ml syringe, stick it in there, and just do a little baby subcision with a 30 gauge needle and inject it with saline. I'm sorry. And 1 month later, your micro injury stimulates collagen production. It will fill in the dent, and you tell the patients, I'm not charging you, it's free of charge, but you may have to come back a few times, because it takes a few times. This is just plain saline, injected. Nothing else was done. You don't need a fancy laser, you don't need anything like that, just an intralesional saline. Okay, so sometimes patients come in, they, in addition to the medical, they ask about anti-aging questions. So I usually tell them, well, this is a medical visit. If you want to go into detail, you should pay for a cosmetic consultation. But, I don't want to make the patient get upset with me, so I group it into 3 discussions. Basic discussion, less than 1 minute. If they really want to talk, AM, use a broad spectrum sunblock, SPF 30 or higher. It's over the counter. PM, use a moisturizer with hyaluronic acid. That will moisturize your skin, Neutrogena, CeraVe, Cetaphil. And then if they are very fancy, they can do a little topical retinoid, which is very cheap. It's made by Neutrogena or ROC, CeraVe. My preferred one is the Skin Better Alpha Red Overnight Cream. It does not cause, they won an award, it does not cause irritation, and it doesn't cause redness, burning, itching. And everybody that buys 1 tube, they buy a 2nd tube. There's also an intermediate discussion. If the patient doesn't want to leave and is sitting there still, so I would say, okay, less than 5 minutes, let's talk some more. In the morning, you can add vitamin C, peptides, growth factors, topical creams. You can do exfoliation, diet, laser, peels, baby Botox. And usually they're okay. And then if they're like, what else? Then they do have to do a cosmetic consultation, and then we talk about other things. And this is definitely not covered by insurance, but a lot of patients, they want it to be covered under insurance, but unfortunately they're not. Okay, so these are some of my pictures I show my patients. This is one treatment. This is a skin tightening treatment, very quick, newer laser, Nuvaderm laser, less than 12 hours of redness. No bleeding, nothing, very comfortable. This is another skin tightening treatment. So there are things that we can do that's non-invasive. We can also do fillers. So Sculpture was originally approved for HIV, lipoatrophy, but now we're using it for aesthetic reasons. So she has very hollows due to weight loss, and this was 3 months after the Sculpture. So it stimulates her body to grow skin. So it's a biocollagen stimulator, and it should last for about 2 years. So this is very good results. Some lip filler, it doesn't have to be very fake looking, it can be very natural. I use combination treatment. I do baby Botox around the lips, then I fill the middle part. This is also baby Botox and then filler. So it can be Used for, okay. Okay, so also rosacea is a big deal. A lot of people come in, they complain about rosacea, redness, pores. What can you do when you don't have a laser? You can do intralesional Botox. A few papers came out of Korea. You can do 10 units of Botox in saline and just inject it like little blips in the central face, just like TB tests, like maybe 10 spots over here, 10 spots, and it works to shrink pores. And that's not very expensive. You can also do microneedling, laser. So there's no topical skincare to shrink pores because it can't be done. It's illegal. It's not true. All the advertisements on TV, they can only say it's minimalized the appearance of pores by removing the top layer of the oil, but they cannot say it shrinks pores. So only a procedure can make the pores look smaller. Okay, sunspots. This is another common thing. People say, oh, what can I do for the brown spots? Okay, so primary care doctors can prescribe bleaching creams, very easy. You can order a very easy 4% hydroquinone cream. Usually it's not covered by insurance. They can get a coupon from GoodRx, www.goodrx.com, less than $50. They can use it for 2 months and with sunblock on top, and it does work, but they have to wait 2 months, okay? Or you can do a stronger formula with compounding pharmacy using the Klickman formula, which is a stronger hydroquinone with a tretinoin cream and a steroid, okay? So, so my approach to melasma hyperpigmentation, I just ordered a 4% plain hydroquinone cream for 8 weeks. I take pre-photos. I have them come back in 8 weeks later and take another photo and put it next to each other and say, oh, do you see any improvement or not? Did you use sunblock? If you did, you should see improvement, but if you want more improvement, we can talk about pico laser, resurfacing laser, chemical peels, microneedling, and if they have very resistant melasma, I put them on an oral tranexamic acid. 650 milligrams, I use half a tab per day. And then there is a maintenance phase. Even after the melasma is treated, they have to do 2 times per week maintenance, okay? These are some pictures of the laser treatment, okay? So this is after one pico laser, but he wanted to be spotless, so he paid for treatment number 2, number 3. This is another pigmentation. This is the alexandrite laser, okay? Okay, so I'm close to my talk. Okay, so I talked about these 10 tips. Hopefully you would be able to get one pro from one of the tips and can help you with your management of your patients. And these are my parents. This is Chinese New Year in a Chinese restaurant recently. My dad is about 92 years old. My mom is about 86. So we were able to get them out one time, and very much thanks to my family and the Nikon family. Dr. Hoffman's trained me in dermatology residency. I'm very grateful. And Dr. Robin Zelnick trained me in internal medicine. Extremely grateful. And all my teachers I've had since then. Is there any questions for me? But thank you for your attention.
explain what that means. So I'm going to start with talking about the limitations of traditional treatments of type 2 diabetes. Then I'm going to describe the evidence that we have to support this change and how we can apply these new treatments to prioritize taking care of protecting organ and individualized care. So the change is basically from glucose centered to organ protection and weight management. Over the past decade, the type 2 diabetes management has really shifted. And I'll tell you, when I was practicing over 15 years ago, patients would come in with, I think it stopped working, with their finger stick papers. With every single finger stick, we would be analyzing every single one and trying to find patterns and what we could do to change and improve their glucose levels, and we would be happy if there were blood stains on it because then it was real and they weren't making up numbers. So that was a long time ago, and now we don't do this anymore because our goals have changed. And the goal is now we want to prevent the short and the long-term complications of diabetes, and we want to also target the underlying cause, which is which is really excess weight. So how did this change happen? So in the 1980s and the 1990s, there were many studies that were published to try to find the effect of lowering blood sugar and how would that prevent complications. So we have one very large study, which was the UK PDS study in 1998, that showed if you lower your A1C by 7%, you can prevent retinopathy and nephropathy, neuropathy. But what was surprising is none of these studies were able to show cardiac benefit and macrovascular benefit. And they kept trying, and there was a big study, the Accord trial, which was in 2007, where they compared a group, half of the patients, the goal was an A1C of less than 6%, the other was between 7 and 7.9%, and they wanted to show that with tighter control, patients would do better and would have better cardiac outcomes. But they had to stop the study early because there was actually increased mortality with the patients who had tight control. And there were different reasons that they thought this happened. One of the theories was that they were over-medicated, they were having too much hypoglycemia, and they were also on the medication Avendia, which was thought to be a culprit. Later on, it didn't really get proven that was the case. But because of that, the FDA mandated all new medications have to have cardiac studies to make sure they are safe. And this is the figure. I don't have a pointer, but on the x-axis, you see the year. On the y-axis, you see the number of patients in these clinical trials. And you can see 2008 was that marking point right after the Accord trial. And the number of patients in these studies went up by tenfold. So we have 1 million studies now to look at. But these have been very good because not only has it shown that these medications are safe, but it also has shown that it has extra benefits that we will talk about. So the two big medications, classes of medications that came out since 2008 were the SGLT2s and the GLP-1s. So the SGLT2s, as you all know, they work by blocking the glucose transporters in the kidneys, make you pee out sugar, and then the GLP-1s work by making you secrete insulin in response to food. It also decreases gastric emptying, and there are receptors for GLP-1s all over the body. So in the brain, it decreases satiety, and it has a lot of other benefits. The year that this was approved, we have empagliflozin and dapagliflozin in 2014. And then for the GLP-1s, we have liraglutide all the way from 2010. I didn't put exenatide, which was the very first one, 2005, already 20 years ago. But that one we really don't use anymore. That was twice a day. We have semaglutide 2017, dulaglutide 2014, and tirzepatide 2022. And it's interesting to note how much they drop your sugars, because SGLT2s are quite weak. They will lower your A1C by 0.5, maybe 0.8%, and we still see so many benefits from it, even though it doesn't lower that much. The GLP-1s, on the other hand, they do have significant improvements in the A1C, even up to 2%. And the weight effect, we know also, is very different between SGLT2s and GLP-1s. SGLT2s is going to be 2 to 4%, and GLP-1s anywhere from 15 to 20%. So it's a marked change in weight. All right, so I'm definitely not going to go over all these trials, but these are the major outcome trials with SGLT2s. And the first one to come out was the EMPA-REG study in 2015, so it's already over 10 years. And they looked at 7,000 patients who had type 2 diabetes, and they also had established heart disease. And they were able to show that there was significant decrease in cardiac events, decreased cardiac mortality, all-cause mortality, and heart failure hospitalization. So this was a huge finding, and the first one to find such significant findings independent of A1C changes. Then we have the DECLARE study in 2019, so this was using dapagliflozin, and this showed mainly decreased hospitalization because of heart failure. And then we have the two studies with dapagliflozin and empagliflozin and dapagliflozin in patients with CKD. What was interesting in the studies is that not all the patients had type 2 diabetes. About half of them did not even have type 2 diabetes, and they were able to show that when they used these medications, in 2 to 3 years, they were able to show significant decreased progression to renal failure and decreased mortality from it. So these were very significant. And then we have the major GLP-1 outcome trials. So those, we have the LEADER trial, which was the first one to come out in 2014, also a large study, and this was using liraglutide. And they found that there was significant decreased cardiac events and mortality. It's important to remember that these studies were done in patients who have already established heart disease, so they are higher risk. And it's also interesting to note that these were significant findings, even though liraglutide doesn't even lower the weight so much as the others. Then we have the SUSTAIN trial, which was looking at semaglutide. This is already 10 years ago. And they also were able to show decreased cardiac events in patients that are high risk. The nice thing about the next trial, which was the dulaglutide, the REWIND trial, that one was done on patients who did not have established heart disease. So this is the only one that really shows primary prevention. And they did show significant decreased cardiac event. And then the next study called FLOW, which is a great name, checking on the kidney disease progression. And you see that that also improved in patients who had type 2 diabetes and CKD if they took semaglutide. And then the newest study that just came out was tirzepatide, just last December. And it did show that it was not inferior to dulaglutide. And there was a trend. It wasn't significant, but there was a trend for decreased cardiac events and renal protection. So I know it's a lot of information. And putting this all together, these studies, what they have in common is that they are large randomized controlled trials, and they followed patients with type 2 diabetes for 2 to 5 years, and they were able to find significant changes in these small periods of time. And these were regardless of the A1C. That was not the goal, not the focus. And they looked really at the major adverse cardiovascular events, which would be cardiovascular death, non-fatal MI, non-fatal stroke, heart failure, hospitalization, and kidney disease. So in general, the SGLT2s, they showed us that it really benefits patients who have heart failure and established CKD. This should be first line standard of care. GLP-1s also showed significant cardiovascular disease protection and renal protection. So very good data. So this is what we mean by changing in paradigm, is that we do want to prioritize reducing these cardiac and renal complications that type 2 diabetics have the goal is not really just to lower A1C, and if the A1C is at goal, we still should be using the medication because there are other effects other than the hemoglobin A1C. So we want to use them early. There's no need to be waiting and doing these stepwise. If they have heart disease, if they have CKD, you start them on the medication, regardless of what their A1C is. And then we need to push more on improving weight. So we want to early on also use medications that are going to help with weight loss, obviously in addition to lifestyle changes, but that should be a big target because we know that that's a big driver. And we want to do it based on patient preferences and their specific comorbidities. I'm going to go back now to the kidneys because it's a big problem. So about 30 to 40% of diabetics will have chronic kidney disease, and we have amazing tools that can really help prevent that. So we know that CKD, what's the definition? If you have a GFR of less than 60, or if you have protein in the urine, the albumin to creatinine ratio of above 30, and this goes on for more than 3 months, then you have CKD. So if that's the case, we have a few treatments that we can use. So I really do like this slide because the ACE inhibitors were the only things we had for decades. And now we have 4 different medications that can help prevent the progression of kidney disease. So definitely the ACE inhibitors and the ARBs are going to be first, and you want to maximize the dose as much as possible. The SGLT2 inhibitors are also standard of care in these patients, and you can start them as low as a GFR of 25. So really low, you can use them safely. You still need to monitor them closely. The other medication is called it's a hard one, finerenone, and this is a newer medication. It was approved in 2021. It works in the mineralocorticoid antagonist, and it's in addition. You are going to use it once you maximize the ACE or the ARB, that's when you're going to add it on. And it has the added benefit of blocking inflammation and fibrosis in the kidneys and the heart. So it's actually approved for chronic kidney disease and also for heart failure. It was just approved for that as well. You have to monitor potassium because it can cause hyperkalemia. So once you start it, you wait a month and you check for potassium. And then the GLP-1s come along again. They also have been shown to protect the kidneys. So this is something else that we can add, both GLP-1s. So these can all be used in combination. You want to watch them closely, but if you see that the protein in the urine is not going in the right direction, the creatinine is not, you want to be more aggressive earlier on and use all these tools. So what's the next target? We talked about protecting the heart, protecting the kidneys, and now we go back to weight management. So this is a scary diagram because it just shows all the effects that excess weight have, right? And I think sometimes we forget about how of all the health effects that it can have. So it's really the whole body. We know that it's going to increase the risk of heart disease, of stroke, kidney disease, liver disease, we're going to talk about sleep apnea, pulmonary disease, and it also increases the rate of cancer, especially breast and colon. So these are patients you really have to be more aggressive at making sure they get their screening tests. And all these parts, so it's really all the body. So that's why we have to push and try to get patients to have better lifestyle changes. It's really for their health and to prevent all these complications that happen slowly over time. The good news is that small changes in weight can go a long way in preventing a lot of those and helping a lot of those comorbidities. So 15% would be ideal, and there are studies again that show, like the semaglutide study, if you lose 15%, you can already help decrease the cardiac disease associated with it. And even 5 to 10%, it's going to lower your blood pressure, it's going to improve your cholesterol, decrease the diabetes. So we're not looking for very huge amounts. And the most important, the hardest is really to keep the weight off, because the problem is people will lose 15%, but then they gain it back. So as long as you keep it off, you will get all these benefits. So what's the average weight loss with GLP-1? So GLP-1s are the best medication that we have for weight loss. We do have some oral medications as well, but these are much higher, the percentages. So liraglutide is about 8%. That's a daily injection, and because it's not so much, we don't use it really as much. So semaglutide is going to be 15%, and this is with the maximum dosage of 2.4. And then the tirzepatide, you can get 20% body weight loss with the max dose. And then we have the oral semaglutide, which was just approved in January, and it's also the same as the injection. So the amount of weight loss, also 15% on the maximum dosage. And then the next one, which is not FDA approved yet, but it's very hot in the market and people are trying to get it off in other countries where it's available. It's the retatrutide, and it's a triple. It works on 3 different receptors. So we have GLP-1, GIP, and glucagon, and the weight loss is the highest we've seen with any medication, from 24 to 26% weight loss. And this is close to what we see with bariatric surgery. With a sleeve, you may see around those numbers, between 25 and 30%, so pretty close. And this can definitely be used also with bariatric surgery. So very, very impressive numbers. So then this brings us to the other organ we need to pay more attention to, which is the liver. So this is a very hot topic because it's very common, and we do have treatments for it, and we need to realize how serious it is. So the fatty liver is defined as having over 5% fat accumulation in the liver, and it's not a result of too much alcohol. We do know that patients with type 2 diabetes are much higher risk for having fatty liver if you have central obesity, and that's why it's so important for us to be measuring waist circumference. We can't just go by BMI now, because you can miss a lot. You either underdiagnosed or overdiagnosed, so it's important anybody with a BMI between 25 and 40, you should be measuring waist circumference. And we know that that, again, increases the risk of fatty liver. Then we have high cholesterol, PCOS. There's definitely a genetic predisposition, and some people are much more likely to develop liver fibrosis more quickly than others. Smoking, sedentary lifestyle, being older than 50, all of these are going to increase your risk. And over 30% of the population in the world has fatty liver, which is now the new term, the metabolic associated liver steatotic liver disease. So this is an important slide, because when we think of fatty liver, we think about the liver, and we think what can happen. The liver, once you start with the fatty liver, it progresses into fibrosis, and then it can progress into cirrhosis. And about 30 or 40% of these patients can progress. Liver cancer is actually quite rare, 1 to 2%. The biggest mortality that happens associated with fatty liver is really cardiovascular disease and kidney disease also. But cardiovascular, if people have increased mortality, it's going to be because of that heart disease. So that's why we really need to work on preventing and helping prevent the progression of liver disease. So how can we do that? Again, if you have type 2 diabetes, your risk of having significant fatty liver is much higher. So how should we screen these patients? So there's a very simple way. Every diabetic should have a FIB-4 score calculated. It's very easy. You go on MedCalc, you enter 4 numbers. It's their age, AST, ALT, and platelet count. And if your score is less than 1.3, you're low risk. If you're higher than that, then you should be checking them for fibrosis. And you can either do that with elastography ultrasound, which is a FibroScan, or you can do the ELF blood test, which is also a good tool. But it's really important to evaluate these patients, because we do have medication that is approved now. So in 2024, resmetirom was approved for the treatment of fibrosis. Once you get elastography and you have the fibroscan, it gives you, there's 4 different stages of fibrosis, and if you're in stage 2 or 3, then resmetirom can help and it can actually reverse it. And GLP-1 now, semaglutide is also approved for the treatment of MASH. So we do have treatment, and again, very important to make sure we catch these people early. So in summary, we want to, I was going to say forget A1C, but no. We want to lower still the A1C, but that shouldn't be our target. We also want to make sure that we're preventing the complications, which are going to be cardiac, renal, and liver disease. We want to approach early. No reason to start, lifestyle first, then metformin, and then years later, the GLP-1, it should all be now. There's no reason to wait. You can always take off if something changes, but the earlier you do it, the better. Medication choice, if you take a good history to know the comorbidities, and that will help you decide which medications are the best to use. And we want to also focus on beta cell preservation. The GLP-1s do help with that too. And the expected outcome is we want to really try to put these diabetics in remission. And it's possible with these new medications that we have. And we want to improve mortality and all the complications. All right, so this is the last slide. Summary, we want to use treatments again that reduce cardiac events and kidney disease. SGLT2s and GLP-1s are the biggest for that. We want to focus on the renal protection. Remember those 4 pillars, ACE and ARBs, SGLT2s, finerenone, and GLP-1s all have shown clinically in large trials to help prevent that progression. We want to focus on weight management. GLP-1s are a great option, but remember they need the lifestyle changes as well. We need to really keep getting everybody to exercise. That's another big one, to be moving at least half an hour every day, 5 days a week, if you want to try. And screen patients for liver disease. FIB-4 score is an important, easy tool to have, and individualize the treatments. You want to base it on the comorbidities and also their preferences. Thank you very much.
Are there any questions for Dr. Romeo?
Thank you very much. A quick question. When the patients use this GLP-1, what I see is glucosuria with the normal glucose level in blood. This is an explanation for that. And the second question is, because not all the proteinuria that we see is related to the albumin, do we have to pay attention to the rest of the proteinuria that the patient is presenting?
So good question. We do expect the glucose with the SGLT2s, right? That is known, like that's going to be very high. With the GLP-1s, it shouldn't be high. And then with the protein, I mean, if the albumin-creatinine ratio is elevated, that's enough to treat. Like you don't need to know, I mean, you still want to do basics, especially if it's not responding to treatment, right? You still want to do imaging and check, but it's still protein that shouldn't be there, and we know it's going to be the diabetes and the high blood pressure, right? It's going to be both. But we need to be more aggressive at checking and following them and making sure it's going in the right direction. Thank you.
Any other questions? Well, another big round of applause for Dr.
Thank you. Thank you.
You made me sound a lot better than I am. So first of all, I want to let you know I'm going to be using note cards because my ADD will have me talking about basketball if I don't stay focused. So please bear with me. But first of all, good afternoon. Thank you for being here. I always like to acknowledge when I'm speaking to physicians getting CE credits that you may actually be passionate about the topic, or you just may be here because your board of, or your licensing board may be requiring you to be here. But either way, I hope you actually walk out of here with some useful tools and that this is very useful for you. I also know the reality of primary care. You're expected to manage diabetes, hypertension, and the patient that comes in with a 3-inch stack of supplements that they found from TikTok, all in a 15-minute visit. Somewhere in there, you're also supposed to find if someone is or may not be, sorry about that, dealing with substance use. And the reality of what today is, because the truth, primary care docs are often the first in healthcare who have the opportunity to catch substance use early. But it's also one of the things that gets missed the most. And I say this not just as someone who works in addiction treatment today, but someone who grew up as son of a doctor, worked in wealth management, and on the outside looked like everything was perfectly fine. But personally, I was struggling with addiction myself. The reality is a lot of people who struggle are exactly the people we don't expect. So today I want to cover 3 things. Why substance use disorder is often missed in a primary care setting, what signs a doctor can look for in a busy clinic, and how primary care can be the first line of defense. So the number I want you to focus on this slide is 3%. 21 million Americans are going to have a substance use disorder this year, and 3% of them will be diagnosed in the primary care setting, with that variance of 21 million going up at least 7% a year. Now, it's important to know why that 3% is where it's at. Obviously, one of them is going to be time constraints. Of the 500,000 primary care doctors in the United States, only 12% are routinely screening for substance use beyond the basic alcohol questions. Oh, let's go there. Time constraints are the biggest issue, with most visits lasting 15 to 20 minutes, and it leaves very little time to screen for substance use disorder, which often takes a backseat to major disease management. Now, it's also important to understand substance use disorder does not discriminate who it affects. For example, healthcare workers have a high rate of substance use disorder due to stress, and they also have a lack of treatment due to stigma. Now, also in my case, I guess I could have fallen under the professionals when I was in wealth management. I had a substance use disorder when it came to pain pills. Again, it doesn't discriminate who has substance use disorder and who does not have it. Now, these are some of the cues that you can actually look for when you're screening for a patient or when there's a patient in front of you. You're going to have the typical one where you can look at their ER visits, lost prescriptions, or needing to fill their prescriptions a little bit quicker than normal. Social withdrawals when it comes to relationships, losing friends, changing their relationships with their friends. And then obviously you're going to have the physical indications like needle marks, track lines, pupil changes, bloodshot eyes, odor, poor hygiene, things of that nature. This is just a little bit on my story. As I mentioned, I was a doctor's son. In my eyes, I didn't have a substance use disorder because I didn't have a needle in my arm. I wasn't behind a dumpster. I had a house. I had a good job. I had a wife. So I didn't think I had a substance use disorder. I thought I could stop at any time. But when I tried, I could not stop. So again, it doesn't discriminate who has substance use disorder or who does not have it. Now, I want to talk a little bit about some of the pathways that are available recovery is not linear. So what works for me isn't going to work for Dr. Foti. What works for Dr. Foti isn't going to work for Dr. Papia. In a lot of cases, 12-step is going to be your, I guess, your gold standard. Everyone, a lot of people, most people that come into substance use treatment are going to go through a 12-step treatment program, which it's human nature to want to grab onto something, hold on to something, and that's what 12 steps offers. It's something much greater than them. It gives them something to be a part of. There's also smart recovery, which smart recovery is kind of the same concept of 12 steps, but it doesn't have the complete abstinence baseline that 12-step does. And then you're going to have your behavioral therapies like CBT, DBT, and motivational interviewing. Those are just therapy techniques. And then you're also going to have medication-assisted treatment. Now I'm going to go over a couple of the medication-assisted treatments that are available for two different substance use disorders. One of them being opiate use disorder and the other one being alcohol use disorder. Now, a lot of you may know what Suboxone is. Suboxone is used for opiate use disorder, and it has kind of two different things that it works on. One of it is it helps with cravings, and it helps with kind of tricking the brain into thinking that it's getting what it wants, because it is a synthetic opiate. So it does trick the brain into thinking that it has what it wants, and that allows someone to actually focus on their recovery and go back to 12 steps or go back to their cognitive behavioral therapy and really work on what was lost during addiction. There's also, outside of Suboxone, there's Vivitrol. Vivitrol is used for long-term cravings. Most people, or actually all people, when they get onto Vivitrol, you have to be at least two to 3 weeks off of all substances, whether it's Suboxone, methadone, or illicit substances. Otherwise, that'll throw you into precipitated withdrawals, and that is absolutely no fun. That is every single withdrawal symptom all at once, and it is god-awful. So when someone is getting onto Vivitrol, you're going to make sure that they're at least 3 weeks off all maintenance medication or illicit substances. Now, when it comes to alcohol use disorder also uses Vivitrol for cravings, and there's also Antabuse. I'm not going to try to say the pharmacological name because I will mess it up, but it's Antabuse, and what that does is that gets someone sick when they're starting to drink. So they take that medication, they relapse, they start to drink, they're going to throw up pretty much instantly. I hear that's god-awful as well. Now, these are just some of the things that you can do when it comes to integrating things into your practice in a primary care setting. Obviously, knowing the screening techniques of DATS and audit, which are two different screening techniques outside the normal how many drinks do you have a week. Also having a warm handoff protocol for someone that does screen positive for a substance use disorder is key. Making sure you have community partners that you can work with, such as inpatient treatment centers, outpatient treatment centers, MAC clinics. Having those readily available is going to be key, because when someone does want to accept help, it doesn't last long. They might not want to do it if it takes more than 24 hours. They might revert back and go to what they know best. And I can say that has happened with me multiple times when I was trying to get clean. I was offered help many times, and I decided I didn't want to do it because it was taking too long, and I did not want to go through withdrawals, so I wanted to feel better, and I just went right back to what I knew. Also having ongoing monitoring as far as having set up drug tests when they're in programs. That's also going to be key. And then ongoing training and support. That's going to be key as well. I know most med students, when they're going through med school, they get anywhere from 8 to 12 hours of substance use when they're in med school, and that's across all 4 years. And that's also another key as to why substance use is missed in the primary care setting a lot of the times, because there's not much training on it. And I also do believe that there is still a stigma when it comes to substance use disorder. And again, I think that just goes back to the lack of training around, not just when it comes to healthcare, just in general. Again, I grew up thinking that someone with substance use disorder was someone that was homeless, living behind a dumpster, that had a needle in their arm, didn't know any better. So I think that education is key as well. So I know it was a little quick and a little shaky at first, but do you guys have any questions, any thoughts? I think that being able to properly screen while having a patient in front of you is going to be key. As I mentioned, the DATs and the audit, those are two of the quickest ways, and if you're familiar with those ways, that 15 to 20 minute visit with your patient, you'll be able to ask those questions because you'll be able to get those questions implemented in just a normal session. Any questions, thoughts?
about what I've learned from some of my professors that are in this room, someone who wrote the textbook that I used in medical school. It's intimidating, but also very much a full, no, Dr. Dowling, please. It's an honor, if anything, very much so. So very full circle moment to now have my students here listening to me. All right, so today I'm going to be talking about OMT for the busy internist, specifically in the hospitalized setting, and how a hospitalist can very easily bring in osteopathic manipulative treatment to many of the bread and butter cases that we see in the hospital. So no disclosures to report. So our learning objectives to describe the foundational principles of osteopathy and their relevance to internal medicine, identifying common clinical scenarios in which osteopathic manipulative treatment may enhance patient care, evaluate the evidence base supporting OMT in internal medicine practice, and apply practical strategies to incorporate osteopathic approaches or referrals within a busy internal medicine workflow. So wouldn't be here, of course, without the very great Dr. A.T. Still. And for those who may not know, or maybe this is just a nice refresher for medical school, remembering that some of the tenets that I'll be touching on today, right, one being that the body very much so has an inherent ability and tendency to want to heal itself, structure and function being interrelated, and of course, mind, body, and spirit is how we approach osteopathic principles in practice. So one thing that I'm going to touch on here, and I'm really going to be focusing on today, is about the autonomic nervous system and how the interplay between the viscera and the soma of the body really produces a vicious cycle that with osteopathic manipulative treatment, we can break and promote healing and then allow the body to heal itself. So talking about the sympathetic chain ganglia as well as the parasympathetic supply to our viscera and how we can not only diagnose but treat very common conditions of our visceral organs. That relates us to what is defined as the viscerosomatic reflex. So it's been found that when we have a visceral organ in a diseased state, a viscera that is inflamed or perhaps enlarged and stretching that capsule because of the inflammation, that sends signals along the sympathetic afferent nerve supply to the spinal segment that is associated with the sympathetic supply to that viscera, that then sends signals to the inner neuron within that segment to the efferent motor fibers and sympathetic efferent nerve supply to the soma, so the musculoskeletal system at that spinal segment, creating hypertonicity and acute tissue texture changes there, that being bogginess, hypertonicity, increased moisture of that level. So what does that do for us as practicing internists and osteopaths, right? So it's a diagnostic tool, and we can support and really reinforce our diagnostic approach to a patient by also finding these findings. Also, we can go with the Chapman's points, being a form of a viscerosomatic reflex as well to help our diagnostic capabilities. But we have to also understand is this creates a vicious cycle because this then turns into a somatovisceral reflex. So essentially, what in turn occurs is due to the somatic dysfunction that can occur because of this viscerosomatic reflex, signals are then sent back along the sympathetic efferent fibers back to the viscera. And as we know, as practicing osteopaths, is that hypersympathetic tone to the viscera is detrimental to its healing. It reduces perfusion to our internal organs and viscera in favor of the soma, and is deleterious to its healing process. So by treating somatic dysfunction at those levels, we can break that chain and allow our viscera to heal even further. So that's what I'm going to be talking about in a bit. So to talk about it within the confines of a case number one, COPD exacerbation in an inpatient ICU setting, a 72-year-old male admitted for COPD exacerbation with increased sputum production, wheezing, and accessory muscle use. So where our targeted OMT would be is respiratory biomechanics as well as achieving autonomic balance. So potential diagnoses that you might find in such a patient would be restriction at the thoracic inlet, whereas we know if there's increased fascial tension along the Simpson's fascia, this is where the major lymphatic ducts drain and can impair lymphatic drainage. Of course, in a patient with COPD, they have inhaled ribs with reduced ability to expire or exhalate the air within their lungs. So they find an inhalation somatic dysfunction of the ribs. as well as, especially if there's accessory muscle use, scalene hypertonicity, as we know, the anterior middle scalenes, activating the upper ribs, right? So a targeted approach here could be to ensure that there's proper vagal output and that there's nothing impeding parasympathetic supply to the lungs, right? As we know, parasympathetic supply to the lungs coming from the vagus nerve, exiting in that suboccipital area. So if we have a patient admitted with COPD, and again, many of these techniques are going to be done supine, of course, because of the acutely ill state of the patient, we can evaluate that suboccipital region for any increased tension of the suboccipital muscles and any increased fascial tension as well. And by treating that area, achieve autonomic balance and increase vagal output. So, especially for those who were just in our OMT workshop, I did talk about this a bit, but suboccipital release involves finding that suboccipital region, allowing our hands to rest in that area, and creating a direct parallel stretch of that suboccipital area to reduce fascial tension and hypertonicity. So what's the goals here? Again, increasing vagal output to the lungs will thin secretions, allow the patient to expirate their sputum production even easier, because often in these states, the sputum is quite thickened, right? As well as increase perfusion to the lungs and improve lymphatic return. So again, this, as you can see, is a technique that can be done very easily in a supine position for an acutely ill patient. Another technique that could be done, again, in the supine patient is our thoracic inlet release. So again, as I mentioned, the thoracic inlet, which is formed by the clavicles, first rib, and then the first rib articulating posteriorly at T1. Immediately to that, we have the Simpson's fascia, through which our major lymphatic ducts pierce and then drain. So to improve lymphatic drainage, we want to make sure we can assess and treat the thoracic inlet. Now, this technique has direct and indirect approaches, but in a patient who's acutely ill, I'd recommend the indirect approach, where you would assess 3 different planes of motion, that being flexion, extension, distraction and compression, as well as side bending, and finding the eases of motion along the thoracic inlet, and then stacking those 3 planes of motion along the freedoms. And in so doing, releasing the fascial tension along the Simpson's fascia. So another technique that can be performed is an indirect release of the thoraco-abdominal diaphragm. And there's several important caveats here. Remembering that the diaphragm is a very important pump of lymphatic return as well as venous return. And of course, in our patient with COPD who is in an inhaled state, this can help reascend the diaphragm into exhalation. Now, the direct approach to the thoraco-abdominal diaphragm release involves placing our thumbs along, inferior and along the costal margin, which may be uncomfortable for an acutely ill patient in a COPD exacerbation. So I'd recommend the indirect approach, placing one hand anteriorly and posteriorly along the diaphragmatic attachments, feeling for ease of planes of motion. I often employ kind of a counterclockwise approach to that. And once you find the eases of motion, stacking those. And what you'll find is that oftentimes the breathing will slow and deepen, exhalation will improve, and oftentimes you might even find that the eases will ease up even more, and we often encourage you to follow that motion until you achieve a full release and deepening and improve in exhalation, specifically for a patient in COPD exacerbation. You also want to remember the sympathetic supply. So the sympathetic chain ganglia that run from T1 to L2, specifically for the lungs, we're talking about the T3, T4 area, right? If there's, again, hypersympathetic tone, this is only going to serve to thicken secretions and reduce lymphatic drainage rather. So a way that we can target that is, again, another supine approach for the acutely ill patient being rib raising. Of course, this can be done seated as well, but for our acutely ill patient, we would do that in the supine position. And what it does is, by articulating or disarticulating rather the ribs from their costotransverse articulations, this serves to do a few things. One, what has been found is that by bringing the rib heads into connection with the sympathetic chain ganglia, that has been found alone to reduce hypersympathetic tone. But by creating this disarticulation of the ribs away from the thoracic spine, it also improves rib biomechanics as well. So it serves 2 functions: to reduce hypersympathetic tone, as well as improve rib biomechanics, in this case, in a patient with inhaled ribs, to increase exhalation for the patient, which would reduce air trapping in a patient with COPD. Case number 2. Another common condition we'd see in the hospital, heart failure with reduced ejection fraction. A 64-year-old female with heart failure and reduced ejection fraction presenting, brought in by EMS with shortness of breath, lower extremity pitting edema, and elevated jugular venous distension. Diuresis was initiated with good response. So in terms of targeted OMT, we want to improve lymphatic flow and congestion, as well as achieving autonomic balance. Some potential diagnoses you might find in such a patient would be diaphragmatic restriction, hepatic congestion, as well as impaired lower extremity lymphatic drainage. So again, I won't go into it fully, but again, this would also help here, of course, because by releasing fascial tension in the Simpson fascia, this would improve lymphatic flow and venous drainage. Direct thoraco-abdominal diaphragm release, helping for the same reasons as well, remembering that the thoraco-abdominal diaphragm is serving as a pump for venous return and lymphatic drainage. A few other techniques is for the edema that occurs, the hepatic congestion from the right-sided failure that occurs in heart failure with reduced ejection fraction, as well as the peripheral edema. So looking at the bottom image there, that is addressing the hepatic congestion. That is a lymphatic pump technique. Again, that can be done supine. And what it serves is to create a pump-like push and flow of hepatic congestion and improve and basically encourage venous drainage from the hepatic vein into the IVC and reduce that hepatic congestion that the patient may be having. And then the above image is what we call our pedal pump, because oftentimes, of course, our patients have lower extremity edema. And again, in a supine patient, it can be done very gently to create an oscillatory force from the feet up to the head and reduce lower extremity peripheral edema as well. What we teach in osteopathy as well is that there's several diaphragms along the body. We have the popliteal diaphragm, pelvic diaphragm, thoraco-abdominal diaphragm, thoracic inlet, and the suboccipital area at the tentorium cerebelli as well. So we can treat and release the popliteal diaphragm as well to reduce peripheral edema. And again, a very gentle release that can be done in a supine patient. So again, we can also address the autonomic nervous system and try to achieve autonomic balance in a patient with heart failure as well. Again, addressing the suboccipital area, improve vagal tone. So in a patient with heart failure with reduced ejection fraction, they have hyperadrenergic hypersympathetic tone because the kidneys perceive this as a relative hypotensive or hypoperfused state. Not only is the renin-angiotensin aldosterone system activated, as well as ADH, but so is the sympathetic nervous system. And chronically elevated hyperadrenergic tone has been found to be deleterious to a failing heart, leading to cardiac remodeling. So we know this, of course, because one of our pillars of GDMT, or guideline-directed medical therapy for heart failure, are beta blockers, which serve to block the hyperadrenergic tone. So another way we can help augment this process, along with our beta blockers, is to improve vagal output to the heart. So if there is any suboccipital tension, as I described earlier, we can improve that tone. And as I mentioned earlier again, using rib raising, reducing hypersympathetic tone to the failing heart as well, to try to counteract that remodeling that is occurring. Case number 3, a patient with chronic constipation. So 58-year-old male with poorly controlled type 2 diabetes presented with chronic constipation and bloating. So our targeted OMT here again would be to the viscosomatic reflexes, autonomic tone, and sacral function. Potential diagnoses you might find is thoracolumbar junction restriction due to the lower GI sympathetic output, sacral dysfunction due to the lower GI parasympathetic output, colonic motility dysfunction, and fascial restrictions. So the parasympathetic approach. So when we talk about chronic constipation, ileus, often this is a function of the distal 2/3 of the large intestine or the colon, which is supplied by the sacral parasympathetics, S2 to S4. So what we can do is a few things. So we can address the, and the sympathetic supply, sorry about that. So, oh geez, what happened here? My apologies, I think I got it. Thank you. The sympathetic supply as well, so I forgot to mention, being the upper lumbar area as well. So we can target any somatic dysfunction in the upper lumbar or thoracolumbar junction which supplies the sympathetic output to the distal 2/3 of the large intestine and the colon by performing, again, very gentle techniques that could be performed in a patient supine, one being the thoracolumbar paraspinal inhibition, which would, again, serve to reduce hypersympathetic tone, as we know, tone to the distal 2/3 of the colon. And in order to perform this technique, the provider basically targets an inhibitory pressure in that, again, upper lumbar area, T12 to L2 region, paraspinally, all right, so it's in the paraspinal musculature until a release is felt. We can also target the sacral parasympathetics to improve parasympathetic output to the distal 2/3 of the colon. One technique that can be done for the outpatient with chronic constipation being a myofascial technique to the sacrum, sacral rocking, in order to prove, just as a general articulatory technique, myofascial to the sacrum to improve motion of the sacrum, release any restriction, and improve parasympathetic output there. Now, with gastrointestinal disorders, there are also targeted abdominal osteopathic treatments as well. As we know, the body is a unit, right? And our fascia from our head to our toe are connected. And that includes the mesentery and connective tissue that surround our intestines. And if there's any increase in fascial tension along our gastrointestinal tract, that, of course, can inhibit gastrointestinal motility, for example. Oftentimes, when we find increased fascial tension in our gastrointestinal tract of our patients, they oftentimes have either chronic constipation, ileus, dyspepsia, depending on where you find it. So one such technique is the large intestine or colon lift. So again, this serves to reduce fascial tension along the large intestine, where the provider wraps their finger pads around the colon, again, ascending, transverse, and descending. Now, it depends. You want to find the ease of motion, whether that's towards the umbilicus, which is often the case, or away from the umbilicus, and then holding it there until you feel a release. One other technique I do want to mention that I don't have up here, so I just thought of, there's also a mesenteric release as well, where you can release the mesentery. Now, because of the attachments of the mesentery, that would be directed in all areas towards the right upper quadrant. But with similar thoughts in that you're looking to reduce fascial tension there along the mesentery in order to improve gastrointestinal motility. These are my references. Thank you very much.
Thanks, Dr. Fody.
Thank you.
Presentation. I have a question. Have you used the Chapman points along the lateral fascia just to also release for that help for constipation?
Yeah, that's great. Again, you know, the questions about Chapman's points. It's another form of viscerosomatic reflex, right? So, for just as a refresher of those, the Chapman's reflex points being kind of pea-sized, nodular-sized areas of tissue congestion due to inflammation of the viscera. Again, very similar to that of the viscerosomatic reflex, really being a form of viscerosomatic reflex, demonstrating that there might be a diseased viscera. So yeah, by treating that, similar, you're disrupting that cycle to reduce hypersympathetic tone back to the viscera, yeah.
And I would double click on that to say that you can, if you have tight IT bands, you can actually treat the, with the mesenteric lift or the viscera of the colon, and sure enough, it improves and decreases Chapman points and improves range of motion of the leg into abduction. Other questions?
I think it was very thorough. Do you ever protocolize when you're this for certain disease processes, and would it be useful to put out protocols for, say, CHF, protocol for asthma exacerbation, protocol for some typical inpatient COPD, some typical inpatient diseases that would be useful then to transmit this information more easily to other colleagues, and also including outside the osteopathic profession? And also, would you think that that would be some realm of study that we could do to validate benefit or not?
Yeah, so currently I teach these exact principles to our third-year osteopathic medical students at Touro Middletown. Each month they come back from their rotations, and we talk about how they can easily integrate this into their rotations depending on the specialty. And so that's where all this comes from, of course, if their preceptors allow. I think it'll be great, I haven't protocolized it now, but I think it'll be a great study that hopefully, going back to our wonderful presentation from Dr. Thacker, that helping us champion use of OMT in the hospitalized patient by increasing that type of procedural credentialing for our hospitalists. If they see the value in it, if they see the ease with which they can integrate this for a hospitalized patient, we can increase use of OMT, especially in that setting. So yeah, for sure. You have another question there?
Well, actually, a question here, and I got my T-Bolt mic delivery.
That is amazing. All right. As you guys know, I'm one of the laziest DOs you'll ever meet. And to do the IT band, you can actually shorten it for 10 seconds. As long as they're pain-free, the pain goes away. Inhibition only takes 10 seconds, really.
Thank you, Dr. Chen.
Sorry, Dr. Cody, I have another question.
Please.
So in the ED for COPD or CHF exacerbation, we use BiPAP.
Yep.
So BiPAP helps with the whole vagal innervation, trying to decrease the sympathetic nerve. Would you do the BiPAP in addition to the treatment, or wait until see how BiPAP works, or start with the manipulation first, provided the patient doesn't tire out?
Sure.
And what would you suggest?
Yeah, it's a great point. So yeah, and there's been thoughts about whether we should be trying to increase venous return in the acute state of a patient, for example, in heart failure with an exacerbation, right? Because can they handle that increased preload? For our students, right, why BiPAP helps with heart failure, for example, is because the increased pressure collapses the IVC, so we reduce venous return so that the failing heart can better handle it. So actually, I would say, my personal recommendation, I would say, treat with BiPAP, diuresis, do all those things first, get the preload to a point where the heart can better handle it, and then release these restrictions to just keep, that's more of a homeostatic approach. Yeah. Yeah, great, that's a great question, yeah, really good. Other questions? Yeah, we want to hear.
Do you know of any online or YouTube videos that can teach these OMT methods? Because us non-DOs are very interested, but have no experience in it. Would love to learn more. Or maybe we can start one.
I think we have an answer for you.
That was so cool. There is a site, however, for non-professionals, there are disclaimers all over the place, written by the AOA. But there is a site called yeswecanddomore.com. And it's vector-based OMM.
And I will say, for those who are here today, look out for the future. Our hopes and goals, and our wonderful new president can talk to this at some point, but our goals and hope is to increase this type of education for our NYSOMS members in terms of osteopathy. What form that comes in, I can't speak of. We're going to figure that out, but our hope and goal is to increase education in this front, similar to the workshop we just did today. Yes,
I'm not going to ask a question.
Please.
But one of my other jobs, non-paying jobs, is Secretary Treasurer of the American Academy of Osteopathy. So there are courses that are available, and physicians are welcome to come in, and they can be tiered so that beginner, middle, and a little more proficient to be able to take courses that way. And there are also some online videos that are available through the Academy. So it's called the AAO, and I can give you contact information for that.
Thank you, Dr. Foti, and really appreciated the lecture. I did something similar for my students a few years ago in terms of incorporating treatments for hospice patients and palliative kind of relief and care. As an internist,
Yeah, it's a great point. And also to add to that, you have to be able to be prepared to modify how you approach the technique. You're not always going to be able to sit there on a rolling stool like we do in our OMM lab and do all our treatments. You might have to be standing next to an IV pole or around an IV pole. And, there's a lot of, the inpatient setting is much different, as everyone can attest to. So you're going to have to modify your approach as well as how the patient is positioned as well. Yeah, it's a great point. Thank you, Dr. Thacker. Yeah. Other questions, comments? Thank you so much, everyone.
Hello, everyone. Thanks for being here. I know it's Friday the 13th at 5 o'clock, but we appreciate you here. I'm Deanna. I'm one of the risk management consultants for the downstate area at MilMIC. I've been with MilMIC about 4 years now. My background is a nurse, legal nurse consulting as well. I went to NYU, and this is like the second time, I think, right? I've been at ROC. So we thank Dr. Riley for always thinking of us and including us. And tonight I'm with Mercedes Markovic, one of our attorneys. So you want to introduce yourself now while we,
Sure.
Before we get started?
Hi, I'm Mercedes Markovic. I'm one of the attorneys from MilMIC. Been with MilMIC for way longer than I want to admit. It's been over 20 years. As counsel to MilMIC, we are there to help the insureds with in any way, shape, or form that they want. We are there for risk management purposes. We defend them in certain lawsuits and provide guidance in any manner, kind of keeping up to date with any regulations, any kind of codes that come along that are practical to their practice. We are here today. I know it's Friday and everyone is probably been here for a very long time. I like to keep it as interactive as possible, so if you guys have any questions while we are speaking, please feel free to stop us and we can address it. Maybe that'll keep everyone a little bit more interested and awake for the rest of the night.
Okay. So welcome to Managing Expectations, what to say and when to say it. Just some housekeeping. This presentation is being offered for informational purposes only. It does not constitute legal advice, and we always recommend you consult your attorney should you need assistance in any of the material presented here tonight. The statements you hear are solely ours as presenters, and Mercedes and I have no relevant financial relations to disclose. So in less than an hour, you'll be able to understand why patients sue their healthcare providers. We'll recognize and review some contributing factor trends with data analytics and take a look at some strategies both in office operations as well as the exam room to help reduce liability. By the way, MilMIC is a professional liability insurance company in case anyone is unaware. So, question of the night, why do people sue their doctors and their providers? All these reasons we hear, but there's been a lot of studies on it, and most of them seem to be like one dominant theme, and that's there could be a provider-patient breakdown, and either that's manifested in poor communication or patients' perceptions of your communication skills as well. They sometimes feel like they've been deserted by their provider. They sometimes feel like information was delivered poorly, or just sometimes they feel like their perspective, is just, not being addressed. Now, the Emergency Care Research Institute puts out their patients' safety concerns each year. And in 2025, the number one risk was the risk of dismissing patient, dismissing caregiver, or family concerns. So, it's an important topic for tonight. So when patients are not feeling satisfied from the care that they do receive, they want an explanation. They want to, hope that the same thing does not happen again. And oftentimes they do want some money or compensation for it, or they want to help, hold the provider accountable. It's important when you walk into every patient appointment, every patient encounter, whether it be a virtual visit, that you keep the top risks in the back of your mind. And sometimes this can help you provide that best care possible. And then as you build these relationships with patients, create workflows that are consistent, sometimes, not always, but sometimes it can help you sidestep the risk of legal action. So here we're looking at MilMIC and MedPro data from 2014 to 2023, a little over 19,000 cases. Now, contributing factor categories, it's not always one reason that causes patients to bring a lawsuit. It's these contributing factors, and contributing factors are those multi-layered issues, they're failures in the process of care that somehow either contribute to patient outcome, the initiation of a case, or somehow had a significant impact on the resolution of the case. You know, so often it's not that one big thing, but maybe a bunch of things that kind of lead up, you know, to the patient bringing the lawsuit. Obviously here, you know, we'll focus tonight on communication, behavior-related documentation as well, and we talk about communication documentation a lot in our educational programs. Clearly, you know, clinical judgment is the most prevalent here. 83% of the cases with 93% of the dollars paid out. Now, communication as it relates to what we'll talk about today is your rapport with your patients, building those relationships, and then behavior related, and that's patient non-adherence or non-compliance to your treatment plan. Whatever we're calling it today, non-compliance, you know, non-adherence. So that would fall under there. And most of those factors, you know, under behavior related are on the patient side. At least, you know, 93, 94% of the cases have to do with the patient behavior. And then the rest has to do with provider behavior and employee issues as well. And then documentation, like I said, you know, we talk a lot about documentation, and that would be insufficient documentation of your clinical rationale, your findings as well. And then, you know, like I said, communication, documentation, and follow-up. That's our risk management trifecta. And when you focus on those elements, you really do a better service to yourself, and you do a better service to your patients as well. And sometimes focusing on those elements will reduce or mitigate the risk of liability. Oopsie, it's all right, no worries. I'll just do it that way. So Mercedes and I will talk a little bit about setting expectations in both office operations as well as in the exam room. Once again, that risk managed trifecta is in there: documentation, follow-up, effective communication. We'll talk about literacy and limited English proficiency, and then Mercedes will get into the exam room. You know, the relationship you build with your patients, that informed consent process, that informed consent discussion, and then we'll have some risk management tips at the end. So there is a distinct relationship between patient satisfaction and the risk of being sued. Now, if anyone has a question, by all means, you can raise your hand during this, but there should be time after. So knowing how your patients rate you as a provider and knowing how they rate the practice can go a long way. You know, it really could predict, you know, what, you know, the risk of of malpractice, basically, you know, and having someone monitoring social media platforms as well to know what people are saying also sometimes can, you know, help the risk of liability. So patient complaints do foreshadow litigation, and one person in your practice really should be that designated person that's going to field all the complaints. And all your staff members should know who to go when there's been a complaint, you know, if the complaint needs to be addressed as well, whether they be, you know, written complaints, verbal complaints, complaints from, you know, third-party payers or other regulatory, you know, entities as well. When you have those, we always recommend you consult your counsel, you know, to properly formulate, you know, a good written response when it comes to these types of things. And as always, you know, those online reviews, we'll talk a little bit more about that, but you never want to go with that back and forth with the patient about any negative review that you might have gotten. Now, we can have an entire discussion about disruptive behavior, workplace violence. You know, we're finding now that behaviors are escalating a lot quicker now, you know, to violence very rapidly. And that could be from a variety of reasons. You know, patients feel pain, they're scared, you know, they have a loss of control. So it's important that we maintain respect when it comes to these things, and really, you know, alert all the providers in the practice if there's been an issue with, you know, disruptive behavior with this patient before, and you know you see them on the schedule, or you know they're coming back in, that everyone is aware so that no one is surprised by it. You know, we get the calls all the time. Sometime, you know, the patient is still in the office. It's emotional, it's exhausting, but it really can jeopardize patient safety. So now some of the things, you know, to successfully manage disruptive behavior, consider that code of conduct, you know, those clear expectations, you know, and define, you know, what is unacceptable behavior, you know, profanity, yelling, threats of, you know, legal action, threats of harm, so that all are aware. And consider posting guidelines with these things, so everyone that comes into the practice knows what to expect. And once again, if it's that patient that's coming back that has been disruptive in the past, maybe you need to consider having a chaperone, you know, in the room, or a second person in the room when they do come back. And of course, you know, if ever your staff, anyone, any other patients feel threatened, then, you know, contact the local authorities. Now, dismissing patients from care is always risky business, you know, and it's a complex issue. It might be from their, you know, you need to dismiss them because of the conduct in the office. It might be that they're not adhering to your treatment plan. So it's really a case-by-case basis. But you have to be careful. You know, that provider-patient relationship comes with legal and ethical obligation. And we don't want you to ever be, you know, under the gun for patient abandonment. So we recommend like a 30-day emergency care treatment for the patient. Of course, if you have a violent patient, you know, then there could be exceptions to that as well. And then, you know, it depends on a variety of factors. You know, you're an OB office, you know, you can't discharge your pregnant mom at 35 weeks. And then also having, you know, a place to send these patients, you know, that availability of care. It's fine down here. You go, you know, 200 miles upstate, it's not so easy. You know, you're sending your patient from your practice, and maybe the next practice isn't, you know, so close, 50, 60 miles away. So taking those things in, you know, under advisement as well. And we always recommend, before you dismiss a patient from your practice, that you consult either your liability carrier or your counsel to discuss this, so, you know, that you're covered. And social media, you know, you may be quick, you know, you see those negative reviews, it's upsetting. You may be quick to want to respond to them, but we always, you know, caution you, take a deep breath, take a step back, and you just have to be careful with the HIPAA, you know, privacy regulations. So you don't want to identify patients. With AI now, it's real easy to try and figure out, you know, who you're talking about. You know, very little identifiers can recognize people these days. And we always like you, you know, to think of the negative review in terms of all the positive reviews that you do get. You know, 90% of reviews are positive, you know, so use the negative ones as that constructive feedback when you can. Why are they complaining? Is it the wait in the waiting room? Did it take them too long to get an appointment with you? You know, was it a rude staff member? And maybe you can nip it in the bud if you get all this information, you know, before it leads to a lawsuit. And it's always best to have that safe response. You know, at X practice, we're striving for that positive patient experience. Due to privacy, we can't, you know, respond right now, but give us a call, you know, and we'll be happy, you know, to address it. Oh, now it's working. So effective communication is really the cornerstone of building that patient relationship. Patients' perceptions of their healthcare professionals' communication skills do impact patient satisfaction, as well as the potential for malpractice. So these points here, you know, effective communication is going to improve your patient experience. Like I said, can reduce that potential for liability. But, you know, just being able to employ those active listening techniques, you know, it helps you, you know, reach that accurate diagnosis, formulate that care plan, you know, addressing the patient's literacy level, and developing plans for communicating with patients that might be, you know, hearing or sight impaired. You know, having a clear understanding of office operations, it sounds very simple, you know, can help reduce those frustrations that lead to escalation. So sometimes just letting them know up front, the office hours, medication refill plans, how telephone calls are being managed, as well as those options for rescheduling. And that could help keep, behaviors at bay. Your office waiting area, that's the first place they come to when they come to see you. You want the conversations private. If a patient is upset, talking to the receptionist or checking out, you don't want to be an earshot of other patients. So then those patients are getting upset, and before you know it, you have an upset patient coming in to see you, that you weren't prepared for. And we always recommend, posting the sign, those behavioral guidelines so that everyone is aware what to expect when they come in, or adding it to your new patient pack. How you use the portal. Maybe the portal is going to be the only way in which you communicate with patients. Indications for social media and what you're going to discuss with patients as far as social media. How telephone calls are being handled, and defining that unacceptable behavior. Now, failure to manage calls properly really does impact patient care and increases your risk for liability. Your staff who answer their phone, they're critical to your practice. Often they make the first impression. So being able to, and often really, there's someone that's going to identify if your patient has an emergency need or a condition. But having a well thought out plan when it comes to telephone management is important. You want to clearly identify the types of calls, who are the staff that are going to be able to answer the call as well, and address any issues. Now, you have to be careful. You never want to put your receptionist, your medical assistant, your LPN in a position where they're triaging patients. It has to be an RN or above. So otherwise, you're going to open yourself up, for issues of, delegating authority when you shouldn't be. And of course, all those messages that come through have to get into the record set. Plaintiff's attorneys will ask for call logs, and they'll want to see how you managed that call that came through and when you managed the call. So if you're using an answering service, request the reports on a regular basis. Keep those messages according to the retention schedule. If you're still using voicemail or answering machines, we don't recommend it. There are no safeguards in the event of a malfunction. But if you really, really have to, the message has to be very clear. How often the messages are reviewed, when somebody will get back to the patient, and if it's an emergency, they got to call 911 or they have to go to the nearest emergency room. So having that plan in place, as well as, every so often monitoring it and see how it's working. And, basically, common sense things, remind people, when they are answering the phone, be friendly, identify yourself, be that active listener when the patient is talking. I know we've all been in situations where we're telling our story on the phone, and then we don't hear anyone. We've been put on hold and we don't even realize it. And then, of course, when patients are on hold, check with them. And if you can't answer the call, or if your staff can't answer the call, let them know when someone's going to be getting back to you, and then who's going to be getting back to them as well. And documenting all these things, once again, including the patient's understanding of what you told them. Now, English may not be our patient's primary language. Cultural differences may impact who the decision maker is, in the family. So taking all these things into consideration, we don't want to label someone as difficult. We don't want to make assumptions, and we don't want to document anything like that, because patients now read the notes. So limited English proficiency, cultural awareness, all, health literacy, all has to be aware when you're having conversations and you're preparing for conversations with these patients. And then you have to develop plans and instructions. Now, if you're using interpretive services, if you're using written materials, your staff needs to be aware of it as well, and what's available to them for that ongoing, teaching for these patients. Now, if your practice is federally funded, you should have a written LEP plan in place. But we don't recommend using family members as interpreters, friends, staff that's not, that are not qualified to act as an interpreter. There's differences in the translated message, those subtleties of language and culture, and medical terminology just sometimes doesn't get communicated the way it should be. And being able to document the services or tools that you use is going to help you, reduce the risk of litigation. Same thing with the low health literacy patients. Try to avoid the medical jargon with them. If you're using, verbal instructions or written instructions, you want to make sure it's appropriate for the population that you have there. We recommend, the teach back method so that all patients can teach back to you as the provider. And what's their plan? What's their plan when they're leaving? What's the patient's homework? When they leave you, are they supposed to, schedule their colonoscopy? Are they supposed to schedule the mammogram? So that they know what they're supposed to do and that you document the understanding that they have to do this. Yeah.
When you have students and residents, do you need to do, tell the patients and family members ahead of time, in my practice we have students and residents, is that okay if they treat you beforehand, before you establish that doctor-patient relation, or as things move on?
Well, if you don't have it in your office information for them to see it prior, it's always a good idea to let them know that it might be a resident, that might be a nursing student, or whoever that's going to be there. Definitely, because that's it, when they find out later, or in the event something happens, then it's really hard to reel that back in. Okay. And then, of course, those open-ended questions we all learned, rather than the yes or no questions. And we all know it's not always what we say, it's how we say it. So, we know, you can't spend a lot of time with these patients. We know that you're busy. But just being aware of what triggers your nonverbal responses. Maybe that patient is coming back in. Like I said, maybe you've seen them on the schedule. So just being able to recognize all those nonverbal cues. Be careful with your gestures, that personal space, crossing of the arms. And really, I tell this story all the time. I love my primary care physician. She's a DO. Been with her for years. We go to, I have my well visit, and the computer's in one corner, the exam table's in another. So I spend a lot of time talking to the back of her head, and she goes like this. I mean, I don't know how she hasn't had whiplash yet, but I just, like I said, spend a lot of time talking to the back of her head. I tell her I like her new hairdo and, and all is good, but we laugh about it. But really, patients just want to know that you're listening to them. They want to know that you're concerned, and that you're truly hearing them. I don't have much of a voice left, but I'm going to turn it over to Mercedes, and she'll talk about what goes on in the exam room and how you can mitigate some risk there. And if not, it's like sometimes it works, sometimes it doesn't.
I got a lot of things going on in my hands. Okay.
Hi, everyone. So first, we're discussing the anatomy of medical malpractice. So in order to have a successful malpractice lawsuit, the plaintiff's attorney needs to establish 4 elements. There has to be established a duty, a breach of duty, proximate cause, and damages. So the duty basically is created when the doctor-patient relationship is established. Once that relationship is established, there's a duty to treat the patient until that treatment or whatever is completed. So we have the obvious ones. When the doctor-patient relationship begins, you have a patient comes in for an office visit, you're called in for a consult. I just wanted to focus a little bit about those ones that don't seem so obvious. So I just had a call from a doctor who is recently retired, going on a cruise, and he called asking, what do I say when I tell people I'm a doctor and they ask me medical advice? Am I liable for the advice that I give them? And correct. So if that passenger relies on his advice as medical advice as opposed to seeking in-person treatment, and there is harm, that doctor-patient relationship can be found to be created and he can be held liable. So just think about that next time you're at a social event, you're at a dinner, you're at, the alcohol is flowing and people are asking you questions. Make sure you don't give them anything that could be deemed medical advice. They should always be calling you the next business day, referring them to someone else. I love telling people that it's not my area of expertise. You need to, focus on that area. But basically, don't offer them the advice that can eventually lead you into some kind of problems. So next we have the deviate. So it's the duty, and then you have the breach of duty. So basically, the breach of duty is established by a deviation in the standard of care. The plaintiff needs to show that there's a deviation. How do they do that? Basically, they need to find an expert in your community, in your area of practice, to say that you did or did not do something that a reasonably prudent doctor would have done under the same or similar circumstances. They need an expert to state that. They can't point to a policy procedure and say that you didn't abide by it. They can't point to a rule or reg or any type of textbook or journal. They need an expert in your area of practice. So as the standard of care is evolving, you need to make sure that your technical skills evolve, your clinical judgment is evolving, and your care. So you need to engage in ongoing evaluation of competency and procedural skills. If you are board certified, you're going to be required to complete ongoing education, periodic assessments, and demonstrate competency. You need to keep up with continuing education and journals. You need to educate patients and set expectations. Educating patients, informed consent conversations, which we're going to go into deeper later. It's not just good practice, it is part of maintaining the standard of care. You need to have that conversation with the patient, benefits, risk, alternatives, including not having the procedure done. And you need to make sure you set expectations. They need to know what the limitations of the treatment can be, what the procedure can realistically achieve, the longevity, any possible need for retreatments or another procedure. That needs to be all explained to the patient. You need to consider consultations and referrals where appropriate. Sending a patient out for a consult or for a referral is not a sign of weakness. That means that you are meeting the standard of care. You need to recognize, there's a duty to recognize your limits. If a case is complex, if a diagnosis is uncertain, if the risk level is elevated, you need to refer that patient out within a reasonable time. So we have duty, breach of duty, and then we have the third and fourth elements here, which is proximate cause and damages. So so you can have a breach of duty and no damages, there's no successful lawsuit. You can have a bad outcome, as we all know. That doesn't mean there was a deviation in standard of care. So you need all four elements to have that successful lawsuit. Again, an expert then is needed to show that it's that deviation that caused the damages claimed in the lawsuit. They are going to review medical records, past medical records at issue, future medical records. They are going to look for anything that can affect that proximate cause argument. Any type of pre-existing injury, what was done that day, obviously, damages, any type of intervening factors, any non-compliance of the patient. Economic damages, they're going to try to see whether or not basically the harm caused the economic damage claimed. Most of the time, the economic damages are loss of wages due to the fact that they were unable to work due to the harm that was inflicted. And then you have pain and suffering. Again, did that deviation cause the pain and suffering? Pain and suffering, other damages in that category could be obviously physical harm, emotional distress, anxiety, disfigurement, loss of enjoyment of life, any type of ongoing discomfort. So now we are going to discuss documentation. I know throughout all your years of practice and all your years of education, you've heard about the importance of documentation to nauseam, and I'm going to make you just a little bit more nauseous tonight. I can't express how important documentation is. It is your lifeline. First, it's going to prevent you from being even involved in a lawsuit. So These malpractice actions are expensive. They take a long time until there's a resolution of the case. A plaintiff's attorney is not going to want to pick up a chart that is documented timely, clearly, concisely, factually, and objectively. They are looking for that chart with the missing entries, the copy and the paste. They're looking for those vulnerabilities that they can kind of get their nails into and make a case out of. Don't make it easy for them. Don't make it easy for them to get that case. And in the event that there is an action that's started, your documentation is your best line of defense. It is what you're going to testify to with regards to what was done, your treatments, your conversation, your thought processes. You're not going to remember what happened when that lawsuit comes to fruition. You have to rely on documentation. Now, you have documentation, and then you have independent recollection, which you're not going to have. And what we rely on then is custom and practice. Can you testify, this was my custom and practice? Yes. Does it always work? No. Some judges, some juries don't even take it into consideration because it seems self-serving, right? So who's going to say something is my custom and practice if it's contrary to the standard of care or if it's contrary to what was done, right? But if it's documented, there's no argument. It happened, it was done, I met the standard of care. Also, Deanna discusses as well, interpretive services need to be documented as well. Plaintiff's attorney love it. So if they have a client that does not speak the same language as the doctor, one of the main questions that they're gonna ask at the deposition is, doctor, do you speak that language? No. Well, then how did you communicate with the patient? Plaintiffs seem to forget English even more when it comes time to those lawsuits. So if someone is there interpreting, document who was there interpreting the conversation between you and the patient. In 2024, there was a Candela report which reported on the effect of documentation on defensibility and patient safety. And it reported that 20% of med mal cases involve documentation failures. It highlights a critical yet fixable vulnerability in healthcare. It concluded that inadequate, missing, or inaccurate documentation significantly increases the likelihood of a malpractice claim resulting in an indemnity payment. It identifies that technologies such as the EHR and emerging AI transcription services is not a cure-all we had hoped in healthcare. When I first started, it was all written charts, and it was me trying to figure out the handwriting of the doctors, right? So it was like the most frustrating part of my job, practically, looking over records, trying to figure out what the doctor was writing. When the EHR came out, I thought it was going to be the best thing ever, and it became the worst thing ever. It was copy and paste. I didn't know, no one could figure out what was what note was newly written, what was carried over from the day before. If there was an error that was done in the beginning of the admission, it was carried over throughout the rest of the admission. If information became irrelevant because it was just carried over and over, do me a favor. If you are seeing a patient many times, change the wording around. Plaintiff's attorney love to focus on the fact that the language is exactly the same throughout each visit. It's hard to know if it's a carryover or if you actually did an exam or looked over the interval events in that note. So go in there, change the words around. If the wording is not the same, it clearly means that you were in there and you did something different that day, and the examination was done, and it avoids that area of discomfort at a deposition. So next we're discussing managing the non-adherence of a patient, the non-compliant patient. Completely frustrating, and if it's not handled appropriately, can result, not handled appropriately and not documented appropriately, can result in a malpractice action. Missed or canceled appointments must always be documented, as well as the attempt to get that patient back into your office, or to follow up for a test, or to follow up for lab work, or for a diagnostic study, or for a procedure. That has to be documented, and your office needs to have a procedure in place to make sure that you are contacting that patient to make sure that they're following up after a missed or canceled appointment. One of the things you need to do is try to contact the patient as well and find out why they're not coming. Is it something that can be corrected? Are they scared about the procedure? Are they nervous about the results? Are they worried about the money? Can they not get there? Maybe it's something fixable, you could correct it and get them to comply. And of course, as we all know, sometimes a non-compliant patient is a non-compliant patient, there's nothing you could do, and then you have to withdraw from care. As Deanna had mentioned before, you should always contact basically your risk management department, legal department, your carrier, and discuss how to do it appropriately so you don't suffer any type of abandonment issues later on. If you called me, I would say send a letter at first detailing the missed appointments, canceled appointments, detailing what can happen if they don't follow up appropriately, giving them a couple weeks, depending on the severity of the situation, to come back, and if they don't, you will discharge them from your practice. In that 2-week, 3-week, whatever period you give them, then you send them another letter discharging them officially from your practice with information on how to get more treatments from another area if needed. So that all has to be documented in the chart. So basically any non-compliance. It's important to be objective. You cannot, even if this patient, you cannot even stand the look of their face anymore, like they've come to the point that you're completely frustrated with them, your note should never reflect how you feel about them. You never want someone to pick up the chart and think that there was any other reason that you discharged a patient as opposed to them just being non-compliant, right? Be objective. They can always pick up the chart and request a chart and see what was written about them. You don't want other providers to see anything else either. Make sure it's objective. Use quotes when appropriate. I find always recommended if the patient says something extraordinary. I like to use it too if they're referencing something that's said about a previous doctor, so it doesn't make it seem like you're saying it about the other doctor, because sometimes those areas become a little bit gray. So put that, anything they say about previous providers in quotes. Emphasize in the documentation that you told them to come back to the practice and at all the attempts that were made. And again, if there's any questions, always contact your risk management or legal department. Chaperones. Chaperones are a benefit for the doctor and for the patients. For the patient, they provide comfort and safety. For the doctor, they can protect you against any allegation of wrongdoing. The patient has a right to request a chaperone or to refuse a chaperone. Whoever is being the chaperone should be documented in the chart. We just had a situation where a patient was claiming inappropriate touching by a doctor. Doctor had the initials of the witness in the chart. It was an ex-employee, so we identified who that ex-employee was, found the ex-employee, they testified, and then we were able to get those charges dropped against the doctor. So again, it can be useful. You never know when you'll need it, but it's always, always need to document who was actually chaperoning the visit. The use of computers, I didn't realize that Deanna had a story. I have a story too with regard to this, but basically, I could tell you myself, it's like I used to go to my kids' pediatricians, and the guy had the computer in the room, and basically it was more of a mission of trying to figure out how to use the computer. He would have staff coming in to try to figure it out, and I would wait for him to finish before I asked a question about my kid, you know, and I was like, so what's, you know, so you need to make sure that, and you lose eye contact. You feel like the focus is on something else. You need to make sure you are engaged with the patient while they were using the computer. We have the poised model here that we recommend. Prepare for the visit before the patient comes in, gather all the information so you know about them before they actually enter the exam room. You're not learning about them at that time. Orient the patient to what you are doing. Information gathering, this allows you time to listen and identify the patient's concerns and values. Share where you're looking on the screen with the patients. This way they're feeling involved and they know that you're not writing anything bad about them. Educate the patient, reinforce plan of action. Have a collaborative decision-making process with your patients. If you have 2 plans, the patient is involved in deciding the second plan is better for me, they're going to be less upset if one of those risks occur when they were part of that decision-making process. So make them part of that process as well. Debrief and assess the degree to which the patient understands the understands the recommendations and plan, utilize the teach-back method. Patients come in all shapes and sizes. Some of them get it really quickly, some of them don't. I have two boys. One, I could say something to, he gets it, he moves on. My second one, he's looking me dead in the eye, and I'll ask him, I'll say something to him, I ask him what I said, and he has no idea. No idea. So that's what it's like. You could have a patient in that same type of situation. You think they're understanding, but they're not. So make sure that they are truly understanding what the plan of action is. Next, we have the patient procedure selection. So inadequate patient assessment is a common factor that leads to malpractice lawsuits. You need to have a good screening process. You need to so you can evaluate risk factors, whether the procedure is appropriate, whether the patient is a suitable candidate, and this can all help prevent adverse outcomes. Red flags. If you listen to anything I say, this is it. If I had $1 for every time a doctor says, you know, the patient seemed a little off, the patient seemed a little crazy, patient seemed a little obsessive, I felt bad, you know, it's a friend of a family member, it's a friend of someone else, so I took the case. And then they ended up in small claims, or they're being harassed by emails and office visits and calls, and you will have that spidey sense. My kids are big Marvel fans, but basically, you know, when you know the patient is just not acting normal, go with that sense. You're probably right. Don't create that doctor-patient relationship. Refer that patient out. If the patient has any type of unrealistic expectations, misaligned expectations, perfectionists, if they want things done so quickly, those are the red flags you have to look for. Refer them out to someone else. You need to modify treatment plans. So if a case changes mid-treatments, you need to immediately pause, reassess, and modify that treatment plan. So as promised, here is the informed consent process. So according to Public Health Law 2805D, lack of informed consent means the failure of the person providing the treatment or diagnosis to disclose to the patient such alternatives thereto and the reasonably foreseeable risks and benefits involved as a reasonable practitioner under similar circumstances would have disclosed in a manner permitting the patient to make a knowledgeable evaluation. It applies to non-emergency treatment. Obviously, if the patient comes into the emergency room, is unconscious, they can't give informed consent, they need treatment, you don't have to get informed consent. It's a non-delegable duty. You can't tell your secretary, you can't tell your PA to give that informed consent conversation, and it has to be done by the provider that's performing the procedure. Patient has a right to refuse treatments. If they do refuse that treatment, you need to document that refusal in the chart, find out the reason why. Again, is it something that can be corrected? Is it something that's, you know, they're scared or they don't, just some kind of unknown that can be corrected? You have to discuss any type of alternate options, and you have to make sure that the patient has the mental capacity to make that decision. I could tell you right now that if you do not have a well-documented chart with regards to the informed consent conversation, it will be a cause of action that is being alleged in a lawsuit against you. So it's not just the form with the signature. You need to have a conversation with the patient, risks, benefits, alternatives, including not having the procedure documented in the chart as well. So you're gonna have that form, the conversation, and documentation of the conversation in the chart. It's signs, basically, like as I said before, risk, benefits, alternatives. They need, and also document that you gave them the opportunity to ask any questions, answers were given. The more you have documented with regards to this conversation, the less likely that it will be raised as a cause of action. And if it is raised, the better our chances of getting it dismissed prior to any type of settlement or trial. We could get it dismissed from that part of the action off the case. So as we already discussed, lack of informed consent alleges the failure to disclose risks, benefits, and alternatives that a reasonably healthcare provider would disclose under similar circumstances. It does not give the patient the opportunity to make an informed decision. The plaintiff must show that a reasonable person in the patient's position would not have undergone a treatment if they were fully informed and it must establish that the lack of informed consent is the proximate cause of the injury. Oh, sorry. Okay. So, lack of informed consent is not only required law, but it is also enhances the patient and family experience. It's going to help develop a rapport with the patient, create a good patient-provider relationship. You are now managing the expectations of the patients. You are removing any elements of unknown or confusion by the patients. When the patient is fully informed and understands, they will have a better adherence to the treatment plan, and they will be better improved health outcomes. So what happens then? You have a happy patient. When a patient is happy, they are going to refer their friends and their family to you. They are going to put positive posts on websites and social media posts. This in turn will get you a bigger patient population and will improve your business. So we already went over this communication, documentation, behavior-related issues. Again, I want to express to you communicating and delivering your message, and how you do that is extremely vital and important to having a positive doctor-patient relationship. Ultimately, you do this, patient likes you. When the patient likes you, they respect you as a doctor. Patients do not sue doctors that they like. So make sure you maintain that good relationship. And we've discussed the documentation. Just so you know, there's always reach out if there's any need of guidance or support. This is the end. I just want to thank Dr. Riley for letting us have the opportunity, and the Osteopathic Medical Society for letting us be here today. I'm sorry? Oh, sorry.
Thank you so much. I have a question. So in regards to when a lawsuit comes out and they take all 35 physicians that have treated the patient over the past 2 years.
Yeah.
I mean, even if you get kicked out, you're still suffering. You know, I mean, you still have to go through the whole until you get dropped, a year, 2 years. So in reality, there's no winning for the physician, because you still have to go through the same. I mean, you don't go to the intense, right? But there's no winning either way, right? Whether you lose, settle, or get dropped, you still have to suffer through that. So how do you mitigate, you know, kind of, there's no way of us suing them back for all our mental anguish and lack of sleep and changing practice and, you know, divorce. I mean, a lot of things that happen when this occurs. How would you?
Right, you shut that off, sorry. Yeah, well, it depends on how you look at winning, but basically, some of the plaintiff's attorney will name everyone that treated the patient. That's correct. That is not as common anymore as it used to be, I find. But basically, your documentation is what's going to be a best line of defense. So if they have a doctor that's thoroughly documenting, they know it's not going to get anywhere, there's a good chance that they're not going to name you. Once you're involved in that lawsuit, yes, it's stressful. But if you give your defense attorney something to work with, our goal at MILMIC is basically when the case comes in, we work it up for summary judgment. So basically our goal is to get you out of that case prior to settling. We don't want to settle, we don't want to go to trial. We want to get you out of the case by motion. And the only way we could do that is if we have good documentation in support of what you did, and an expert that can then come along and say, there's no deviation on his part, or his or her part. So that's the way we work it up. We work it up that way. So we want to get you out by motion, but we need something to work with. If you don't have a well-documented chart, we can't get you out. So there's nothing I could do to say, I can't prevent someone from naming you in a lawsuit if they're naming everyone that ever touched the patient. But we can do our best to work with what you give us so that we can get you out of that lawsuit prior to trial, prior to anything else, so you don't have anything reportable to the data bank. Deposition, you might have to appear for, because that, we also use your testimony in support of that motion for summary judgment to get you out. Does that answer? Yes? Oh, I'm sorry. Oh, sorry. It's like, now you're good.
Oh, now it's on.
Yeah, sorry.
So I was in a lawsuit that was a big net, and it happened on a patient that had diverticulitis. And they went to the emergency room and they did a CAT scan that showed it, but they didn't treat. They didn't notice the sign. And I was on vacation, so I came back, saw that he was delayed. I started Monday Athletic. I wrote in my handwritten note that it was delayed treatment, that he had to watch out for perforation. If he did have sudden pain, he'd go to the emergency room. 2 days later, my partner saw him was better. 3 days later, he perfed. And the emergency room doctor said, your PMD did something wrong. He's to blame, okay? So what happened in the deposition, it happened within a week or two.
You're
what happened was...
You're the PMD? I'm sorry?
Huh?
You were the PMD? Who said? Who was the PMD?
I was the primary.
Oh, okay.
But I was on vacation.
Good, okay.
Okay, so when I got in, the lawyer said, I looked at your notes, the handwritten notes, and said, we can't sue you. It will look silly. You did exactly everything right. But it was a handwritten note, which is the funny thing. I wrote everything down quickly so that I noted that he needed to see the emergency room if he got worse, that the treatment was delayed, and that actually saved a lot of people. Now the other thing too is that when a patient knows you care for them, it's unlikely they'll sue you. That's just by enough. Don't touch the door before they're finished. Don't keep staring at your computer, because that means that you're more interested in leaving the room than listening to their problems. Okay? And one patient actually looked at me and said, I like you already after just saying hello to him. I said, what did I do? I just met you. And he said, well, first of all, you're writing on a piece of paper. You don't have a computer, and you asked me how I was doing. It's a really low bar. Really low bar.
We do a lot of, is that Wolf? That's Wolf? Oh, is that, we do a lot of non-party depositions too, and I can't tell you how many times I have a doctor that is not sued because the family refused to bring him into the lawsuit. So now he's being subpoenaed, she's being subpoenaed because, you know, all the defense attorneys are wondering why this doctor is not named in the suit. But patient found someone that they love and they want to continue treating with them, they trust them, and they're not named in the lawsuit.
Wow. And sometimes a plaintiff's attorney won't take the case if that's the consideration. If you have a client or a patient that doesn't want to sue one doctor but wants to sue the other, sometimes they don't take it because they know they're not going to formulate the best cause of action against it. You know, maybe they need both of them in there. So sometimes it's not worth it to them either. To take it.
Dropped the case because I did everything
right,
properly.
Right, yep.
So if he brought me to court, he would look silly
Sure.
in his own words.
Right.
Were they able to read your note, though? That's what I want to know.
I'm a legend.
And that's great with the notes. You know, we don't do it often enough anymore with the EHR. We get so used to templates and drop downs. But every so often, you know, put a note in there if you have to. If you need more room, if you need to elaborate, it's going to go a long way. And like Mercedes said, when things get copied and pasted all over from one visit to the next, it really just makes the provider look bad.
Okay, and last question, because we have another speaker.
Does a doctor who provides pre-operative medical evaluation, commonly called a clearance, have any responsibility for a surgical patient who didn't have an adequate informed consent? In other words, does the doctor who sees the patient for a medical evaluation need to contribute to the informed consent?
You have to shut off your mic. It's funny, I just had a medical clearance call come in the other day. And in that medical clearance note, I told, basically, he was out of state and the patient was in Florida, needed emergency surgery. But basically in his note, I had the doctor document that basically the indications of the surgery and any type of anesthesia clearance is up to the surgeon and anesthesiologist. So the individual that is performing the procedure is responsible for the informed consent conversation. Medical clearance is, I would say it's not, you're not obligated to do so. That puts a whole new.
Thank you, everyone.
so much again.
Big round of applause.
Well, happy Friday. Whoever made it to still my lecture, thank you for really being present here. It's an honor to see you all again on the annual conference. Yeah, what Mercedes said before, we were laughing a little bit with Dr. Juan Acosta, that patients who like you will not likely sue you, but their families will. So I think she forgot to add that. But I was hoping Dr. Broder will be here, but he said he'll be later tonight because it brings me memories when I graduated NYSOMS in 2011. His favorite joke was about the introduction to my lecture today about prognostication. He said, so you probably know this, the guy gets a call, right, from a doctor coming from vacation, feverishly running to the office like, doctor, you have like news for me. What is the news? It's like, well, there's good news and bad news. Which one do you want to hear? He's like, so what's the good news? He's like, well, you have 48 hours to live. He's like, that's good news. What's bad news? Well, I forgot to call you yesterday. You know? So, but that's not about palliative care, really. But the preface of that is, yeah, prognostication and prognosis are two separate kind of entities, I would say, because prognosis means you just estimate, it's like an estimate of numerical, right? Kind of we put sort of preface of, okay, so with all the knowledge we have collected in our clinical, potential knowledge, and we prize ourselves as obviously clinicians, collecting all the data and research, and we can put a prognosis as a forecast for the future and apply it to each particular family and patient and deliver sort of the news. But prognostication takes more than just the knowledge. It really takes a lot of whole clinical experience and a skill, the actual art of really gauging and applying that knowledge to the particular scenario at hand, right? So that's really the difference. And again, there is definitely a lot that's played into the criteria of what requires of a clinician to deliver. Oftentimes, as palliative care physicians, when we rotate with patients' families, we're the first at hand, sadly, at times to approach them and deliver certain news that may not be as favorable, right, outcomes of their expectations. But we have to take into account whether it's patient-related factors, right? A lot of comorbidities, of course, go to conversation, knowledge of different options presented to them, ability to really have enhanced communication skills when it comes to the delivery of the prognosis and risks and benefits discussed, and obviously to be aware of just the natural progression of the illness, right? I think in terms of the actual prognostication, again, it's a skill, and a lot of us would say in our all years of clinical practice, no matter dimension where we specialty focus on, there have been cases that really proved us wrong, right, despite our best maybe predictive abilities. And we'll talk about cases that maybe we underscored the importance of really emphasizing the timing, right? And again, I think we've done in the previous years some lectures about the distinction between palliative care and hospice care, and really how it goes into, remember that palliative care spectrum of caring for an individual and their family, it transpires the entire scope of the trajectory of illness progression, regardless of the really where you meet them in their timeline. But hospice is a very particular segment of palliative care when it differs to 6 months or less would not be sort of that surprise question to your best competent expertise as a provider. Would you be surprised if somebody had 6 months or less prognosis of time? That's when the hospice entity created by the Medicare in 1986 went into the action by the government to take place as a benefit entitled for end-of-life quality focus, right, on comfort for the patients, individuals who are diagnosed with specific spectrum of prognosis of 6 months or less. Now, so there are different trajectories of different illnesses, right, that we kind of fall into different categories of how do we expect the communication of prognosis to look like timing-wise. As we all know, let's say something like cancer, right? And you can see the blue line, like one trigger event, or normally like they can plateau until some sort of acute event brings them to a point of a sudden decline or more like infection, let's say PE, and then even eventually, even sometimes imminent death, right? So if you ever take a board and you know that there's a patient that you have, and we always have it on the palliative care board, but I'm sure it's for everybody else. If you were to ask by the family, you're on the wards, and the doctor has, like, let's say today I had a patient with metastatic cancer to brain from lung and liver. Presumed the origin it was never biopsied, but presumed from the lung. And the family asked, okay, so how much time do we look at, right? So the biggest prognostication, let's say for metastatic cancer, by default from the studies we've done, is really functional status. And the nutrition, obviously, status combination. So basically, it's called performance status. Or we had something maybe you've heard in They do ACOG, or in the oncology worlds, right? They use Karnofsky performance status or the palliative care performance status. And it goes to say that once you pretty much had succumbed to the bed-bound state and you have not been having any progression of, let's say, nutritional intake, you probably look at the weeks to months prognosis, especially in the setting of metastatic cancer. And if you even further look at certain other indicators, sometimes it goes to days or weeks. And these are all important depending, again, on what we're dealing with. We'll talk a little bit more, and how you deliver the message. So the other type of, let's say, diagnosis is, let's say, pathways like CHF, COPD, where they follow through when we talk to the families and sit down with the conversations is typically you have, like, again, the slow decline due to episodes of acute, right, relapse that brings them back and forth, back and forth. How many times you've heard or you've sent as a primary doctor to a patient that we see on our side in a hospital, and it's like 6 months, this is like their 8th admission for CHF exacerbation, this is, I don't know, their 3rd admission in the 4 months for COPD exacerbation. Those are the hard diseases to really sometimes to give exact timing or prognostication to the families when we reach a full sort of determine end stage prognosis, because they tend to fluctuate, and it's not as clear cut as, let's say, somebody end stage dementia or somebody end stage cancer to characterize and put a sort of a full veto by full competence of the physician to say, listen, we reached it, right? But it comes to that point, of course, too. And then let's say the category of diseases that fall into a lot of neuromusculoskeletal kind of diseases that we know, dementia, Parkinson, a lot of times MS, ALS. A lot of those patients, you know, which leads to a slow, again, kind of onset, not only cognitive and functional deficits, but also later progressive decline and over variable time, right, depending on severity and the type of onset, I guess, and then what kind of, I would say, type of dementia particularly, right? A lot of times we'll talk about it's important in the community, I think, more and more, not to underscore. So what I see with families and patients on our end is that we always say, like, you know, the theater doesn't start from the stage, right, and performers. It starts from that wardrobe where you hang your coat, right? So a lot of times it would be so much more helpful for the families to understand their trajectory before they come to the hospital, because oftentimes you ask them, well, have you talked to neurologists, let's say, in these cases? Have you talked to your primary doctors? Did they prepare you what to expect? What will eventually happen to somebody who has Parkinson? What eventually will happen to someone who will manifest end-stage dementia progression? What will be the deficit? Are you looking at potentially being fully dependent, and what dependence will look like? All of them will end up on a ventilator eventually unless you make decisions, right? All of them will likely require PEG unless you make decisions, right? So all of those important trajectory and prognostication pieces of each segment of their disease progressions, we wish sometimes patients and families had discussed prior coming to sort of acute event that brings them to oftentimes sometimes either critical condition or imminent situation. So I would just absolutely encourage and would absolutely, it would be delightful if any one of you took a little bit more initiative if you had, of course, opportunity to discuss with your patients. Different, again, prognostication tools. Whether depending on your specialty, I'm sure the MELD score, just today I had a gentleman, it's really, really very sad story, but it's a sort of self-inflicted situation. I mean, he had alcoholic background cirrhosis and not a candidate for any transplant. His MELD score, as of today, literally speaking, was 36. So let's say hypothetically that puts him to a category of 3 months or less expectancy of life, above 70% chance, basically, prognosis. Just to give an example, right? The different calculators we use in medicine, or like recently I had a patient septic shock, right? The multiple pressors in the emergency room, I know we use a lot of also prognostications when it's like cardiac patients, you know, acute presentations, right? Or multi-organ failure, we use a lot of calculators too. So we can't, in medicine, there's very hard to predict something to the absolute degrees, right? And unless something is literally in front of you within minutes happening and you know it's inevitable, then you can tell kind of minutes to the patients or well, not patients, mostly families, right? But otherwise, it's very hard to say on the dot. Like if I ever speak to the families, right, I may say, or the oncologist or the pulmonologist can say 3 months or less surprising will not be the prognosis. But they can't say it's like, okay, June 27, we'll never say 3 p.m. is going to happen, right? Because none of us just have a crystal ball clearly. But, you know, in a lot of obviously conditions, like let's say I had a patient with dialysis, and oftentimes I think our little bit of conflict or maybe the challenge from our team is the expectation set in terms of what did the nephrologist discussed, let's say, what would be the expectation of timeline if you stop dialysis today, right? There's a lot of other, let's say, comorbidities, but in the spectrum of the general research that we've done, if you were to stop dialysis today, let's say you have days or weeks of life, right? We always talk in intervals. Like, it would be surprising if you lived months, what I'm trying to say, right, to most practitioners. But it's much better to say it that way as opposed to imagine, I cannot even tell you how many times we see in the ICU also patients, even from the conversations of whether cardiologists, whether I would say even nephrologists or any specialty track, and they would write, how many times you've seen it too, like poor prognosis. Like if you're the family and you're on the reverse side, and I told you, and you asked me how much time I have, and all you have to respond is prognosis is guarded, or it's poor prognosis, it doesn't by de facto give any sort of sense of I would say preparation or level of clarity for the family, because it's such a very abstract term, right? There's families, we don't know on their end what they have to prepare for, right? What their challenges are, what maybe they need to take care of before, how much legitimately time they have on hands to deal with things. So I would advise not to really say poor prognosis or guarded prognosis when we really have families who are truly asking you for very particular clarity, right? So again, I know one time I've done a presentation, maybe some of you have attended. This is a concept that has been talked about in a lot of, I would say like a TED Talk type of style presentations, but they would talk that once it was proclaimed that the longest distance one will ever travel is from their mind to their heart, right? And that's the exact distance, they say 18 inches from your mind to your heart. And you know, where the wisdom of you as a clinician, right? The wisdom of the universe and the wisdom you empower yourself with the knowledge of your heart and your mind, and the universal truth comes in, basically, in anything that you do in life, right? So how many times you have told yourself, maybe as a clinician, that my mind is telling me one thing, but then I struggle in the heart with a decision to deliver information. And we'll talk about why is that too. And the errors, why they happen in prognostication, not because we're only not obviously crystal ball, and not because we're still human and miracles happen, of course. And there's spiritual things that I will talk to you about in palliative care world that we've seen that beyond explanation of anything, and I'm sure you as well, that we cannot really put a dot to the research or medical experience, why it might have dictated. So again, because sometimes the longer you know somebody, right, the longer your attachment, the longer your relationship and bond, because of the continuity of truly being their family, part of their care, being present, is immensely, immensely hard to bear the burden of your own hardships at heart, to know what is expected, let alone to really face the truth and come forward to the families, right? No matter how hard it might be for you to deliver the information. But the sort of, you know, sometimes also as we're advancing in medicine, the enthusiasm for all the new innovations available to us, right? All the new treatments, we often struggle, like, should we hold off maybe? Should we still try something? So that's the constant battle that we all experience every day. And I don't know if you ever heard of this concept. Have you heard of this term, chagrin factor? So chagrin is like a Latin term, but it was kind of introduced in 1985, like literally a year after I was born. It's hard to believe. I mean, it's like, this is like, oh my God, new concept. Okay, relatively. So by Dr. Alvin Feinstein, who was a very particular interested person in more quantitative and qualitative analysis of the related to emotional approaches and risks we take in management of the patients, right? So what he said is that you have this concept informally, obviously, and sort of psychological discomfort, and where is our own comfortability as a clinician lies, and why do we really struggle of delivering certain particular information when it comes to the concept of particularly maybe death or around conversations of taboo topics, oftentimes related to aging and dying, right? And they say sometimes maybe you overestimate outcomes, right? Survival, recovery, disability, unconsciously bias present because of the relationship or because of the embarrassment of your own sometimes regret that you may have later because of the feeling that I'd rather over-deliver than under-deliver because I'm playing on a safe side, which is what a lot of times, unfortunately, we have been experiencing as well in the modern medicine, right? We'd rather throw 20,000 tests, we'd rather prove everything else until we have a certain courage as well as clinicians to come forward and say to you, listen, I have exhausted, I've tried everything else, because a lot of jargon and the words I think matter that we have to remember for the families. If you were to ever encounter a situation when you're delivering news, every word matters that they will remember, right? So you can't really say, you know, the patient unfortunately failed chemotherapy, because how does that sound if you were the patient or the family? That sounds that you were the failure. So we shouldn't use the words really failed. They just didn't deliver the outcomes that they were expected for the patient to receive, right, of the expected therapy. And similarly, how many times you maybe heard the family when I asked them, so what did the doctor tell you when I initially introduced the concepts, or just try to get from them what their sense of understanding? They say, well, the doctor said he has nothing to do with me anymore and there's nothing he can do for me. How would it sound if there's doctor, or how many of you heard this, or maybe even said, and even I in the past, right? Because until your framework of mind has to be reset, how many times have you said there's nothing else I can do for you? That sounds as a neglect, right? That sounds as an abandonment of care. So the concept of cure and care, remember, never, it's very not synonymous. So care never really stops until very end of the last breath. It's just how do we refocus, we tell the families, how do we retarget, and how do we orient your care matters. And that chapter, even though they may feel powerless in the sense of a defeat by disease, but there's so much more, we always say, like, yes, the doctor is right, but you should name things, right? So you should name, what is it that you cannot deliver to the patient's care treatment options? Yes, chemotherapy is no longer, seems to be helpful in your case. However, try to avoid the words buts too, because of neglect, right? There everything else you're trying to preface. However, we can still do so much more for you when it comes to a different type of fight. Because, you know, oftentimes what would you hear? I don't care, grandma, right? My mother is a fighter, she's always been a fighter, I'm gonna fight for her till the end. So how does that fight look like? What does a fight for you means, right? Because the fight can look different ways. Not necessarily the fight is always for the curative intent, but the fight could be also in the sense of retargeting the purpose of the treatments, maybe oriented for symptoms management, pain management, comfort-oriented care. That is a different type of fight for their dignity, for their grace, for the delivery of really something that we can have ownership and still actually have the power, and for the family to feel control sense. Because any person sitting in this audience and anywhere outside, the last thing you want to remember that you went with is some sense of control in this life. None of us want to lose independence of any kind, let alone control of decision making, that we still have some power over. And that's what families want to hear as well, that they still can dictate certain things that matter to them. Oftentimes we ask the question, actually during interview with the families, what matters to you most? You probably heard that as well. And then they would say, but you have to prompt them, right? So when it comes to physicians' uncomfortability of their own level of reserve, right, reservation from avoiding sometimes providing reassurance because of the false hopes maybe, or maybe they think of their own clinical impact because sometimes overutilizing, like we said, certain treatments or tests. And what is happening is, I think, is also, while we're battling our own demons within and sort of the uncomfortability level, have you ever heard the difference between something called prolonging life with any treatment level that you would provide, but there's something called prolonging end of life, right? And it hits very different to different people, most of us in general. So there's a reason why we have to be very careful when we come to the explanation of the timing with patients and families, and not forgetting what is the fight in their eyes and what it matters the most and that we orient for. Are we really prolonging life, or are we prolonging merely those weeks of life, and at what cost to them, right? Or the risks potentially. And again, you know, this is obviously funny, back in the day cartoon. There's like basically, sorry, I'm late, but they held me, let's say, in the ICU for 60 extra days, but I missed my spot upstairs, you know. So assessing readiness, right, to discuss prognosis. So they did a lot of studies, and basically majority of patients would want more than 75%. In fact, seek clarity. It's very important to families and patients to talk about prognosis if they had less than especially 1 year to live. And how many times maybe you've seen certain specialties, the hardest that I work with, I would say neurology, nephrology, and oncology in palliative care, because there's a lot of those very waning and mixing signals, and there's so many new therapies, right? So it's almost the hardest for those specialties would be to ever step front and say, well, they always say, oh, 2 years wouldn't be surprising, 3 years. And then we're all looking, the rest of the consultants at the patient in front of us, we're like, well, what about functional status? What about everything else? Look at the patient, like, really, do you think he's gonna make it to that chemotherapy session for 3 more times? He barely can come out of the chair. But we're giving 3 years unrealistic expectations to the family? On which grounds, right, let's say? So it's hard, right? It's hard for both. We're in between, you know, consultants may have their own reservations and conflicts of opinions, and at the end of the day, it's the patient and the families that is under-delivered in terms of the information and potentially expectation. And, you know, it's the discussion of the prognosis, when and how, obviously, to prepare. Obviously, the context and it matters how you approach the family, right? The timing, you ask certain, like, understanding, right? I never start palliative care meetings and like, boom, let's start, like, I have information to deliver, I came with the agenda, and let's go. I have 20 things to tell you. You come from meeting them at the place where they're at, right? So you ask them, what is that you're understanding so far? What have the doctors discussed with you, whether it's outpatient providers, whether it's inpatient providers, and you pretend like, obviously, you know, you're here to just chip in information into between the gaps that maybe something is missing in their understanding. And then, you know, obviously you take it from there, depending on their understanding. I don't know if the negotiate, but that's a standard of approach in palliative care. Negotiate maybe not the right word, obviously, but you sort of try to mediate the content, right, of the discussion between patient and families, because also the other point is maybe the patient wants one thing and has certain expectations, but because innately sometimes they want to shield their own families and they want to please their doctors, they may have a conflict of how to interpret your information in front of their families and to deliver their own decision making. So oftentimes we would have to serve as clinicians as the advocate, not only for the patient, right, to be heard and to voice their concerns, but also to mediate the gap in sort of, I guess, distinct misunderstandings of communications or whatnot goes into between disagreements between family members. And, you know, obviously you have to respond to their emotions, because a lot of times, even myself, we get on a high-speed train, especially in the hospitals, we work like locomotive, right? First day, you learn as a resident when you're on rotation in a hospital, it's not the question how the patient is doing, what's the discharge plan? Patient just got here like 3 hours ago, we're already talking about discharge, right? You know, you remember that, right? It's for medical students. So it's like held off, like, okay, what's the emotional state? Because patient just told you, I feel neglected, or I feel whatever it is, right? And you just already, no, your lactate is 34, like, I don't know, whatever it is, right? So you just completely bypass what he just told you. He absolutely feels neglected, ignored. He doesn't care what else you have to deliver because he just heard that you have not heard him. So you have to account and you have to admit and acknowledge what he just said, the emotional voicing of whatever is the circumstantially their feelings are first, to acknowledge them, and then you can proceed because you open a very different relationship, right? And then you agree on a plan of steps next for the care. Like we were talking about before, you know, when to discuss the prognosis. So let's say in metastatic lung cancers, right, they did the study a lot, and especially end-of-life care discussions, right, with their physicians. So prior to the last months of life, we're less likely to receive highly aggressive care. Ideally, we don't want it to happen prior to the last months of life, right? Because if I were to tell any of you, you have 30 days to live, would you want to know it on the day 31? Or would you want to know it on the day 61 before? You know, so it's a little bit, it's hard meddling, right, to really know what's right. There's no right or wrong, but we do know that most of us probably would deal better knowing certain information and handling it a certain way. There's cultural background. There's a lot of times, as you know, also people come from very ethnic, religious, different backgrounds, and they would say, listen, I'd rather not to know. Tell my son, tell my daughter, tell my nephew, my grandkids, they would know what to do for me. But then the family members start attacking you sort of in a sense like, okay, but we do need to know, right? Or I need to plan. I was the caregiver. I need to take FMLA. I need to do this. I need to come from California. I need to move my life around, right? Who's the caregiver? What are we doing here? Social situations, financial situations, right? And they don't take 31 days to plan, oftentimes. And if you need to discharge the patient home or arrange the hospice services, majority of us struggle to understand who's going to be the caregiver, who's going to pay out of pocket, where am I going to get all those resources? And you know, the biggest, you know, I have to tell you, besides the question, when is the patient going to be discharged in the hospital? In order to discharge them, you know what's the next best question becomes from the people on top of length of stay and throughput, on top of every doctor, right, politically, is, okay, where's patient going? Can they take patient home? If not, let's put them to the nursing home. Okay, how is he going to go to a nursing home if he doesn't have a supplemental insurance to cover for room and board? Yeah. Family has to apply for the institutional Medicaid. That takes not 30 days. It takes a little, of course, some days to collect information, submit it, receive the response, right? Let's say we have 30 days of life. And let's say they're not acute to be in the hospital inpatient unit and they're really just going home. So you're working with race against the time and not in necessarily favor, because then the patient's family, hey, he has a Medicaid. The typical story, 5 days, 8 hours, home attendant comes from insurance, but I want to know that he's so bad, doctor, you just told me, we're going to apply for increased hours. You know what's the real question? You know how long it takes for the city, we all know, to increase the hours? So the real question, does the patient have those 2 months of life that it will take for the city of New York to increase his hours? But we just told him he has 30 days, right, or something. Based on how he looks, it wouldn't be surprising that he has short weeks or short months. He may not ever see the increase of the hours. So meanwhile, the family has to drop everything they've got and take care of the patient. Or they find out-of-pocket expense some kind of person to help them out. So I think there's so many factors, sadly, that sometimes we don't think, and I'm super grateful because I never imagined, you know, that I would do palliative care, believe it or not, being as a medical student. However, I'm truly grateful because everything that takes into account is not our just medical, purely knowledge and research and everything we've done. At the end of the day, it will come down to finances, to social situation, to purely human factors, besides delivering the knowledge and delivering that timing, right? Content. So I think just solely because of that, if none of us have been in certain shoes, or I don't know, sometimes it hits closer to the theater near you than you expected, obviously, and each one of us probably have struggled or faced potentially either challenge or a loss of someone we truly cared about or loved, but we all knew probably in that moment that time is of really essence, right? And not just 1 minute, not just 1 week, not just 1 hour, but preferably longer than that if possible, to certain things to be arranged in place. You know, obviously the way to uncomfortable conversations is never easier. Like I always say, you know, if you go to the gym and you try to weigh tomorrow 40 pounds and you've only done 2 pounds before, it will feel impossible. But over time, you get equipped, like with anything else. And in 3 months, 40 pounds will feel like nothing for you to labor, right? So it's always with uncomfortable conversations and the feelings of, you know, there's no easy way to tell you this. I'm going to send you to Dr. Rubina because that's all she preaches every day, right, basically. It's still hard for me to do this, believe me. But, you know, again, the propensity of us thinking as human beings, again, that something should, like, you know, could have been in life a certain way, but then we compensate with this contemplation of, well, it should have been in life this way, and we question, right? So delivering difficult news, maybe you heard of something called SPIKES. SPIKES is an acronym. We use it a lot in palliative care and other areas. It's just basically for setting up the conversation, perception of the condition of the family. You inquire from them the information they know, and then invitation to open the conversation to give and provide them the information, maybe the gaps that they to fill in that they have not been aware of, and the knowledge, right? The actual delivering facts, factual information to work with the formulating the sort of later strategy and approach their care treatments, but also exploring their emotions and sympathizing is a very important step. So how to discuss, right, the prognosis? Again, this is about setting up those spikes things we talked about a lot. I don't want to focus so much on that, but this really resonates with me a lot. This is what I literally get called 6 times in the ICU a week to do. And you've got 6 months, right? But we can really prolong it with aggressive treatments because robotically we can pretty much have every facet and orifice of the body. We can introduce any possible tube in the world to name it, right? And I'm not trying to be, believe me, sarcastic, clearly, but just in the sense of, I've had a 101-year-old just like a few weeks ago. I don't know, in other countries would never even fly or happen, right? But in our country, it's inconceivable that I had a 101-year-old that I had to discuss with a son that was on 2 pressors, had undergone trach and PEG before, and was on dialysis, and barely keeping with dialysis. And we're still talking about full code, you know what I'm trying to say? And this is 101 years old. And then not to say about number doesn't mean anything. She could be 1 in 100 sharper than me and you sitting here, but the predisposing other comorbidities and baseline before she came to the hospital matters, right? But these are the things we're talking about. We can make the 6 weeks or 6 hours look much longer if we need to, right? So prognostication. Now, in palliative care, and I encourage all of you, if you had to remember anything from this lecture, besides some of the other things we talked about, we never talk again June 27, right? Like we said, and I don't think you either. So we prefer to speak whether intervals, minutes or hours, because you don't want the families who don't like you later on, like the patient, and come and sue you. Because they would say, doctor, but you told me that it wouldn't be surprising to you that, you know, patient has 3 hours. I've had a lot of colleagues in the ICU or some other levels of care, step-down units, where they would say, patient has like 4 hours. Guess what? Patient leaves 2 days. Then what happens? Patient comes back to me later, because I'm the palliative doctor who also obviously clearly expressed that we're talking about challenging situation, critical, likely we're in imminent progression of state. I never say 3 hours like the other guy, but I say hours or days. But then there's a conflicting information. Look, she proved all of you wrong. She lasted 3 days. So now they start doubting. And they really have a mistrust in what you said in the beginning. Then they said, okay, maybe I withdrew or withheld the treatments a little too early. So if she lasted 3 days, what if she lasted 3 weeks? Maybe you were all wrong in a whole other space. You know, there are people conflicted with grief and emotion, and they're all stages of going through the feelings, right? So I think it's very important not to either underscore or overscore. It's hard to find the balance, but if we kind of stick to more like days or weeks, weeks or months, they cannot quite say, because honestly, 7 days is 1 week, okay? I've had a patient that, you know, I'll never forget, this was the most surprised question for myself and my colleagues when I was on an inpatient hospice unit as a fellow. So the lady was with the squamous cell carcinoma. She was on a vent, tracheostomy done, and PEG. And then we brought her to the hospice unit with the anticipation that we'd have to take off the vent. She had an incarcerated son in like 5 states away who was brought by the convoy. We thought, honestly, at that point, okay, she was never getting already artificial nutrition, hydration. She was not getting any escalation of care. And honestly, we thought she had days. She lasted 3 weeks and exactly 2 days, because guess what? Me and you will never be able to explain this beyond our spiritual realm of understanding. As soon as the son arrived with the convoy from, I forgot that, Wyoming or something like that, 2 days later, she passed. So, I mean, none of us can explain how without any nutrients, how without, obviously she was bombarded with resources prior to disconnecting her from the ventilator. However, how did she last 3 weeks and 2 days and waited until he came for her closure? Beyond us, you know, obviously. So the surprise question to the majority of doctors would be, in general, even from the intake when you see them in the outpatient clinics or when you see the patients coming into triage at the hospital, right, when you do the admission, would you be surprised at the time of the presentation when you look at the patient if they had 6 months to 1 year life expectancy? With every information that you've gathered to that point, let's say 6 times in the hospital in 3 months, like they're already on the BiPAP dependent at night, nasal cannula 4 liters going at home, that same COPD guy, right, let's say coming to the hospital 20 times. So, I mean, this is where we're gearing towards, like, are we there yet, right, or are we not? And that's when I would just encourage you to consult early on, palliative care, and not because of the fear that we are there to enroll every single person's soul into hospice. We don't get any percentage if we do, believe me, by the hospital, or the funeral home for that matter. But because people do have that myth in the community that I'm in cahoots with them, you know. But I think there's never too early or too, quite honestly, there's late. There's never early to introduce certain things in terms of pain, symptom management, and optimizing certain conditions to have early on conversations on what matters the most, right? That sometimes is often avoided. And in summary, again, this is a lot of our own uncomfortabilities, of course, as human beings. I've had a patient also with the end-stage dementia, right? And if you know by Geriatric, let's say, Society, that we've done plenty of research and studies, in the final weeks of life, especially in very short months of life, we don't recommend to put feeding tubes in patients with dementia, right, end-stage progression. However, I had a patient's son, who himself is a doctor, in fact, and not geriatrician, but regardless. And he said, you know what? I blame myself with the experience with my father. I did not put, his words were, I did not put a feeding tube into my father, but I will do it to my mother. Who is that dementia end-stage patient? So is there a right, is there a wrong? What is the medium, where we stand? You know, this is always, we say this is not our story, right, to live. This is not our making to remember. You can only present them with the best options and stratifying the risks and benefits and analysis to the best of the timing that you have at hand. However, they are the ones, the caregivers, they're the ones they have to live with the story every night and day with their own family members. And if that's how they're gonna remember their experience, and if that's something, you just prepare them what the signs to look for if things start down the line, let's say exacerbating or worsening, and maybe that's not working, or in case you try to place it, right? But if that's something they chose and had to, with even the timing that you provided. But I always talk, you know, especially we have a lot of residents and students, we're so easy and eager to offer interventions, but like everything is about the timing. As we say in real estate, is about location, but everything we know we do in medicine is really time essence of it, right? So if we start antibiotics, 6 weeks of life for somebody with osteomyelitis, the real question we need to ask before we send that patient with a PEAK line to nursing home, does the patient have 6 weeks of life to complete them? Or at the baseline, what we're looking about before discharging the patient, maybe there's so many things happening that we already know. Let's be realistic. Patient gonna bounce back in 2 weeks to the hospital and likely gonna die in the hospital. Not gonna even make it to 6 weeks of seeing the effect of antibiotics to happen. So I think this is where we need to gauge not just our knowledge, but the actual skillful way to understand the bigger complexity, right? And, you know, this is like not the new, you know, coming to theaters again near you, you know, the infamous movie. But this is like, what are we scared of as physicians? It's like anything in life, you know. I've had the other physician tell me the other day, oh no, absolutely, I will not give morphine like 5 milligrams PO tablet. And I was like, okay, but if you went to dentist yourself and he gave you Percocet, would you take it for your tooth extraction? He's like, yeah. I said, but did you know that morphine and a Percocet was the equivalent, kind of like, not in, believe me, impunitive way, clearly, or sarcastic way, but it's like the same thing, you know, the fear of the opioids use. People forget, or the patients have the myth, the same thing, right, that Percocet is stronger than your oral morphine, 1.5 to ratio, right, to oral morphine, and we don't think about it automatically, but we pop up Percocet for like some knee issue, for the arthritis, for whatnot. But no, oh my God, morphine oral, no. Like, you know. So it's a similar with anything like that we approach. I mean, where is our own stated uncomfortability? Just not as the only provider, as a society, as of course members. And I think again, the judgments alone, it's hard because it's a lot of complexity goes into that, not just delivery information analysis, but prognosis discussions are intense, right? No matter what. And nobody wants to be on the side of that, like regret or delivering the bad news and the bad guy. And I'm often the bad cop, you play the good cop, you know. At the end of the day, we're all going to be on that side at some point. I think no matter how you deliver the news, the most sympathy, the most way of compassion, the most clarity. I think, you know, this is funny cartoon too. So she goes like, okay, when I die, should I be cremated or should I be buried? And she goes like, should we talk about something more pleasant? And he says, okay, so when you die, should you be cremated or should you be buried? So, I mean, inevitable conversations, clearly. But I always say, like, I'll never forget it. Just like that movie really struck me. I think I mentioned maybe at some point some other conversations I had. I don't know if you ever watched something called From Scratch. If you haven't, you should. It's about the guy with a really bad stage sarcoma on Netflix. There's a TV series called From Scratch. And very young guy, like in his late 30s, inevitably like incurable condition. And his wife is the biggest, you know, advocate for his health and go through a multitude of appointments, hospitalizations with him, and trying to get really to the sense of what should I really do? What's the best next step in approaching the care for my husband? Meanwhile, they have a child, they have all the chores, and you name it, like all of us together. And then she runs after this oncologist to the parking lot and basically taps her on the shoulder and is like, what does it take? Does it take me to run to the parking lot after you for some clarity? Because the oncologist has been avoiding to have the conversation that is really the elephant in the room. She's like, I am not afraid of him dying. I know my husband is dying. I just need to know so I can prepare our daughter, so I can prepare his maybe last trip to Italy to see his parents. I just need to know what to do. Right? And all of that takes the window of opportunity. Just like today, there's a patient, like I mentioned, with that MELD score of 36. We're trying to send him back to Mexico to die at home with his family. But in 5 days from now or 10, he might not have the vested opportunity to fly, as we all know, right? To be boarded. So we need to intervene. And meanwhile, patient has been, guess what? Today, they just asked me to come in and talk to the patient. And finally, we found the sister in Mexico to talk as a surrogate. And today she heard for the first time that he has weeks of life. Gastroenterologist, hepatologist saw the patient, right? Oncologist saw the patient. Nobody says to the sister he has weeks of life. He's been in the hospital, you want to guess how many days? 68. You're going to fall off the chair right now. They just consulted me literally today. I'm not joking, this morning. True story. So why do I have to come between that window that we can miss and try to push with my social worker to advocate for the patient, to try to fly him home, work with the council, work whatever? Why does it have to take that long? For someone to have that, right? It's not just a throughput, it's not just whatnot. It's hard conversations, but I really thank you for really being the biggest advocates for all of your patients and really come from your heart when it comes to the very difficult conversations, but also meaning that you would advocate for their fulfilling life choices like no one else, and I know that you all will, because this is the osteopathic way, clearly, and this is what we do in the most holistic way of sense, right? So thank you so much from my heart that you give me the opportunity to speak to you today. Thank you.
Thank you, Dr. Urbina. Thank you so much. Any question for Dr. Urbina? What's a senior assistant professor?
Yeah, so it's like one title before associate professor. kind of between assistant professor.
Because you're dealing with elderly, then they give you.
Yeah, I know. I hope to get my movie theater discounts with that.
How can you assist us emergency physicians in dealing with, we just met the family half hour ago, an hour ago, to discuss palliative care options when put in that predicament, but how would you assist us in
Yeah, I mean,
starting the conversation and getting palliative care early, as opposed to waiting 2-3 days when they get admitted and no one wants to call for palliative care?
yeah, I've had a lot of times with my own emergency department. We've sort of built the way of trust, but also empowering the physicians there. We know that they can initiate certain conversations early on themselves within, let's say, the first few hours of registration in the room. However, whether it's just prompting the family, what would matter to them most in terms of if you're worried about upgrading them to medical ICU or step down, whether you worry about taking them to intubation level, whether you worry even to go into BiPAP, whatever it is that worry, you have to escalate any level of care or de-escalate level of care. The role of palliative care, we always try to introduce that we're a supportive team, right? There's going to be another team meeting you that will sit down with you, and they're part of their competences, make sure they assist us to make very good observation, make sure you don't have any pain, you don't have any symptoms, control burden management, right? They oftentimes may guide you what to expect from, because it takes social worker, they have a chaplain, they have other spiritual leaders in the team, they have a doctor, nurse practitioner. So they do a comprehensive background of your situation, and they will work with you not only understanding what matters to you right now, but also as you come to the hospital, they'll have a continuity of care and following you on the floor. So you know that these people will start seeing you from the ED, let's say, right? For whatever it is. And let's say we have a challenging situation. Let's say you're really trying to figure out with them, should we really intubate? Should we really do BiPAP? Should we do whatever it is that you're thinking really to escalate? I don't know, oftentimes, right? And I think that would be a great asset to sit down with you and really see from different perspectives, multiple different specialty, right? Whether that's social piece, whether it's medical piece, whether that's your spiritual, maybe some challenges that I think we as physicians in emergency medicine may not be able to fully, to the best of our expertise, to time manage right now in the moment, but we really feel that you'll be in good hands to sit down with the team and really come down to like what matters to you. But also again, because people think, you know, if you mention the word palliative care, remember unofficially for a lot of patients in the community, it's synonymous with end of life by default, right? That's just how they perceive sometimes. So if you say these are the supportive care team that we have in the hospital that first of all will follow you and monitor your pain, symptom management as well, you can introduce us as that expertise. You don't have to say necessarily, because a lot of times we don't talk necessarily end of life right there, right? And we talk about certain directives and goals. And how can we assist you better to understand your risks and treatments? And they work together with us comprehensively to deliver the way that we can support you. So you don't feel like, because the transition of care will be smoother from ER, because I may not follow you upstairs, but this team will know you from beginning to the continuity in the hospital care, I guess.
I mean, you know, as a physician, but also, you know, family member, I mean, one of the things I did with my parents is have a discussion ahead of time. What did they want to look forward to in an end-of-life situation? So, and also to be able to then discuss that with my brothers so that we could be consistent in what was going. Because what I've seen a lot of situations is people, the family arguments, do everything, don't do everything, you know, get a DNR, don't get a DNR, how could you do that? Even, you know, I want a post-mortem, I want to see why she died. And I want a post-mortem, and it's just like, well, like that. So I had that conversation with my family. So that, you know, I know my mother wanted to be cremated, and they bought a mausoleum vault, you know, somebody talked them into that, you know, to do that. And then it came to my father, who had dementia and expressive aphasia. I had a discussion with him, you know, do you want to be in the vault with mom? That's okay. You know, they were together for
enough time.
yeah. And do you want to be buried? And I was like, no. I said, Dad, you're a veteran. Do you want to be buried in a military cemetery? Yeah. You know, that's what he wanted to. It was like all of a sudden he could express his wishes in that, because you know you're entitled to that.
Right.
And then the next question is, do you mind if mom's in the coffin too? And I was like, oh, okay. You know, it was like, but it was like to have these discussions with them, because they had proceeded downhill, but at least to be able to say, you know, do you want, we'll try to make sure you're comfortable, but to do everything.
Right.
Because I think I told you before, it was like we were given the feeding tube option, what is that going to do for them? It's just going to prolong their discomfort, not make anybody else comfortable, except if you say, oh, I did everything, or I did what I could. So I think that, you know, sometimes encouraging families to discuss, even though there may be weeks or months to go, saying, what would you all like? So at least when it comes down, you don't have to deal with two family members arguing, you know, yes, put in everything, and mom's going to survive this.
Right.
I've seen doctors make that mistake too. It's like, this person's going to walk out of the hospital. It's like, are we seeing the same patient?
Right.
You know, the person is a bihemispheric bleed into the head,
Right.
and that person's not going to walk out of here in any case.
Right. I think I hear you clearly. I think the most precious moment when you still have the integrity of capacity and really valuable insight of the patient themselves being able to vocalize their own preferences and wishes, right? No matter of which directives being discussed, because later on, like you said, the conflict and challenge between getting on the same page family members. Just like today, I had a patient who has been taking care of the mother by a daughter out of 6 children. And you know how they say, like, mother can take care of 6 children, but 6 children cannot take care of a mother, so that's really true. And what happened is she's a sole caregiver, she's the healthcare proxy, but she started crying and really venting to us and saying, listen, she's not getting off high flow for 7 days. I can see she's ready. She like almost signaling to me she's ready herself. But it's like my siblings, like you said, will never forgive me, and they will keep blaming me that I was the one who hands like offset, like, listen, I'm letting her go peacefully, right? So she has to live with those siblings. And then you have to empower to take the ownership for that person, the healthcare proxy, to say there's a reason why that person made you his healthcare proxy. Because they knew the other 5 children would do exactly what you just described, but you would know what's best in the interest of this patient, no matter how hard it is for you or anybody else, to execute to the best of her own wishes and compatibility of her own life quality, right? So I think it's very important what you're trying to say, but it's also our job to empower that particular family member that they can stand in their own truth and they can stand in their integrity, because for most, they own it to who? To that patient, right? To their mom. They will live with their siblings and they'll have to mediate. And they will have to somehow agree and live with that. But you know, this is what exactly like you're saying, we're seeing the conflict, and then unfortunately, like you said, if the earlier directives were not appointed or not vocalized, then you're missing that precious window when the burden of decisions, the heavy weight of it falls on all the conflicts later, yeah.
Any other questions, comments? Dr. Rubina, thank you
so much.
Yes.